It was the 20th of February 2020 when a patient on his 30s tested positive for a new coronavirus in Lombardy, in Italy. That was the beginning of the crisis outside Wuhan. With colleagues from Italy and ESICM, we decided to warn colleagues worldwide about the incoming crisis. A few days later, in March, the WHO declared COVID-19 a pandemic. And a few days later, ESICM united more than 130,000 healthcare professionals. Before we start, I would like to start by sending a warm message to all the doctors, nurses, and allied healthcare professionals, and all the researchers and scientists for their exceptional work in the last 15 months. The pandemic has shown the heart and strength of our ICUs to the outside world. To all the ICU teams who are still fighting to provide the best possible care for our patients, I would like to say our heart is with you. Unfortunately, the pandemic has closed the doors of many ICUs to families, and too many have lost their loved ones. Even if our words can do little, our thoughts go to them. We have done our best to be close to everyone in the ICU. We have often been a family for our patients. We have come a long way in the last year. We have especially learned that we can better face this crisis if we all stand united. With the help of citizens in the community and by collaborating and treasuring from each other's experience. In the first weeks of the crisis, much attention was on ventilators, drugs, beds. While these are important, a ventilator is not an ICU bed. First of all, an ICU bed is a group of skilled healthcare workers working together. It is essential to acknowledge the enormous amount of work done by our teams. We need to be aware of the fatigue and burnout now and help everyone getting back the right energy. It is impossible to have new specialist healthcare workers in just a few weeks or months. And finding skilled healthcare workers during a surge was also very difficult. The C19 Space program is a success story in this regard. With this program, we have trained more than 20,000 healthcare professionals not working regularly in intensive care. This is one of the most extensive training ever provided in an health emergency context. We wish to thank the European Commission for its support to the frontline healthcare workers across the European Union in such a crisis as the COVID-19 pandemic and all the stakeholders that made this initiative a reality. While during a surge, the deployment of non-ICU workers was critical, this is not a long-term solution. At ESICM, we are committed to shaping the future of intensive care in a way that can serve citizens and public health. We are working with institutions at national and international level to help to raise the awareness of investing more in intensive care for the coming years. We also believe that the free movement of intensivists will be a landmark development for the profession, giving recognition, flexibility, facilitating the exchange of best practices between the European countries that this critical field of medicine deserves. Research has been one of the pillars of the fight against COVID. From efforts like the recovery trial or REMAP-CAP to the development of vaccines, scientific research is what has allowed patients to be treated better after a year and what is showing us some light at the end of the tunnel. ESICM Unite COVID, it was a study that enrolled nearly 5,000 patients in the first wave. The majority of ICUs in Europe had to increase their surge capacity significantly. We are now extending the study to look at what happened in the last surge. We need your participation. Travel will be restricted for some time, and it's important that as a scientific society we ensure that everybody has the same opportunity to access the latest educational and scientific resources in intensive care. This is why we have decided to digitalize all the 2021 events. Now that the pandemic seems to be getting under control in some countries, we must not forget who is in a less privileged situation. A pandemic will end only when it ends everywhere in the world. We must do better as a scientific society and demand fair access to vaccines for everyone. We must do more for our colleagues. We must do better and give a stronger voice to low and middle income countries. And we must help them in the way that they ask. We are now working on educational programs also thanks to the ALIVE Fund. If you can, donate to the fund. It can help delivering education tailored to the needs of those countries. We must do better for our patients and families too. It is time to open more the doors of our ICUs and help families, ICU patients, ICU survivors to understand and live better the ICU experience and the post-ICU period. We must do better and let institutions know that critical illness and sepsis are here to stay even when the pandemic will finish. To do better, we need your support as a member of this global community. Indeed, the intensive care community has truly gone the extra mile in their daily practice, while also delivering research and education. We have been able to navigate this crisis by sticking to our values: diversity, respect, inclusiveness, vision, and excellence. These are the values also behind today's digital marathon, with the ultimate goal to improve patients' and family lives and experiences together. I hope that the next hours together will provide insights into improving our daily practice. And importantly, to remember that we're all going out of this crisis and building the future together. Let me thank all the speakers, our ESICM office, the technical teams, and our sponsors for making this marathon possible. And now, let's start. But before we start, let me welcome on stage a friend, the professor of intensive care at St. Louis Hospital in Paris, and the president-elect of the society, Elie Azoulay. Elie, how are you?
I'm wonderful.
Yeah, how are you doing today?
Very happy to be here and very excited about this second marathon on COVID from the European Society of Intensive Care Medicine.
I'm very excited, and we're going to have quite a few hours together, so I'm sure we will have time to exchange. Unfortunately, no face-to-face events again, but at least we managed to, as these events, to keep our community together. It's going to be an interactive marathon. You can interact with us on social media. You will see the hashtags. You can ask questions. We will have also social media moderation. So I'm sure it will be exciting, and I'm looking forward to learn from everyone. So without losing more time, I would like to introduce the first speaker. And before I mention her name, I would like to say she's from an organization that has put an enormous effort in guiding the world through this pandemic, which is the WHO. We've all been following these updates for the last 15 months, and I would like to thank the WHO for all the guidance in this year. So it's a great pleasure to welcome Dr. Anne Lindstrand. Dr. Lindstrand is a pediatrician and a specialist in public health and social medicine, and she works as a coordinator in the Department of Immunization and Biologicals at the WHO. Hello, Dr. Lindstrand, welcome.
Thank you.
It's a pleasure to have you with us, and thank you for all your work.
Yes, I'm actually truly humbled to be here in front of ICU professionals and researchers around the world. You have been the true heroes during this pandemic. I'm a pediatrician, but I have not been fighting the coronavirus pandemic as you have on the front lines, but actually in the WHO that I can say have changed quite a lot during the time of the pandemic, and the intensity of this work is extraordinary. Myself, I work in immunization, so my presentation will be focusing on the vaccine rollout, which is also what we hope is one of the key instruments for taking us out of this pandemic. The global situation, you know very well. More than 3 million deaths. You've seen them, you've taken care of them, and many, many cases. Somehow, almost like a 3-wave and different timing of waves in different parts of the world, and truly an unpredictable extent of this pandemic and what we've all had to live through during this past year and a half. To fight the pandemic, WHO was rightly, as you said, working a lot on the clinical guidance, trying to maintain and support keeping up essential health services alongside taking care of COVID pandemic patients. But at the same time, we endeavored into a very strong collaboration with Gavi, UNICEF, CEPI, and us in WHO to make use of some key tools that would help and will help in the pandemic. But those are, of course, the diagnostics, the therapeutics, and what I've been mainly involved in with the vaccines. And as you rightly said, the science has been absolutely extraordinary and delivered not just 1, 2, 3, but many very effective and safe vaccines that are already being rolled out in billions. So up to recently, there were about 1.5 billion doses that was administered in 210 countries, areas, territories, and economies. And you see the map here. The darker it is, the higher the number of doses administered per 100 population. And of course, the collaboration between CEPI, Gavi, UNICEF, and WHO, and many other partners helping in is COVAX facility. So COVAX, where we try to make this map look more green, and not this heterogenic with gray patches and countries lagging behind. So in the February, there were the first rollout of the vaccines coming out from the COVAX facility. And we were extremely, extremely happy because in the initial days of the rollout, you know very well that it was just a very few countries and high-income countries that took advantage and had the possibility to vaccinate their populations. And the world looked like this today. The COVAX has shipped about 69 million doses to 125 of participants around the world. The yellow parts are all the countries where COVAX doses have been available. And the blue one are economies that are vaccinating either by bilateral doses or by donations. The COVAX countries are also making bilateral deals and getting shipments and donations. But just to say that COVAX at least helped 37 participants to start their initial campaigns thanks to these COVAX doses. But what does it look like really? Is it an equitable distribution? Well, not at all. 10 countries have administered 76 of all doses, and you can see the high-ranking countries, out of which China is the highest one. And the bubbles in the middle here is doses per 100 population. So you can see that the United States, the United Kingdom are on top when it comes to the delivery coverage across populations. 28% of the doses have been administered in one sole country, in China. And we are worried at WHO that this race towards me in the vaccine race is not serving the purposes of the COVID, of us collectively stopping the pandemic. Here you see there are only 10 countries across the world that has not still started to vaccinate, and you can see the countries down on the left, majority of those in Afro or in Western Pacific region. But they are moving by the hour, you can say. So this has been the fastest introduction of any vaccine in the world so far, arriving to almost 95% of member states in a matter of few months. That is an extraordinary accomplishment by immunization programs worldwide. As I said, we're not happy. If you look at from December in 2020 to now in May 2021, the distribution between blue, high-income countries, orange, or whatever that color is, upper middle-income countries, yellow, lower middle-income countries, and then the gray ones are the populations in low-income countries. There is an extraordinary inequity still. However, the picture is increasing. It's getting better. So only 0.3% of the global doses so far have been distributed in low-income countries, which actually make up 8.8% of the population. And 16.5% of the doses have been administered in low and low middle-income countries, even if they represent about half of the world population. So we have a long, long way to go where issues of vaccine donations are hot. And there are more and more commitments coming through to COVAX of being able to share doses and deliver to everyone and the target populations in every country that needs protection. So again, a timeline from December to May. In February, March, it was a 10,000 gap between the number of administered doses in high income versus low income countries. But as you can see across the time here, that picture has substantially increased. In another way to see it, you have by income groups, high income, upper middle income, low income, and lower middle income country and lower income countries, and the populations here. It's really an inequitable distribution. And in the low and low middle income countries, it's only Mongolia and Bhutan who has been able to reach those critical 20%, which we in WHO were hoping and recommending all countries around the world to distribute the doses to first. And you know that very well, you yourself, healthcare workers, medical risk groups, and the elderly. So what are we facing in support of COVID vaccine rollout? Well, we are facing a lot of different issues at the moment in supporting countries across the world to make use of the doses that come along. Some issues there are on vaccine uptake, so vaccine hesitancy, even healthcare workers questioning and not understanding the true value of these vaccines, the supply constraints of the second dose. So we have guidelines saying you have to have a recommended dose interval, but then when the shipments never turn up on the doorstep for the second dose, what do countries do? Well, they extend the time between the doses, which is not bad immunologically, but is not within the recommended time schedules. Safety, we're worried about low reporting because we do want all countries to report their safety signals into the global database. And costing and financing is a major bottleneck. Many countries now, in low-income countries, they may have had the vaccines, but they have insufficient operational cost, logistics, paying the healthcare workers, etc., to reach out and get the doses going. Which we're trying to work with the World Bank, UNICEF, Gavi, and many others that help everything they can to get this problem out of the way. It is also an extremely complex work with multiple vaccines and products in each country. Actually, the majority of countries not only vaccinate with one type of vaccine, but many different. So the administration, the timing, and the cold chain requirement, etc., are enormous. And then what we also worry about in WHO is the effect of this massive rollout, the costs that it will take, the HR it will take, the staff, health staff to do it, that will be pulled out from routine immunization. And what will this do to vaccines that itself? Initial effectiveness studies are very, very promising and leaning towards very much supporting the results in the clinical trials. Here is just an ecologic study where you actually see that the age cohorts have switched in the last wave in Germany so that the elderly populations no longer are on top and the most at risk of being the COVID cases. And here you see another ecologic study with data that was sent to WHO from Germany, Greece. This is majorly this is European countries. And so the first row is the first dose, and the second dose, how fast the proportion of the 70-year or the patients above 75 are among the COVID-19 deaths. So a sharp drop in many of these vaccinated countries, which have been vaccinated at a higher rate than the low-income countries. So let me just turn to a worry that we have about disruptions of other vaccines. So on the x-axis, on the graph on the left, you have different countries, and then you have percentage of essential services being disrupted. And it's a number of 63 different services, including the vaccination. And the global average is a decrease with 38% of different services being disrupted due to COVID for different reasons. Lockdowns, healthcare workers being dragged away, socioeconomic problems, fear of transmission in healthcare settings, many reasons for this. And on the right-hand side, you can also see the disruptions in immunization by regions, which is also very much of a worry, not the least for measles, which we are afraid will come and hit us in the neck while we're rolling out the COVID-19 vaccines. And why do we say so? Well, in early on, WHO have been assessing ever since the different campaigns of vaccine preventable diseases that was postponed or canceled due to the pandemic. So on the left, you have the situation in May 2020, and now we are in May 2021, which is a lot of countries have now taken up their vaccination campaigns, particularly polio. Measles is still lagging behind, and 49 countries are still having postponed campaigns against mainly measles, which is why we were very much worried that there will be an upsurge in the measles cases, and you know very well what that could mean. Let me just stop and look back a little bit at the general role of WHO. As I said right in the beginning of my talk, WHO has massively changed during these last year and a half. Everyone has almost dropped what they had to be able to respond to the pandemic in whatever possibility capacity they had, and being part of either monitor and learn, collecting evidence, coordinating panels across the world. You may have been contributing to those, and then writing implementation guidance. And you know them very well. Here is just a collection for you to look at a little bit later in your area of therapeutics and pharmacological treatments of COVID-19 COVID-19 patients. But also in COVID-19 vaccine delivery, we've been incredibly active, both in trainings across the world, but also the delivery of enormous amounts of guidance and trainings to help support this never ever seen ramp up of an introduction in almost all countries across the world in just a few months. So thank you very much, and happy to take any questions.
Thank you very much, Dr. Lindström, for your contribution. I would invite you to stay with us because we're going to ask the questions at the end with the debate. And I'm going to ask my co-host, Ellie, to introduce the next speaker.
Thank you, Maurizio, and thank you for this excellent presentation. And I'm very, very happy to invite Professor Manu Shankar from King's College in London. Manu is a gifted, a talented colleague, and he's Professor of Critical Care. And his presentation on science to fight the pandemic of COVID-19 is going to be an amazing one. Thank you, Dr. and Professor Shankar.
Good afternoon, and thank you, Ellie and Maurizio, for this opportunity to share some of my thoughts and the invitation to join. It's an honor to be here. For the next 10 to 12 minutes, I'll try and have a brief run through the science of the pandemic. Starting with my acknowledgements and disclaimers, my research is funded through an NIHR Clinician Scientist Award in the UK. So these are my views, not necessarily of the NHS, the NIHR, or the Department of Health and Social Care. I do not have any financial conflicts of interest. I do note that I am an associate editor in ICM, and I will touch on some of these slides, the journal ICM's contribution to the pandemic. To kind of frame the discussion, I thought let's go back to 2019. Let's try and understand how the science, especially the critical care academic space was. So healthcare in 2019, we all knew in our hearts when we read this front cover of Time magazine that actually we are not prepared for a pandemic should it were to happen. And I think the warning signs were all there. And I think Professor Ciccone in his introduction highlighted some of the challenges that we faced early on in the pandemic. When we think about the science in the 2010s to 2019 leading up to the pandemic, there are tremendous progress, but we all know that there is tremendous research waste. Roughly 80 to 90 billion pounds or dollars is wasted research. 85% of the research is wasted research. I'll come on to that in the next slide. This is a lovely summary slide from Ian Chalmers, which was a Lancet coordinated activity of trying to reduce research waste and increase value. And you can be any scientist or a clinician looking at it, and you could broadly see research into 4 quadrants. Research waste, which is essentially giving random drugs to a small number of people and say that it works, not in a randomized control trial, but outside of it. And then there are scientists amongst us who do fundamental discovery science. Their primary goal is to advance knowledge. Then we got absolutely wonderful phase 3 trialists where they have an idea that is generated from the basic research or from an early phase trial, and they go on to do the trials to change the way we look after patients. And that is the relevant to immediate clinical care. And then you have these in-betweeners who do, like myself included, where we do kind of combination of early phase clinical trials and observational cohort studies and immunology and mechanisms to try and understand actually what do we actually bring to the table where we can take some fundamental discovery science to the bedside. So that's a kind of the space of research. And I think there was tremendous research waste in critical care. I think we can't shy away from that fact, and there is still a lot of that going on. So let's kind of, with that sort of introduction, let's get into the meat of the discussion, which is how did science help? And that's what I've been asked to talk about. And I want to kind of take us back to SARS-CoV-1 or the SARS outbreak in 2002. Each of those lines represent roughly a month. The first patient was highlighted in Foshan in China in 2002 November. And as you can see, roughly it took around 6 months or so before the first genetic sequence became available. Let's kind of compare that to SARS-CoV-2, which is the coronavirus outbreak in 2019 in Wuhan, the first patient. And actually, if you look at it, the first genetic sequence was identified less than 45 days from the time we had this virus discovered. And then WHO, as you heard earlier, swiftly highlighted this as a public health emergency of concern, and then pandemic later on. And we also kind of, when you compare these two things, there must be something going on in the scientific space that led us all to happen quickly. And one of the key things, I just put one journal group's editorial where they explicitly stated the value of open science, team science, and accelerated peer review to try and get the best possible evidence to clinicians and scientists. So what I thought I would do is in the next 10 minutes or so, or less than that, to try and pose a question and try and say how we were in 2020 and how we are in 2021. I thought I'll pick some simple examples. How did we reduce transmission? how did we understand the disease? How do we treat now? And a bit about vaccines. And then we're starting to kind of probably have to figure out what is this long COVID condition, how we're going to manage them. So as an example of how did we reduce transmission, this was not new science. We knew this. This is an example of a paper from the journal Science in 2003, modeling the etiological agent SARS-1 and ways in which we can prevent SARS-1. And a lot of those principles are true for SARS-CoV-2. And there are similar papers looking at flu and the H1N1 flu. The basic premise of all this came down to a very simple modeling exercise. This is an example from Imperial College London. If you look at the x-axis, you got the time, February, March, April, May, and y-axis is the time varying reproduction number. So the idea here is if you were to add one or more sequential steps to the isolation or reduction of the transmission, you can see that there is a progressive improvement in transmission with the maximum benefit when you do what we now term flippantly as a complete lockdown, where you ban public events, essential activity, no shops, no bars, pubs, clubs, that sort of thing. And you're essentially now down to bare minimum. And that tremendously changed the progression of the pandemic and overwhelming of the healthcare system. We were fortunate in the UK to have learned from the Italian lessons very early on, and that helped us probably to kind of get to this lockdown stage quickly. And let's think about what happened, what we know about biology and the disease a year on. We know now that there is a clear entry mechanism of the SARS-CoV-2 virus into the cell. And once inside the cell, it is directly cytotoxic to the cell. It disrupts a number of biological pathways, and I've just highlighted some examples from this lovely summary work. It's a review article in Nature Medicine. I've just highlighted that. And I think a lot of us who work in the critical care space are particularly taken by the latter two, which is the endothelial cell damage and the thromboinflammation, and then the dysregulated immune responses that cause tremendous kind of systemic manifestations that we see in these patients. And we were fortunate to kind of highlight some of the challenges. There are some superb other immunological papers in the literature. I'm just using mine as an example, where we show that there is raised IL-6, IP-10, and IL-10, which kind of forms a triad of signatures that highlight a higher risk population. We show that there is significant alteration in the T cell compartment, and you can therapeutically target that. And if you were to kind of think about the disease progression idea that people have considered in COVID-19, we know that there are more asymptomatic or mild infections compared to more severe and those requiring hospitalization. And therefore, some of the early manifestations are like that of an upper respiratory tract infection. When the disease gets hold, which is somewhere between 7 and 10 days of symptom onset, you have pulmonary manifestations and systemic manifestations of the disease, resulting in hospitalization in a proportion of patients. And I think the prevention hypothesis needed to focus on the pre-symptomatic or early symptomatic phases. And I'll come on to what we do in early and late phases of the disease in the next few slides. And although we talked about, like Professor Ciccone highlighted the mechanical ventilation story, followed by the fact that actually it is a multi-system disease, and we cannot just have ventilation as the sole investment when we think about managing these patients. And we need the whole multidisciplinary team to look after these patients, given the wide multi-system manifestations of this condition. That brings us nicely into how to treat. Now here, I'm just going to have a philosophical discussion for a minute. So most of us did not know how to treat this condition because it was a new disease, relatively new virus. We understood some of the basic principles of immunology, but we didn't know. So as clinicians, we are making decisions with tremendous uncertainty. And I think we have to then keep this principle in mind, that actually we are trying to explore in the context of insufficient knowledge. And we just need to somehow understand what's going on and then change the way we look after patients. And actually, if you don't do that, if you don't continuously follow the train of thought and the new knowledge that comes out, you are not going to make patients better. And early on in the pandemic, instead of actually embracing this uncertainty, people started throwing terms like cytokine storm and all sorts of other things. I mean, none of those help bedside management. They just give you airtime to talk about, hey, I can talk about this in a different way to you. But actually, what we are doing early on in the pandemic is making clinical decisions with tremendous uncertainty. So what were this uncertainty? So you have antivirals, immunomodulators, anticoagulants, you have mild disease, moderate disease, and severe disease. How do you actually treat each of those groups of patients? Which of those treatments that you have works best? None, we don't know. And that we didn't know. And I think that's where the uncertainty kind of comes in. And therefore, the decision-making and the learning has to go simultaneously. And as an example here, and I think the critical care probably got into the act early on with the REMAP-CAP platform, and actually recovery platform trial, which is very different to the REMAP-CAP in that it's a frequentist design, the other is a Bayesian design. And they both started to look at multiple treatments at the same time, evaluating them simultaneously at scale with minimal data collection. So became very clearly a phase 3-4 pragmatic trial designs. And we started testing a number of things. And Mauricio wanted to kind of me to highlight this particular point. UK was set up for dealing with this because we had the NIHR and the clinical research networks. If you think about clinical research network in the UK, it had roughly 6,000 studies before the pandemic. The moment the pandemic hit and the NIHR realized that this needs to change, we brought that 6,000 down to some of the key urgent public health portfolio studies. And to date, we have recruited more than 1 million participants. And I think it's a tremendous effort, and big thank you to the healthcare workers and the patients who participate in these trials to change the way we look after these patients. And I just wanted to highlight the REMAP-CAP and the recovery platforms because they have done tremendous contributions amongst other number of other trials. The coronavirus, the first breakthrough came out in June 2020. The last few slides, I want to just bring in the rapid recommendations and the drug treatments. I'm just going to use the WHO living guideline that informs most of our care. That should inform most of our care. I am a contributor to this guideline. That's my only conflicts of interest. So the population of patients, the current recommendations are that we don't give ivermectin. We have learned a lesson with the hydroxychloroquine behavior. We don't give antivirals, aside from probably remdesivir, where there is probable weak benefit in reducing the duration of illness. Corticosteroids, one of the first drugs that came out, where we gave a potentially strong recommendation. And the Living Network meta-analysis is an interactive field, so please go and look at them, and you can try and understand how the drugs interact compared to standard care through to no difference and uncertainty, and how we could pick up benefit. And this cartoon on the left essentially highlights the benefit of corticosteroids as an example. And I think my previous speaker has done a tremendous job highlighting the vaccine lack of equity in access and both the quality. And I'm going to just put the success story spin on it and just highlighting that actually year on we have an array of vaccines. Some of them have been past the phase 3 trial and been accepted into routine kind of healthcare use. We've got inactivated virus, viral vector vaccine, nucleic acid vaccine, and protein-based vaccine. So we are in a much better place, thank God to science, to get to the stage where we are thinking about coming out of thinking about what will look like when you get out of the pandemic. And I highlighted this earlier on the post-COVID condition. As I was making this talk yesterday, there was a paper that came out in the BMJ about the clinical sequelae that some of these patients face, and it looks like a tremendous list that is common to sepsis, common to critical illness, common to many of the hospitalizations. So hopefully we will learn some of the lessons, use some of the lessons learned rather than starting afresh. As I said, I am an ICM editor. I wouldn't have finished the talk without talking about intensive care medicine. And I think intensive care medicine has done a tremendous job whilst in this pandemic. There is no way that critical care community would not have responded the way we have. And I think thanks to many of the editors and the reviewers who help us along. And we have a coronavirus collection. And I think I was particularly taken by the quote from the editor-in-chief, Giuseppe Citterio. We have essentially had 3,200 submissions, which is kind of an increase by 75%. And yet we managed to kind of still keep our high standards and turn things around. You have an ICM session later on. I just want to bring two particular examples because they kind of highlight the challenges that clinicians face. And this is the paper on the left is the paper from the CoVAPID study group, which highlights the increased risk of ventilator-associated respiratory tract infections in patients with COVID-19. And the one on the right is a much more kind of longer-term problems that we will have when patients who recover from COVID-19 leaves hospital, and critical care follow-up clinics will start to become a relevant thing in the future. And I think Professor Ciccone highlighted this point, which is Unite COVID. And I think ESICM has been a tremendous unifying force during this crisis for the pandemic, especially in the digital environment of learning and education and dissemination. And I think Unite COVID is a fantastic example of such a study. So I think in summary, we have done a tremendous job as a scientist to contribute to this. And there is much to do. There is no time to rest, but we are at a better place than before. I will leave you with that summary slide, and happy to be contacted via email or other means. Thank you so much for the opportunity and the invitation.
Thank you very much, Manu, and thank you both really for two wonderful presentations for our opening. So we're opening the debate now to both Dr. Manu Shankar and also to Dr. Lindstrand. And I am taking some very important messages from your talks. One is that we really lived an unprecedented time of discovery and research, but I think too often we talk about the last 12 months, and I think this has been made possible really from what you say, from the previous 20, 30 years of research. And the implementation science behind this also, being able to have the results and to implement this is also being unprecedented. But I was very touched, and it's something that is very important for us. What Dr. Lindstrand was saying is that there is clearly no equality now in the distribution of vaccines, and it's very, very important that we try to address that. We are in a strange situation in intensive care because we really are the last line of defense in this. But we feel as a scientific society that we have the duty to pass this message. So I'm going to ask really Dr. Lindstrand first, what can we do as a society, as a society of intensive care doctors to help spread this message, which we think is very important. Also because, as you clearly said, the pandemic will end well, it end everywhere, not just in high-income countries.
Well, we should recognize that any political leader at this time has very high pressure to deliver vaccines for their populations. I think we should all together, both as citizens and medical doctors and the politicians themselves, recognize that we will not be safe. We will not be able to stop this pandemic, which is a key care for all of us, unless everyone is safe. And so what people can do, easy. what we need to do is share the doses, the excess doses, and make sure that before we start to vaccinate young, healthy teenagers in high-income countries, that we care about healthcare workers at the front line in low-income countries. So a swift shift into the sharing of doses. The second piece, I think, is investment in manufacturing sites across the world to make us into a better site and place for this pandemic, but also beyond, where production has been one of the, when science have been so successful, it's one of the bottlenecks is the manufacturing capacity. So I think that is also a key, getting together, having pooled funding and decision-making. And there was an excellent report by an independent panel reviewing the pandemic response, which I encourage everyone to read actually, which really said that the world has to prepare for the next pandemic right now. And that takes global collaboration. It takes a lot of funding. It takes us thinking about global health security now. It is also about investment in manufacturing and again in basic science and research.
We completely endorse this, and thank you for sending very clear messages. I think, Ellie, you want to ask a question to Manu, maybe?
Yeah, maybe to Manu and maybe also to Dr. Lindstrand. I really appreciated your lectures. Dr. Lindstrand, we as ICU specialists, we are, I would say, used to evaluate patients based on their physiological reserve. And I liked you very nicely and elegantly pointed out that countries have also a healthcare that has a kind of reserve, and this reserve varies across countries, and then that would be also associated with outcomes. So what is the next step from your perspective, and how do you think that we should align countries' reserves across the world to get more into health equality in the future?
Well, I think what we need to do is being very, very mindful of the socioeconomic damage the pandemic has left us with. So countries lacking the resources and also very stretched healthcare worker pool across the whole world, right? But seeing that as a constraint, it's also an opportunity. I can see that unusual, actors are now investing and investing large amounts of money into stronger healthcare systems. And taking that opportunity to fight the pandemic and roll out the COVID-19 vaccine, and at the same time build for the future. So build better safety monitoring systems, for example, building better logistics systems and cold chain requirements, building better monitoring and digital tools for following the vaccines to the last patient. That can also serve for so many other reasons. We need to be effective with the resources we have left after this pandemic and be mindful of the next step and use those resources we have effectively for building better systems for the future.
Thank you very much. And Manu, maybe a very short question. And again, thank you. I really appreciated the way you not only brought the science to the evidence, but also, did a lot of reference to the ESICM journal, Intensive Care Medicine. Manu, I have a question. It is very surprising that the same people who were frontline caring for the patients also were really frontline for clinical translational and experimental research. So this is very appealing for the young generations. So please send a message to our young colleagues to tell them more about what we do on a real basis.
So, well, Ellie, you've asked a difficult question. So I can just say what I do. Half of my time is spent doing research and half the time is spent doing clinical medicine. I take my ideas and the inspiration from looking after patients and try and see what I can do within the research I do to make a contribution that will make them better. Science is not an easy task. It is a full-time job. It is, you essentially do more work, but it's much more rewarding when you see some of what you do make it through to the bedside. So to my younger colleagues, I think it's a fun thing to do. It will help you interact with people. And in fact, my interaction with Professor Asale started off as discussing science at an European Society meeting. So it's a fabulous place to be. And I grew up in India, a kind of a little town, and I came to the UK. And here I am sitting in front of you and talking about science, which is great. So go and discover your passion. It'll be there.
Thank you very much, Manu.
Manu, Eli, I think we have a question or some question from social media. I see Twitter is buzzing. I'm checking on my phone. So we have Jamie Strachan, who is a consultant in anesthesia and intensive care, a long acquaintance of our society. He's based in Milton Keynes University Hospital in the UK. If Jamie is available. Hi, Jamie, how are you?
Hi, how's it going? I'm well.
Nice to see you.
And you? Yeah, Twitter is buzzing with the global translation of knowledge from the European Society. So well done. So just one question, really, I suppose mainly for Manu, but perhaps useful for Anne as well. How do we walk the tightrope between needing to act quickly in a pandemic and then being patient while waiting for therapies with definitive evidence?
And do you want to go first, and I can follow suit?
Yeah, that has been so key, because the early steps of the pandemic was really working in the dark, right? There was very little knowledge, and we needed to know quickly. So I think it's with the same way that we do research otherwise. We take mini steps, we take stock, we take the next step, right? And I know that this has been from the WHO side managed in a way that WHO is really not working in a silo. The connections, the collective thinking across the globe has just been magnificent in this pandemic, with research collaboration, sharing of data, and doing that more real time than probably has ever done before. I don't know if you agree, Manu, but and then taking us out from that dark cloud a little bit faster then.
Absolutely, I totally agree with you, Anne. I think, Jamie, the reason why I think I feel strongly about trials in this context is that if you think about corticosteroids and a viral illness, when we got into the pandemic, there was debate, right? I mean, there was debate and arguments that corticosteroids are going to kill you because you're going to give it to a viral infection. The viral infection will go out of control and you're not going to make it. And hey, presto, we see an RCT which highlights benefit. And then if it is one RCT, you could say, okay, it's a chance. But actually, it's consistently, multiple RCTs highlight the same point, that actually, overall, there is benefit with corticosteroids. And in fact, the recovery trial is a absolutely stellar example, and so is Solidarity, for that matter, for bringing in things that are what we would call as repurposed drugs. Because if you think about, sitting in the UK with an NIHR backing us to the hilt to deliver science is easier than globally, where there is significant inequity to access to healthcare, let alone getting into a hospital, seeing somebody. And then, in that context, to deliver a repurposed drug trial is really, really important. And there is no way that everybody in the world will get tocilizumab or whatever else unless we have consistent benefit. And the other thing we forget in this context is the cost of these drugs. Dexamethasone is free, no patent, available globally, easy to administer. You can give tablets, IV, etc. Some of the other drugs, it's not that easy. Anne talked about the cold chain and vaccines. I mean, there are substantial implications globally, and I think to me it feels like this was one of those pandemics where everybody had, the ESICM group had worked up the pandemic preparation kind of document, and it was essentially on ice, and then it just had to go. WHO had Solidarity set up rapidly, recovery set up. If you look at the article from an interview from Martin Landray, Martin highlighted that actually the idea was February, the first patient was March. So we can do this. If we can do this safely, there is methodological expertise, and there is system expertise to do this. We just need to be accepting of the fact that we don't know, and therefore best thing to do is to do a clinical trial rather than random things.
That's great. Thank you. Jamie, do you have another question? We have very little time, but if you have a burning question, no? Okay, I think it's time to wrap up, really. It's been a fantastic opening session. So I really would like to thank the two speakers, Dr. Lindstrom, Dr. Shankar. It's been really fantastic and some so important messages. And if I can wrap up with one important message, is what Dr. Lindstrom says, really, do not work in silos. Research network, clinical networks really are what made the difference. In a very strange year where we could not meet in person, we used technology to stick together. And I think this has facilitated the speed of research and implementation, and we do not have to forget this for the future. So thank you very much.
Thank you.
Thank you.
Thank you.
Well, we cannot have a session on COVID-19, a marathon on COVID-19, without a session on respiratory failure. And it's a great pleasure to introduce the moderator for this session, Professor Nicole Uferman. Nicole, she is a staff member at the Department of Intensive Care Medicine at the Onze Lieve Vrije Gasthuis in Amsterdam, and a co-chair of the Laboratory of Experimental Intensive Care Anesthesiology of the Amsterdam University Medical Center. But I have to say, I'm very proud to say that on top of that, Nicole is the editor-in-chief of ICM Experimental. She is a very talented researcher and doctor. We're very happy she's leading this experimental journal of the society now. And so, Nicole, please welcome on stage.
Wow, Mauricio, thanks very much for that very kind introduction.
How are you, Nicole?
So, sorry?
How are you doing? It's great to see you.
Oh, yeah, I'm doing excellent. Yeah, I'm doing very fine. Thanks. Yeah.
Okay, we look forward to hearing this session with you. Please go ahead.
Okay. So hello, everybody. A warm welcome to this session on the management of respiratory failure of COVID-19. This is obviously a very important session. And therefore, I'm very happy that we have three excellent speakers. They each will have 15 minutes of talk, and then afterwards we have a Q&A session. So if you have any questions, please submit them via all the media that are there present for you, and I will collate them, and we have a discussion at the end of the three lectures. So let me now introduce the first speaker, which is Dr. Luigi Camporota. He's an intensivist at Guy's and St. Thomas's Hospital, and also senior lecturer at the King's College in London Hospital. He's an associate editor of the National Intensive Care Society of the UK, and his research interests are airway and lung biology. Dr. Camporota, please.
Thank you very much, Nicole. And thank you very much, Nicole, and thanks everyone. Thanks Maurizio and Ellie for allowing me to be here today. And it's a real pleasure. And also I'm very grateful to the ESICM for such an event today covering all the aspects of COVID-19. But my brief is to talk about pathophysiology of COVID-19 lung injury. So, but let me start just by reviewing for 1 second, so the traditional model of ARDS. You can see that often we see that there is a known insult, a primary insult that leads to an increased lung permeability with lung edema. The lung weight increases, the lung collapses under its own weight, creating atelectasis. And that generates a very small ventilatable lung, so a decrease in FRC. And that, with ventilation, increases dynamic strain, which leads to amplification of forces. And that, in the classical model, is the second hit, which is the ventilator-induced lung injury. You can see this is a vicious cycle. That's why this is the basis for low tidal volume ventilation, which is the small ventilatable lung, and also PEEP and recruitment maneuvers, which Liz will talk about this much more in the next few talks. But when we look at the severity of disease, you can see that this amount of extravascular lung water increases with severity, to the point that with increase with a decrease in PF ratio, there is an increase, parallel increase in non-aerated lung tissue. Now, why am I saying this? Because what we've learned with COVID-19 is that COVID-19 seems to be more complicated. So in a way, there are alterations of the angiotensin II metabolism and vascular inflammation that causes a hypoxemia. And the hypoxemia seems to be a combination of various elements. On one side, on your left-hand side, there is a dysregulation of pulmonary perfusion, which could be some of it is functional, so abolition of hypoxic vasoconstriction, but some of it is structural. So there is a neoangiogenesis, there are vascular abnormalities and perfusion defects, even in the absence of overt thrombosis. And on the other side, there is the proper immunothrombosis, which obviously plays a role, and Beverly Hunt will talk about this later on today. And on the other side, there is the proper sort of lung edema, the consolidation that here I call more ARDS-like, at least in the traditional sense. So if we talk about the first group first, we can see that clearly there is an increase prevalence of major pulmonary emboli, particularly we have noticed that worldwide. And also this is the work of Max Ackerman in the New England Journal, say that essentially there is a distinctive angiocentric disease, COVID-19, with severe endothelial injury, a thrombosis that is 9 times greater than H1N1 ARDS, and also significant new vessel growth, the neoangiogenesis, which is almost 3 times greater than ARDS. But what you can see at the bottom is very interesting, that some of the features increase with time. So the natural history of disease is very important, and the timing of observation is very important and remains important, I think, for the rest of my talk, and I'm sure for the treatment has got quite an important relevance. So if we stay with the vascular thing, the anomalies, we can see some initial reports where there was, in the face of a preserved lung volume, there was vascular dilation. And that vascular dilation evolved, almost predated what then was a new pulmonary consolidation. And obviously this leads to increased shunt fraction. You can see this is work from Brij Patel and Sujal Desai from the Brompton. You can see that dual energy CT scan basically shows anomalies in 63% of the patients. And they've described this characteristic tree and bud. I'll show you later on what it is. Essentially, it looks like that, exactly, a tree and bud, where there is a vascular abnormalities and dilatation peripheral to the lung, and that leads to perfusion abnormalities. But also, if you look at that sort of violin plot on the right-hand side at the bottom, you can see that these anomalies, again, they're time dependent. So they're much more prevalent later on in the hospitalization and later on in the when the duration of ventilation is greater than a week, let's say. So there is that anomaly of ventilation associated with anatomical abnormalities of the vasculature. More data, obviously this is from Giacomo Grasselli. You can see that there is quite a lot of hyperperfusion in some areas of the lung, and others have described the same thing, so altered perfusion within an area of the lung that is heterogeneous, but largely with preserved lung volume. This is an interesting one, just illustrates quite nicely, I think. You can see two things. One, the lung volume is again relatively preserved, but what you can see is severe hyperperfusion in the area of the lung that is relatively healthy, or at least aerated. And so there are some other areas where there is increased perfusion in areas of ground glass. Now that is the basis of some increased dead space that we see in COVID-19, increased shunt fraction that contributes to the hypoxemia. But this particular pattern has been associated with increased admission to ICU with a hazard ratio of almost 12 and increased risk of invasive mechanical ventilation. Again, when you see the dual energy CT scan, you can see that the perfusion defects were seen in 100% of the patients, and about 46% of the lung was involved. Now, it's possible to look at some morphological aspects. You can see some of the video that I just played. It shows the mottled disease. So you can see some perfusion that is mottling around the periphery of the lung. Seems to be the most frequent, about 50% of the cases. There is a mixed component, and then there's a more traditional wedge-shaped perfusion defect that was present in 16% of the patients. Now, this is a case report. It's obviously not a large study, but it's quite interesting illustration. So what you can see is a computed tomography CT scan, a glucose metabolism PET CT scan, and a SPECT CT scan on the right-hand side. And I think, again, what you can see is two things. So if you look at the bottom where the D panel is, you can see the lung volume is about 1.2 liters. But what you can also see is that the majority of the lung perfusion, as you can see in the SPECT, is collocated with the area of greater inflammation. So much so that about 60% of the lung perfusion happens in the inflamed lung tissue, and only 41% of the lung perfusion goes into the normal lung. Then the authors just basically point towards the hypoxic-based vasoconstriction being lost in that particular patient. So I think it's interesting, again, illustration of the pathophysiological mechanism of this mainly angiocentric vascular COVID-19. Now, if we move to the other side, where we look at the consolidation and the edema, when we go back to the ARDS task force, the Berlin definition in JAMA in 2012, what we could see is that there is an increase or a parallel increase in the shunt fraction as the lung weight goes up, or the other way around. Whereas you can, so essentially the two go hand in hand. Whereas on the right-hand side, again, data from post-mortem from Maximilian Ackermann, it shows one thing, that when you look at H1N1, the lungs of H1N1 are much heavier, 2.4 kilos, compared to 1.6 kilo in the COVID-19, which is clearly higher than normal, but not as much as the H1N1. So it's quite interesting to look at these differences. And then this is from the Amato group, from RESC. You can see that there is a log normal relationship between the anatomical CT scan shunt fraction and the PF ratio, so much so that for each level of PF ratio, one could predict the CT scan shunt fraction. Now, that doesn't seem to be very much the case sometimes in COVID-19, because the lung volume seems to be greater, and therefore the compliance more preserved compared to patients with other etiology for the same PF ratio. And again, this is a CT scan study that shows how the lung volume for each section of the lung going from the sternum to the vertebrae is clearly higher. You can see that's in red compared to other etiologies. And that, when you put that together, the angiocentric, the vasculopathy, essentially the fact that the non-aerated gas fraction doesn't go hand in hand with the PF ratio, you can see how at the extremes, sort of left and right, you see ARDS. You can see that non-aerated tissue fraction is related linearly with the venous admixture. But that is not the case. That relationship is lost in a COVID ARDS. So that's quite important. And also you can see how the dead space fraction is quite elevated and at the same time does not reflect changes in lung compliance and does not reflect the PF ratio per se. So there's clearly an effect that depends on time. This is one of the initial studies where they show essentially the changing in morphology in COVID-19 ARDS, going from the early stages where there is more ground glass, more preserved lung volume, to the later stages where there is more consolidation and more bilateral disease. So depending where and when we study these patients along this spectrum, is that where we can see different morphological and anatomical and mechanical characteristics, which might explain the heterogeneity of the results that have been published or present in the literature. So if you take those two extremes, very early and very late, you can see that although the hypoxemia is what links them together, obviously the anatomical and CT scan findings can be quite remarkably different that can affect the outcome, the ventilation and therefore the outcome. You can see that is quite common. You can see same PF ratio, very different CT scan, very different mechanics, very different response to PEEP. And when we look at PEEP, for example, this is a study from Professor Antonelli's group, and you can see essentially that while most of this patient respond after an increase in PEEP in terms of PF ratio, then there seems to be a heterogeneity in terms of response, in terms of dead space ventilation. Respiratory system compliance goes up in some patients, goes down in some others, and the same thing, the driving pressure. So although PF ratio seems to be indicating a response to PEEP, other markers might indicate the response might be more heterogeneous. The PEEP obviously doesn't come for free in a way that adding PEEP to a lung increases the static stress and strain, and that will increase potentially the level of inflammation. You can see that study looking at volutrauma versus atelectotrauma. So it's quite important to understand what's causing the hypoxemia and how we can correct it without before adding quite a lot of mechanical ventilation power. And that's quite important. I'm sure Liz will talk about this later on much more in detail. Now, the other interesting thing is that although there is a wide variety of compliance distribution in all patients with ARDS, when we look at the LungSafe study, 12% of that population had a compliance greater than 50. And the probability of dying went down when the compliance went up. Whereas in the paper by Giacomo Grasselli in the Lancet, what you can see is that the high compliance, low compliance had the same probability of dying when you look at that Kaplan-Meier curve. and the proportion of patients with greater compliance was significantly larger than the one seen in the LungSafe study. So this is one of my penultimate slides, just to say that this is a paper that would be presented later on today by Brij Patel. And essentially what we've done in this study, it just compared looked at the trajectory of disease. You can see with that diagram at the top, but your attention, I would like it to draw at the bottom. When you see the COVID ICU, the progression of disease in terms of PF ratio from mild to moderate, from moderate to severe, is actually much larger, 44% of the patient transition, compared to the LungSafe, where there was only 15% of patient transitioned to a worse disease status, and the Berlin ARDS, where there was 13.5%. So this is my last slide to conclude, to say that essentially what we have learned, I think what we have seen is a wide heterogeneity of lung presentation, which goes from the initial part, where mostly is a vascular dysregulation of ventilation perfusion, with normal lung volume or preserved lung volume, with low lung edema and low recruitability. Then you get to the intermediate stage when the lung edema starts to accumulate, the recruitability improves, and the lung volume go down. That's what you might call sort of very close to traditional ARDS, and then evolves into a less recruitable, maybe organizing pneumonia, maybe more fibrosis or fibrin deposition, where the lung becomes small, becomes non-recruitable, and the hypoxemia persists. So various phases, various treatment for each phases, but I think it's important to recognize the differences as well as the similarities with what we know so far. And with that, I would like you to thank you for your attention. I hope I was on time.
Thank you, Dr. Camporota. I think you really set the stage with this great lecture highlighting the pathophysiology of respiratory failure in COVID. And as I alluded to, we will have the 3 talks after each other, and then we have the Q&A session. So please submit your questions via the social media that are available to you. So I would like to move on and introduce to you the second speaker, which is Professor Massimo Antonelli. Professor Antonelli is Professor of Intensive Care in Anesthesiology, practicing in Rome in Italy. He is quite famous, I think, as he is the past editor-in-chief of Intensive Care Medicine. He's past president of the Italian Society of Intensive Care Medicine. And of course, he's also past president of our own European Society. His research interests are in non-invasive mechanical ventilation, ARDS, shock, and infection. And he will talk to us about non-invasive respiratory support.
Thank you, Nicole, for the introduction. I guess that Luigi Camporota has beautifully and elegantly introduced the pathophysiological mechanisms that are behind these difficult diseases. These are my conflict of interests. Well, I would like just to start with the recommendations or suggestions, I would say, of the Berlin Definition Task Force that enlisted the high flow oxygen therapy nowadays, but at that time non-invasive ventilation, within the possibilities, treatment possibilities for approaching my LDS and to some extent moderate LDS. Well, we know that if you look at the clinical presentations at admission to the hospital of the patients that we have treated so far, we can recognize the 2 hallmarks for the most severe cases who need the hospital admission are the tachypnea and the low oxygen saturation on room air. Well, we know that especially during the first heat, but also during the second heat, we had a problem connecting to the surge and the capacity of the hospitals and the ICUs. And that is why often we had to find solutions treating these patients with non-invasive ventilation, high flow oxygen therapy outside the ICU and also inside the ICU, just giving a possibility for having a better capacity into the hospital. I guess that looking at this narrative review published recently in the intensive care medicine, we can get some of the elements that pertains the application of high flow oxygen therapy in general to the COVID-19 patients. We know that a high flow oxygen therapy can deliver flows something in between 20 up to 60 liters per minute. And in general, we use it something in between 40 and 60. And one of the prerogatives of this technique is just assuring an adequate humidity, because the flows are humidified, fully humidified and heated, allowing a better comfort of the patient. But the high flow rate has several other advantages concerning the washout of the dead space, especially in the upper airways, increasing the CO2 clearance, allowing a reliable and persistent and adequate FiO2, whilst in low flow systems at times this is maybe not the case, and also capable to assure an increase of the pressure, airway pressures, increasing the end expiratory lung volume, the recruitment, and the lung compliance, ultimately translated into a reduction of the respiratory drive, respiratory rate, the tidal volume, and work of breathing and respiratory efforts. You understand that just having all these advantages in the early phases of the ARDS caused by the COVID-19, these may be very good options. In the same review, there was also another interesting suggestions that I guess can be largely applicable to the patients with SARS-CoV-2. A ratio, a score, which is a ratio of pulse oximetry over FiO2 to respiratory rate, has been proposed with different thresholds. And for each of these thresholds, articulated over time, there were some suggestions on the therapeutical behavior, considering the possibility of moving up to the endotracheal intubation if this score is quite low, or continue monitoring and insisting over time. But at the various steps, the possibility of considering the various therapeutical solutions. And always in the same review, has been also pointed out how the use of the high flow oxygen therapy, at least also in combination with non-invasive pressure support and non-invasive ventilation, could be various methodologies to be combined together when the patient need to be intubated because of his or her deterioration, and where we want to assure an adequate oxygenation before the intubation. After that, has been also published a conference report of a multidisciplinary and international panel on the role of high flow nasal cannula, and has been developed a sort of clinical practice guideline, where I draw your attention on the recommendations concerning hypoxemic respiratory failure that obviously pertains the patients I was speaking about, the COVID-19 patients, where the use of high flow nasal cannula is strongly recommended, even though with a moderate certainty. But it is certainly true that a number of information and justification to the application of the high flow nasal cannula also to this patient came from a study from the Florali and Reva network in France that has been published a few years ago in the New England Journal of Medicine, where the high flow oxygen therapy was applied in a randomized fashion and compared to the standard oxygen and non-invasive ventilation, obtaining a very clear and interesting message. Looking at the cumulative incidence of intubation, there was no difference among the three different categories. But focusing on the patients who were more severe, whose PF was below 200, the better performance of high-flow oxygen therapy resulted very evident. And speaking about patients enrolled in that study, very severe, with a bilateral pulmonary infiltrate and whose PF was in general below 200. However, the first real application concerning the report concerning the use of high-flow nasal therapy in COVID-19 came from a multidisciplinary and a multinational panel, whose first author is Molly Patel, and published the British Medical Journal Open. The conclusion of this trial was that the use of high-flow nasal therapy is associated with a reduction in the rate of invasive mechanical ventilation and overall the mortality in patients with COVID-19 infection. So it's certainly an observational study, but an interesting possibility in favor of the application of this technique. These were the first studies that were published during the first heat. Another study that came from China, where the first appearance of the SARS-CoV-2 was during the Wuhan epidemic. The author applied in non-invasive pressure support together with the high-flow oxygen therapy. And what has been shown in that publication, that having a very similar oxygen saturation in the various group, all with severe dyspnea, those who had the success of high-flow nasal cannula showed a consistent and significant reduction of the dyspnea, as well as a significant reduction of the endotracheal intubation rate. It is obvious this is another observational study and not a randomized one, but still an important signal on the usability and feasibility of the high-flow nasal cannula in this context. It is also, however, important to remind that this is a sort of an open system, which means that the patient is free to breathe in the environment and just disseminating the droplets that we know are the main responsible of the diffusion into the environment of the virus can be just found in the various fomites and on the beds, with the possibility of contaminating the external environment, and also the problems concerning the possible contagiosity for the personnel. That is why it's important that all the healthcare workers that assist these patients must be entirely protected with adequate PPE. However, some studies have shown as the simple use of a surgical mask in a computational fluid dynamics simulation can be capable to consistently and importantly reduce the dissemination of particles into the environment. This is maybe not the case when the patient is sneezing or coughing. It has been shown how this may generate a multi-phase turbulent gas cloud, where the capability of the droplets for reaching a long distance, even 7-8 meters, is very important. And this leads to the second possibility concerning a specific device that we are using more and more for delivering non-invasive ventilation, which is the helmet. The helmet has the advantage, at least under the circumstances of sneezing or coughing, of containing into the environment the environmental pollution due to the droplets, provided the fact that the port of the helmet are assured with a HEPA filter where the PEEP valve is located. I guess that the first study that showed the superiority of the helmet non-invasive pressure support ventilation over face mask as a mean to deliver non-invasive ventilation has been shown by the group of Patel and John Kress into the JAMA, where the application of the helmet was has an effect the increase of the probability of survival, but on top of that, the reduction of the endotracheal intubation and the possibility of deliver a higher level of PEEP by using the helmet in comparison to the face mask, and consequently allowing a better recruitment for those patients who are responder. Interestingly, the helmet has also been used in a sit-up mode and putting the patient prone. And under these circumstances, the graphs coming from this observational study from the Monza group, Giacomo Bellani and Acoppo are the first two authors, they show that as soon as the patient were put prone, they had a relevant and remarkable increase of PF, just recovering the same level of PF when the patient were put again supine, but showing anyway how the system can work also with this simple solution, and its feasibility can be largely applicable in our ICUs. We recently published a paper which was the effect pertaining the effect of the helmet non-invasive ventilation versus the high flow nasal oxygen, looking at the days free of respiratory support in patients with COVID-19. We enrolled 109 patients, and 54 of them received the helmet ventilation and 55 the high oxygen flow. When in the very early phases of the RDS due to the COVID-19, and where they had to fulfill the criteria represented by a PF below 200, but also a PaCO2 below 45. The primary endpoint, which was the median respiratory support 3 days, was absolutely identical, showing how both devices can be safely used without compromising any of the major effect. But, however, even though this was a secondary endpoint, those patients who were treated with the helmet non-invasive ventilation had a significant reduction of the cumulative incidence of intubation. And the hazard ratio for the endotracheal intubation in the helmet was 0.45, and the follow-up completed to 60 days after randomization for the patient confirmed what we have seen since the first days of application. How can we titrate the setting of the ventilator? We suggest of using a higher PEEP than those that we can deliver through the mask, something like 10 and 12, 10 the pressure support. Where the ventilator has this possibility, we can also just adjust the respiratory trigger in between 10 and 50% in order to avoid the double triggering, even though the asynchronies are not so important in these setting, or because the patient anyway is capable to express a work of breathing also before the opening of the valves, because there is a pressurized environment from which the patient can take some volume and then perform an active respiratory work. What about the inspiratory trigger? Let's have it at 2 liters per minute. and at times it's also useful to set up the maximum inspiratory time at 1 and 1.2 seconds. Interestingly, in a previous study that was recently also published, we showed how the reduction of the work on breathing and the esophageal swings, showing then the potential reduction of the transpulmonary injurious pressure by the application of helmet was a clear advantage in comparison to what we have seen under the same setting into the patient breathing to the nasal cannula. But what was the real application of these procedure during the first heat? I would say that at least in the first publication, in the largest number of patients enrolled in the north of Italy, no more than 11% of these patients received these devices. And however, when in the following enlargement of the sample size were considered the respiratory support, the non-invasive ventilation, and the invasive mechanical ventilation, the last three all represented a sort of increase of the heart rate ratio. But whilst the invasive mechanical ventilation increased the hazard ratio for the mortality rate by almost 4 times, non-invasive ventilation was a little bit conservative, I would say. And interestingly, the mortality of these patients who underwent the subsequent intubation was similar to the one that the patient who were treated since the very beginning with invasive mechanical ventilation, which meant that there was no real harm by delaying the intracranial intubation for those patients who failed non-invasive. Which are my conclusion then, which are practical and clinical, I guess. The high flow oxygen therapy and non-invasive ventilation can be used in acute respiratory failure due to COVID-19. The high flow and helmet CPAP can be used as first-line intervention, also in emergency cases outside the ICU, but we need a careful selection of the patient. And don't forget that treating COVID-19 patients, full protection for the person, for the healthcare workers is mandatory. Thank you for your attention.
Thank you, Professor Antonelli, for this wonderful talk about non-invasive ventilation and about summarizing all the data that have already come available to us about COVID management. So I would like to continue with the third speaker of this session, and it is my pleasure to introduce to you Dr. Lise Piquiou. Dr. Piquiou is an intensive care physician practicing in the University Hospital in Lausanne in Switzerland, and she is also an honorary lecturer at the Lausanne University. She is deputy chair of the acute respiratory failure session of our society. Her research interests are mechanical ventilation and ARDS. And she has the enormous task of discussing with us invasive mechanical ventilation as well as rescue strategies, and that all in 15 minutes. Please, Dr. Piquiou.
Thanks a lot for this kind introduction. I'm going to go through some key messages regarding the invasive mechanical support of the COVID-19 ARDS patients. Acute respiratory distress syndrome, ARDS, is a diffuse lung inflammatory disease responsible for acute hypoxemic respiratory failure. It's defined by the Berlin criteria: acute onset, bilateral opacities on chest imaging, lung edema of non-cardiac origin, and hypoxemia. ARDS has different etiologies, including COVID-19 pneumonia, which is a viral illness that causes inflammatory response and hypoxemia, and which, in the most severe cases, matches the Berlin criteria for ARDS. ARDS was first described in 1967 as a respiratory distress syndrome of acute onset characterized by hypoxemia and loss of compliance. At that time, mechanical ventilation was used with the aim to correct normalized blood gases. Of course, that meant delivering high tidal volumes and high pressure. ARDS in the 70s was associated with very high mortality. During the 80s, the concepts of volotrauma and barotrauma related to mechanical ventilation emerged as the idea of delivering more gentle ventilation to prevent ventilator-induced lung injuries. Protective ventilation was progressively applied with a parallel decrease in ARDS mortality. But what means protective ventilation? As illustrated in the right part of the figure, protective ventilation means delivering low tidal volumes to avoid volotrauma, keeping plateau pressure low in order to reduce the stress applied to the lung parenchyma by mechanical ventilation. And protective ventilation also means delivering enough PEEP to prevent derecruitment, to avoid atelectasis and atelectrauma, and to decrease lung strain. The current recommendation for ventilatory ARDS patients, as for example here, the recommendations from the French Society of Intensive Care Medicine, mention all those components. Low tidal volumes, around 6 milliliter by kilo predicted body weight, plateau pressure kept under 30 centimeters of water, and PEEP should be higher than 5 to prevent derecruitment. Those recommendations have been written for standard ARDS, but should, in my opinion, be applied for our COVID ARDS patients too. As you can see here, very similar recommendations have been published for COVID-19, a severe disease. Low tidal volumes, plateau pressure of less than 30, and enough PEEP. Even if we have recommendations to treat our COVID-19 ARDS patients, it's very important to underline that ERDS is an heterogeneous syndrome and that some individualization of the settings is important. ARDS is heterogeneous. There are different etiologies, direct lung injuries, as for example pneumonia or aspiration of gastric aspirates, but also indirect lung injuries, as we can observe in extrapulmonary septic shock, severe trauma, polytrauma, or pancreatitis. In addition, different phenotypes for inflammation have been described in ARDS. And severity varies from mild disease to very severe disease with refractory hypoxemia. And if we look at respiratory mechanics, and in particular, as illustrated in the right part of the slide, respiratory system compliance, we observe that the range of values we can have is very wide, from very severely altered compliance to nearly normal compliance. If we look at recruitability, here also we have major heterogeneity. In these studies, Gattinoni and collaborators assessed 68 patients by CT scan at low PEEP and very high PEEP. And they compared the amount of lung tissue that was potentially recruitable. And you can see that depending on the patients, the amount of potentially recruitable lung was very different, as illustrated in the left part of my slide. And this suggests that there is a clear interest for ventilator settings individualization and not for using only one rule for all our patients. Constantin and collaborators have recently demonstrated the potential interest of this approach. The idea of their study was to apply different tidal volumes, PEEP, and recruitment strategies, depending on whether ARDS lung had a focal or non-focal aspect on chest X-ray or CT scan. Overall, there was no difference in mortality between the control group, treated as usual, and the intervention group. However, when the initial classification based on the chest X-ray or CT scan was revised, it appeared that a lot of patients were initially misclassified. And if we look at those misclassified patients in the intervention group, which means if we look at the patients that were ventilated with the wrong strategy, we can observe that mortality was very high in those patients who were misclassified. This again underlines that individualization of ventilator settings in ARDS patients is probably a good idea. This is probably true for COVID-19 ARDS patients also. Indeed, COVID-19 ARDS is a very heterogeneous disease, as mentioned by Luigi in the first part of these presentations. As illustrated here, COVID-19 hypoxemic patients can have only interstitial infiltrates, as in the left image on the slide, but they can also have typical baby lungs of ARDS patients. Some authors have described the form with interstitial infiltrates as a type L disease. Type L for low elastance, high compliance, low ventilation over perfusion ratio, low lung weight, low recruitability. Oppositely, the more typical baby lungs patients were described by those authors as type H for high elastance, low compliance, high shunt, high lung weight, and high recruitability. As illustrated in the right part of the slide, compliance and recruitability can have a wide range of values in COVID-19 patients, as also in other ARDS patients. This is also true for ventilatory ratio, a parameter correlated with dead space. This important heterogeneity of COVID-19 ARDS probably has to be taken into account to optimize our ventilator settings. And this is probably particularly true for PEEP setting. Indeed, the effect of high PEEP are not expected to be the same in type L and type H patients. In type L patients, high PEEP is expected to create overdistension, or at least there is a risk of overdistension when high PEEP is applied to those patients. High PEEP in those patients can lead to a decrease in compliance, an increase in dead space, and even to hemodynamic impairment. Oppositely, in type H patients, high PEEP is expected to enhance recruitment, to increase compliance, and to decrease shunt. The different responses to PEEP in COVID-19 ARDS are illustrated on the right part of the slide. it is obvious that response to PEEP is not the same for all the patients. This is illustrated here for respiratory system compliance in the upper part of the slide, and for the ventilatory ratio in the lower part of the slides. Based on those observations, we can say that PEEP setting should be individualized in COVID-19 patients based on the patient phenotype, if we can call that a phenotype. This pragmatic approach has been suggested in the recent review from AJA and collaborators. Those authors suggest using 8 to 10 of PEEP in type L patients and higher PEEP in type H patients. Of course, this pragmatic approach should be tested prospectively. We have now discussed what we know about the general principles for ventilating our COVID-19 ARDS patients. It's now interesting to look at how ventilation was performed in 2020 in COVID-19 ARDS patients. You can see here in a very large amount of patients that median tidal volumes delivered was around 6.5 milliliter by kilo. This is the red bar. Plateau pressure delivered was around 23, and PEEP around 12 centimeters of water. However, tidal volume, plateau pressure, and PEEP values were spread over a very wide range. Another important point to discuss regarding ARDS management is the use of rescue therapies in case of severe hypoxemia. We know from previous studies that proning the ARDS patients who have a PF ratio of less than 150 was associated with decreased mortality. This is the PROSERVA trial published by Claude Garin already some years ago. We also know that inhaled nitric oxide can improve oxygenation, but unfortunately did not decrease mortality. And we know that extracorporeal membrane oxygenation can be used as rescue strategy when we have refractory hypoxemia. This is for standard ARDS. What about COVID-19 ARDS? Recent data has shown that proning improves oxygenation in the COVID-19 ARDS patients, as illustrated in the middle part of this figure. There also has been demonstrated that proning those patients is safe. And for those reasons, a recent expert clinical practice statement recommends using proning in the more severely hypoxemic COVID-19 ARDS patients. We can look here what is the reported use of rescue therapy for COVID-19 in 2020. And you see that prone position overall was used in nearly half of our intubated COVID-19 patients. Pulmonary vasodilatators was used in 16% of the patients, and ECMO in 3% of the COVID-19 patients in this reported data. In conclusions, we can say that protective ventilation should also be applied for COVID-19 ARDS with low tidal volumes and low plateau pressure. We can say that PEEP setting should be individualized to enhance recruitment and limit hyperinflation. And we can say that prone positioning should be used if hypoxemia is severe. Thanks a lot for your attention.
Thank you, Dr. Pikiu, for this excellent contribution. So now there is some time for discussion between all of the panel members. Hopefully, yeah, there are other faces. That's great. Great to see you all together. So we have several questions from the social media. And I think I would like to first start out with a question about the different types of ARDS that were encountered, because both Luigi as Lisa, you alluded to the existence of the L and the H type of ARDS. And there's a question here about, there's a little bit of a controversy in ARDS, in the ARDS community. What are your thoughts on this? Is this really helping us in stratifying our mechanical ventilation settings, or is it only causing a little bit of harm?
For me, the type L and type H classification is a bit theoretical. There is not one type L and one type H, and a patient can move from a type L to a type H. However, this classification is, in my opinion, very interesting because it underlines the point that ARDS is a syndrome and not a single disease, and that each ARDS patient has specificities, and that it's important to set the ventilator by looking at the effect of what we do, and then in particular at looking at the effect of increasing PEEP. Sometimes it's the thing to do because it's improved the situation, it's improving the compliance. And in other patients, especially those who are described as type L, you can also really overinflate the lungs and have adverse effects of this strategy. Then the main point for me is think that all your patients can be different. I don't think, Luigi, what you think?
Yes, thank you, Liz. I think I agree largely with what you said. I think the important thing, if I may, is important to realize that this differentiation was not meant to be like, these are stable phenotypes. It's like, this is what they are and they are set in stones. It's just a way of understanding how essentially patients with the same idea of a PF ratio present a variety of lung volumes, and therefore, as Liz said, the treatment applied should be individualized, both in terms of total volume and in terms of PEEP. Because the idea at the beginning of my talk, in a way, alluded to the fact that traditionally, worse PF ratio was worse lung edema. And that is what I was trying to say, that the vasculocentric or the vascular abnormalities predominates. Therefore, that relationship is less clear, particularly at the beginning. Clearly, at later stages, and depending when patients get admitted in individual units, we might see a different aspects of that particular continuum. But it is a continuum. They're not absolutely stable ideas. So yes, I would say that they help me understanding at the bedside, looking at a chest X-ray and CT scan. And I don't imagine that patient having a PF ratio so low. And it points to the direction that I'm not going to give huge amounts of PEEP, I'm not going to do a recruitment maneuver, but perhaps I'm going to use prone positioning a little bit more. I'm going to use other things which do not involve reversal of atelectasis or consolidation, which some of
Nicole, sorry to interrupt, and while Luigi and maybe Massimo also want to comment. We have some other questions, and I would like to invite, maybe before Massimo finishes, also David Links, who is also our social media moderator for this session. He's also a consultant in anesthesia and intensive care at Belfast. But please, Massimo, go ahead, bringing your view on this question.
Okay. My comment may be provocative, but is essentially very simple. Are we sure that the COVID-19 ARDS are so different from the traditional RDS we see, it is true what Luigi said concerning the microvascular involvement, but we know all that probably may be prevalent in COVID-19 patients, but on the other hand, the involvement of the microcirculation is also a hallmark that with microthrombosis and so on, what we see in the traditional RDS, which I remember is a syndrome and maybe multifactorial, and various pathophysiological reasons may determine the RDS. In other words, the variability of the patterns imply what Liz stressed the most, that we need to individualize anyway our ventilatory strategy on the various patients, remembering that whatever we do, the tidal volume, respiratory rate, and PEEP all, in a way or another, act in concert on the driving pressure and the plateau pressure. So we need to be very careful what we do, whatever would be the reason of RDS. But this is my personal view.
Thank you.
I totally agree with you.
David, sorry, we for the sake of time, we have some burning questions also coming from the social media. David, do you want to ask? We have time for one question, one quick round with the panel.
Yes, I've sort of consolidated a lot of the questions from social media into sort of one, and I think it really comes down to a practice question, which is likely necessitated by enormous resource pressures across traditional ICU beds. There is a huge uptake in CPAP in the United Kingdom particularly, which is largely delivered outside intensive care, and therefore the collection of traditional ICNARC and ICU data systems. There seems to be a massive paradigm shift away from early intubation that was sort of mooted at the start of the pandemic, and it's the exception therefore that patients are intubated early, and we tolerate a tremendous amounts of hypoxia successfully. So I suppose the question is, what does this match the practice in your own countries outside the UK, where an enormous amount of CPAP is being used and perhaps data is not as rigorously collected as in intensive care? And is there much work to be done on characterizing the hypoxic phenotype of patient that is sitting on the ward, quite often left far longer than we would normally leave these hypoxic patients, which then obviously dictates the need for invasive ventilation strategies?
If I can I start with three considerations? The first concern, as I mentioned at the beginning of my presentation, the capacity. It is obvious that despite the attempt that has been made up so far for enlarging the number of ICU beds, still we may find a situation where the number of beds is insufficient. And so we are obliged to treat these patients as much as we can in the best possible way outside the ICU. One of the modalities is certainly the application of CPAP, whatever would be the system or delivery system we use. And the other one is high flow oxygen therapy. The second point is in general the best way to treat this patient in the very early phases? Maybe yes. It is better to allocate them outside the ICU or inside the ICU. I would say, if you do have the capacity, better into the ICU, because always you may run the risk to an emergent intubation. As a third, which is always important, it is true that we at times use these devices and treat hypoxia that remain relatively low with a good tolerance on part of the patient for a long period of time. But the recommendation says that in general it's better to avoid very long lasting. I know that there were groups where they used a non-invasive ventilation for days before intubating the patient. Maybe this is not the right way to go. And probably after at least in our experience, the use of the helmet non-invasive ventilation for, let's say, 12, 24, 48 hours at the most, if the patient did not improve at all, they never hesitate to intubate. That remains the best solution in these cases.
I fully agree with that. This is our practice as well. Yeah.
Well, thank you very much. I have a short comment, and maybe Massimo and Luigi, I really enjoyed the comments and the way you are bringing, really guidance to the bedside. I believe that when we compare the different waves, obviously the last patients, we did CTs for every patient, and for the UK variant, we almost didn't see any pulmonary embolism. So do you think that the microvascular component has been reduced between the different waves? And do you think that all the data that are coming from the first wave, with the learning curves and the changing pathophysiology, would also apply to the more recent patients and maybe the future ones? Massimo, maybe?
Okay, I can confirm what you're saying, that also we noticed that in my personal unit, we treated over the entire pandemic more than 1,100 patients. And whilst in the first phase of the pandemic, indeed, the microvascular involvement and pulmonary embolism were very common, now we see them, but in less percentage. To be honest, I cannot tell you if this is due to the change of the variant or a more representation of the UK variant, but this is something that we have already seen. And we are using the anticoagulant in a usual prophylactic dose for the prevention of deep venous thrombosis, instead of using in a higher dose for treating the embolisms.
Liz, do you want to make a comment?
Very brief one, if you don't mind. It just basically say, although the pulmonary emboli might have decreased, you can see that most of the problem sometimes is with altered lung perfusion that we see on CT scan or dual energy CT scan in the absence of clear thrombosis. So I think that aspect will be has to be studied a bit more. I'm sure Beverly Hunt will talk about this later on this afternoon, but still we saw one in 3 to 1 in 4 patients with some vascular abnormalities, which are macroscopic, and some of them smaller on perfusion scans.
The discussion is great, but we really need to close. Maybe I would like to ask Liz and Nicole if they can give a very short take-home message. If you are a resident at 3 o'clock at night and you have a patient that is just being intubated, we hear that you have to individualize, but how do you start?
Yes.
A few seconds.
Liz, go ahead.
For me, it's never forget that the COVID-19 ARDS patients are ARDS patients. Then you have to do what we've learned to do for ARDS patients for years.
Very simple and very good message for all the audience. Thank you very much, Liz, and thank you, everyone. And it's time now to move to the next session. And a great thank you for all of you. Thank you. good afternoon for those who are staying and good afternoon for those who just are coming. This is the LIVES COVID-19 Worldwide Digital Marathon webinar, and we are the European Society of Intensive Care Medicine. Good afternoon. So I'm delighted to introduce Professor Jean-Louis Teboul, who is Professor of Critical Care at the Paris South University. And we know Jean-Louis as a leader in the delivery of critical care and a role model for many of us. And we are now getting into the cardiovascular involvement of COVID-19 severe pneumonia in the critically ill. Thank you very much, Jean-Louis.
Thank you very much, Elie. So, good afternoon, everyone. Good morning, maybe, or good night, maybe. So I'm Jean-Louis Teboul from Paris. I would like to introduce the first speaker, who is Dr. Susanna Price. Dr. Susanna Price is a consultant cardiologist and intensivist at the Royal Brompton Hospital, where she is lead of procedural echocardiography and severe acute cardiac failure or cardiogenic shock. She's professor of cardiology and intensive care medicine at the Imperial College London. Susanna is a chair of the Education Committee of the European Society of Cardiology, ESC, and immediate past president of the European Society of Cardiology Acute Cardiovascular Care Association. She's also deputy editor of the European Heart Journal, and she has authored numerous papers and book chapters on cardiology, echocardiography, and intensive care. So Susanna, you can start now your presentation.
Thank you very much, Jean-Louis. So welcome everybody. It's a great pleasure to be here to talk to you about COVID-19 and the heart. I have no disclosures related to this or any other presentations. So in the next 15 minutes or so, I'm going to explore with you a little bit about what we're beginning to understand about the unique vulnerability of the heart when it comes to COVID-19 infection. And then I'm going to see how this maybe explains some of the cardiovascular findings we've seen over the last year or so. I'm going to explore briefly the important unintended consequences of our response to the COVID-19 pandemic with respect to cardiovascular disease. And then I'm going to touch briefly on the potential future impact of what having had COVID-19 might mean for your cardiovascular health. So first up, I would urge you to take a look at these two excellent papers. The first one, published in Circulation Research in April this year, is really a fantastic overview of COVID-19 and cardiovascular disease from bench to bedside, drills into some detail of what we know from all different areas of cardiovascular medicine and how that might impact on how COVID-19 interacts with the cardiovascular system. And the second, also published in April 2021 in JACC Basic Translational Science, begins to drill down into the mechanisms of what happens when the heart is infected with COVID-19. So I'm going to turn to the second of the papers first, and it's got two parts to it. The first is a small clinical part, and the second is much more basic and translational science. So first up, the authors sought to demonstrate that there was virus within the myocytes. Now, you might think that that's a no-brainer, of course there is, but there's been some controversy as to whether there actually is virus or viral involvement in patients with COVID-19. So they took 4 autopsy COVID-19 patients, proven myocarditis, proven COVID-19 infection, and what they demonstrated was that there were intracellular viral particles, there was clear budding on electron microscopy, and they also demonstrated cell death and macrophage infiltration associated with areas of myocyte cell death. And to date, this is the largest number of patients that have been shown with proven COVID-19 myocarditis, as well as identification of virus in the myocytes. Next up, they move to the larger part of the paper, which is looking at the mechanisms of what happens when myocytes and heart cells get infected with COVID-19. They looked at engineered heart tissue and they looked at 2D cultures. And they took inoculated human cardiac stromal populations inoculated with a recombinant COVID-19 clone, which contained a neon green fluorescent reporter. And the importance of the neon green fluorescent reporter is that it's supposed to highlight active viral replication. And they looked at different areas. They looked at intracellular viral RNA transcript levels. the susceptibility to infection for different cell types, the temporal relation between any infection that they saw and cell death. They looked for active replication in different cell types, and then again they looked to confirm virus and replication with electron microscopy. And the headlines of what they showed were these. So first up, they showed that this cardiomyocyte infection showed rapid production of infectious virus with a peak at day 3 post-inoculation. And then they showed that cardiomyocyte cell death was observed beginning days 4 to 5 after inoculation. Their flow cytometry performed 3 days, so that was at peak, after infection, revealed that this neon green reporter expression was only seen in these myocytes. And then on electron microscopy, they confirmed that COVID, in what might call various stages of assembly, was seen within the cardiac myocytes. So now thinking a bit more broadly about what might this mean in terms of cardiovascular health and disease. The second paper, the circulation research paper, pulled together what we know in terms of state-of-the-art ACE2, COVID-19 and cardiovascular disease. So the first is that if you look at ACE2 expression in cells within the heart, it's heavily expressed in pericytes, in fibroblasts and cardiomyocytes. The second thing that they highlighted was the effect of cardiovascular disease on ACE2 expression. So if you look at dilated cardiomyopathy, hypertrophic cardiomyopathy, these diseases have a profound effect in terms of upregulation of ACE2 expression. Looking at the effect of ACE inhibitors on ACE2 expression, they do not have an effect in terms of cells within the heart. And interestingly, for what we saw within the pandemic, our ACE2 expression in terms of these cardiac cells decreases with age and is greater in women than is seen in men. And that paradox has not yet been unpacked. Then going back to the basic science paper, they then looked, having demonstrated the virus was there, what was the effect in terms of downstream signaling? So they looked at differential regulation of host genes in cell types and in 2D tissues. And they showed, obviously, there was the upregulation in terms of inflammation that they did expect to see, but there was profound downregulated expression of the genes associated with cardiac myocyte function, contractility, and energetics. And you can see here the areas they looked at, so calcium handling, sarcomere function, and so on. So profound downregulation associated with infection. So that really is an introduction. It begins to show us why the heart is so vulnerable in COVID-19. How did this translate into what we saw clinically? So this was a patient that we saw during the COVID-19 pandemic. He's a previously fit well person who had COVID-19 2 weeks previously and is in extremis with a SCI-E cardiogenic shock. And this turned out to be biopsy-proven myocarditis from which he made a full recovery. Interestingly, right across the board, all of the autopsy papers that have been published suggest that acute myocarditis is actually relatively uncommon, much more common to see inflammation. And the inflammation is probably associated with myocardial injury, which again, relatively common in COVID-19. And this is one of the earliest papers, came from Wuhan, looks at patients in the first wave of the pandemic who were discharged and died with COVID-19 by January 31st, 2020. And they showed an association up to nearly 200 patients included in the study. Association with mortality was age, elevated D-dimers and cardiac troponin. And numerous studies since then have shown this association with elevation in cardiac troponin and increased risk. The worst combination being preceding cardiovascular disease, COVID-19 and elevated troponin being associated with a really very high mortality indeed. So with all of these data emerging, the discussion amongst the cardiac community has been really focusing on COVID-19, not so much as a disease of myocarditis, but an endothelial disease, and turning their attention really to type 1, type 2 myocardial infarction. And type 2 myocardial infarction, you'll all be very familiar with, those of you who work in critical care, and that's the supply-demand mismatch. And it's felt now that the pattern of myocardial injury during COVID-19 looks a little like this. So you start with your direct ACE2 mediated damage. You move on to hypoxia-induced myocardial injury, which could result in type 2 myocardial infarction, and or right ventricular dysfunction. This progresses potentially to cardiac microvascular damage, and then you see the myocardial dysfunction associated with a systemic inflammatory immune response or superadded infection. And that's felt to be how the heart responds to COVID or is damaged during COVID with this progression in time. We shouldn't forget the right heart. And I think it's notable that the way the right heart responds probably reflects the underlying pathogenetic mechanisms. And it doesn't look like the right heart that you see in typical ARDS on the ICU. There's more of a loss of radial function and quite profound VA uncoupling. So I've been through the unique vulnerability, a little bit about why this might explain what we've seen clinically, but what about the unintended consequences? So the cardiologists across the world were bracing themselves when they knew that COVID was coming for a huge increase in acute myocardial infarction. And pretty well across the board in terms of viral pneumonias, there is an increase in acute myocardial infarction in 7 to 10 days after infection, probably related to acute plaque instability. And so they were expecting to see exactly that with COVID-19, but actually we saw quite the opposite. This is an editorial from the European Heart Journal, and it accompanied a study that was done during the first wave, towards the end of the first wave. They looked at 141 countries, 6 continents, varying degrees of lockdown, and nearly 80% of respondents stated there was a reduction in the numbers presenting with STEMI, so quite the opposite of what we expected. And nearly 60% stated that a significant proportion presented after the optimal intervention time interval, so too late for the evidence-based therapies. And when they drilled down into what were the reasons for patients presenting late or what were the associations, they related to 3 areas. One was the degree of lockdown, so none, partial or full. So the greater the degree of lockdown, more patients presented late. The number of COVID admissions to hospital, again, the more COVID there was being admitted to hospital, the more late the admissions were that they saw, and the degree of restructuring of cardiology units. So the cardiology units, many of them were restructured in order to accommodate COVID-19 patients or redeployment of staff. And again, these patients are presenting late, too late for their evidence-based interventions. So right across the globe now, the cardiovascular community is very concerned about what we're going to do about the backlog, what we're going to do about the patients who didn't have the optimal therapy during the first, second and third waves of COVID-19, and what are we going to do to future-proof to make sure that this doesn't happen again. And then finally, I'm going to turn to the potential future impact for all of our cardiovascular health for people who've had COVID-19. You will have heard a lot of discussion about fit athletes who had abnormal CMRs with late gadolinium enhancement suggesting scarring and fibrosis. And what does that mean? This study was done not in fit athletes. This was done in nearly 150 patients who had COVID that required hospital admission, had elevated troponin, and I think about a third, 32-33% were ventilated. And they did CMR at 68 days afterwards, with or without stress imaging, depending on the indication. Now, the ventricular function on the left heart was normal in nearly 90% of these patients, but they saw late gadolinium enhancement and or ischemia in more than 50%, 26% with a myocarditis-like scar and 22% with infarction and or ischemia, and then dual pathology in a small percentage of patients. So this is common as a finding in patients who've been admitted to COVID-19 and troponin elevation, ongoing potentially heart failure or potential arrhythmia. You can see here that are being currently undertaken to try and work out what the long-term effects of COVID-19 might be. We know other viral diseases, other pneumonia of cardiovascular risk. We know that the clinical effects of pneumonia have been linked to an increase of cardiovascular risk for up to 10 years of follow-up. We also know previous SARS epidemic, lipid metabolism was disrupted for 12 years after clinical recovery, and that was a metabolomic study. So we don't actually know what the future holds for our patients who've had COVID-19. So take-home messages are these. The heart is uniquely vulnerable to COVID-19, particularly in the presence of cardiovascular disease. The mechanism involvement begin to explain clinically, but the unintended consequences of firstly our response to COVID-19 or what the long-term effects of COVID-19 might be on our patients and ourselves if we've had COVID-19 are absolutely unknown. Thanks very much for your attention.
Thank you very much, Susanna, for this very brilliant presentation on the heart in the COVID-19. So we'll move to the next one and we'll have a debate at the end of this session. So the next presentation will be given by Beverly Hunt, who is Professor of Thrombosis and Hemostasis at King's College London, consultant in Thrombosis and Hemophilia Center at Guy's and Thomas NHS Foundation Trust, and clinical lead in hematological sciences at VIAPAS LLP. She is founder and medical director of Thrombosis UK and chair of the steering group of World Thrombosis Day. In the COVID-19 pandemic, she has become an international expert on thrombosis and coagulopathy in COVID-19 patients. She sits on the World Health Organization and NICE guideline development groups producing living COVID-19 guidelines. Thank you very much, Beverly, for participating in this meeting, in this conference. Thank you very much.
Thank you very much. And COVID has moved on. We are now vaccinating people, and we have a really important but rare side effect of thrombosis. And I'm going to try and have a few slides at the end about that because it is very relevant at this current time, especially for critical care units. So you've heard my conflict of interest and that I belong to living guidance with WHO and NICE, and we're going to move on. So we all know about COVID. We know it enters the body through ACE2 receptors. Most people have mild disease, and the issue for us is that we're admitting people to hospital to treat them for hypoxia, and we separate them out into those on the wards who have supplementary oxygen, and then the critically ill who have mechanical support. And we know that we have a profound inflammatory response within the lungs in those with COVID pneumonia, not the asymptomatics, but just COVID pneumonia. And that production of interleukin-1 and interleukin-6 has meant that we see a pro-inflammatory state. And interestingly, we know that COVID pneumonia is most likely in people with diabetes and obesity and increasing age, all states where we've got more pronounced pro-inflammatory states. So I think this slide just says it all about the coagulopathy. It was a bit of a shock this time last year to find that the coagulopathy of critically ill patients with COVID was actually a prothrombotic acute phase response, because we were expecting disseminated intravascular coagulation as was predicted by the Chinese experience. And I think that obviously we do see DIC, but it's really those with multi-organ failure. And one wonders whether those that they described were terminally ill. So I think we all know that critically ill patients with COVID have very high levels of fibrinogen. Medians in this study of our first 66 critically ill patients were 7 or 8 grams per litre, normal values up to 4 grams per litre, and some reached the heady heights of 14 grams per litre. We also know we had incredibly high levels of D-dimer. You'll see the D-dimer scale is logarithmic, and that the D-dimers do not discriminate between those who have VTE and those who don't. On the bottom of this chart, we've got the pro-inflammatory markers, procalcitonin, ferritin, and CRP, and they all tend to move with the fibrinogen and D-dimer. So the next surprise was the really high rates of venous thromboembolism on patients who are actually receiving thromboprophylaxis. And if we look at all these papers that were produced by June last year, we're finding levels of VTE up to 79%. Many of them were describing mainly changes on CT pulmonary angiograms, and I think that we now recognize that we were picking up two phenomena in the lungs. So we obviously are having VTE. COVID is the perfect recipe for VTE. It switches on all aspects of Virchow's triad, but we also had immunothrombosis, by which I mean microvascular thrombosis as a consequence of local inflammation. And this is a well-known phenomenon in acute respiratory distress syndrome. And it just reminds us about the basic concepts of the coagulation system. The coagulation system has evolved as an effective system of the immune response, and it's designed to wall off invading bacteria. And so when you get profound inflammation, you should expect microvascular thrombosis. We certainly do when we do clinics with Behçet's disease and vasculitis. And we know for those patients, it's no good giving an anticoagulant. We need to switch off inflammation. And these days we do it with a biological. And then the last profound stimulator is hypoxia. Remember, hypoxia leads to hypoxia-inducible transcription factors, which will bind to tissue factor and the PI1 gene and several other genes so that they switch off fibrolysis and switch on coagulation. When we look at all of the studies on coagulation and immunothrombosis, everything is positive. So we see massive netosis, we see platelet activation, we've got complement activation, which will further activate coagulation. The next thing to consider is the D-dimers, and D-dimers, as this paper, which comes from Wuhan, show that D-dimer levels are a marker of the acute respiratory distress syndrome. They looked at the COVID patients they were ventilating and compared with those who had viral pneumonia over the last few years. And if you look at the bottom, you can see they've both got really high levels of D-dimers. And in fact, the lung can produce urokinase to break down that microvascular thrombosis. And it's probably spillover from the lung that's causing these high D-dimers. So, is COVID coagulopathy the most prothrombotic state we have seen, or certainly as far as viral pneumonias? And this paper from Guy's and St. Thomas's says yes, because we looked at patients who were going onto ECMO because they were so hypoxic and compared them with previous influenzas. They always get a CTPA, and the CTPAs show that there was greater number of pulmonary artery filling defects, and there were greater numbers of pulmonary immunothrombosis as defined by finding segmental and subsegmental changes on the scans. Thankfully, not a higher rate of intracranial hemorrhage. And then at the end of ECMO, we always do Doppler to look for the residual DVT. And what do we find? We find that there is significantly more DVT in those who have COVID when compared to other pneumonias. So, through this pandemic, many people worried by these huge rates of thrombosis, which they took to be pulmonary emboli, but probably most of them were immunothrombosis, have been using different ranges of heparin to try and prevent this problem. And at last, we have some randomized controlled trials to tell us what the outcome is. So this triumvirate of REMAP-CAP, Active-4 and Active did a trial of full dose anticoagulation versus standard of care, which is either intermediate dose or standard thromboprophylaxis. This is the critically ill group, and you'll see there is no benefit from full dose anticoagulation. And actually, there is evidence of harm because the major bleeding rate occurred in 3.1% of those on therapeutic anticoagulation. and 2.4% on those with standard care. So no benefit in clinical outcome. So this is organ support-free days combined with mortality. However, if we do the same trial in those with moderate disease, so the ward-based patients, we get a different answer. And in actual fact, there's evidence of benefit of using therapeutic anticoagulation on clinical outcome. So there were more patients who left hospital early, and there were fairly low rates of major bleeding, only 1.9% in the therapeutic arm and 0.9% with standard thromboprophylaxis. Now, what does all this mean? This is heparin at work, and we know heparin is an antiviral agent, it is an anti-inflammatory, and it's an anticoagulant. And it's not clear at all from the data that this effect is working as an anticoagulant, and we suspect that much of it is its anti-inflammatory effect, and more work's necessary here. This is all summarized in an editorial a group of us wrote for the BMJ, and since that editorial we've had one further paper, the Inspiration randomized controlled trial. They compared standard thromboprophylaxis, weight adjusted, versus intermediate dose anticoagulation in the critically ill patients. 600 patients, perhaps maybe ever so slightly underpowered. There was no difference in outcome. So there was no difference in clinical events. So this tends to make us think that we need to probably go back to using standard thromboprophylaxis for the critically ill patients. Well, I have to touch on the vaccine, and somebody will stop me, I'm sure, when I'm run over time. Just to remind you, it's incredible, isn't it? This time last year, we were suffering from huge numbers of patients. Many people were dying. A year on, we have got a vaccine. We have vaccinated over 1 billion people. And this is someone getting the vaccine at the bottom of the Himalayas. So an incredible achievement, but we have had some problems. And we have seen post-vaccine induced immune thrombocytopenia and thrombosis. This is what I'm talking about here. Two typical cases. This is a 38-year-old vaccinated with the AstraZeneca vaccine. 14 days later, has a severe headache with a Glasgow coma score of 14, found to have cerebral venous sinus thrombosis with thrombocytopenia, very high D-dimers, another marker, low fibrinogen, admitted, but within 24 hours, despite good care, unfortunately coned and was declared brainstem dead. On the right, we have a 41-year-old man. He was vaccinated with AstraZeneca because his 8-year-old son was quite unwell and he was the main carer. 6 days later, he presented with bilateral ischemic legs, platelet count of 40, D-dimers 8,000, slightly low fibrinogen. Immediately he arrived, he was given intravenous gamma globulin and orgatroban. He went to theatre. Unfortunately, all the thrombosis reoccurred, so he went back again. This time they retrieved most of the vessels, and he's been left with a 4-foot amputation. So I'm describing this very, very rare syndrome, but important because in the UK we are vaccinating so many people with AstraZeneca. We've hit 23 million, and it also occurs in the US after J&J vaccine. So this is thrombosis at unusual sites. Half of them have cerebral venous sinus thrombosis, 30% have splenic vein thrombosis, and then the rest have arterial events, myocardial infarction, aortic thrombus, leg ischemia, and then a few will present with DVT and PE. They tend to have low platelets, very high D-dimers, and sometimes low fibrinogen. And what we have found is that they have an antibody to platelet factor 4, which is a characteristic of heparin-induced thrombocytopenia. In the UK, there are a group of us who work together every day at 2 o'clock. We have a call and we go through all of the new cases that exist in the country. We talk about the diagnosis and we organise care, and we have living guidance, which is on the British Society for Haematology website. We are 2 months in with this syndrome, and we have hundreds of patients with about a 20% death rate. We are looking back because we suspect this syndrome was only described in March. We have been vaccinating with AZ in the UK since the end of December. We may have missed cases, so we're doing a major look back. So just to remind you, with heparin-induced thrombocytopenia, heparin binds to platelet factor 4 and forms a neoantigen, and that will the antibody to that will bind to platelets through the Fc receptor, also monocytes, and activate coagulation. So looking at our cases, this is last week, 262 cases, and probably reflecting the denominator as far as male and female is concerned. Why are we getting these antibodies? Is it the fact that we're using an adenoviral vector, which can cause thrombosis in primates? Is it that spike protein has sequence homology with platelet factor 4? Or is it some immune response? And we know that from the work of Andreas Grunetscher in Germany, that probably platelet factor 4 is binding to vaccine particles that are circulating, and therefore the vaccine is acting with platelet factor 4 to make it a neoantigen, very, very similar to HIT. What's the frequency? Well, Denmark has described 1 in 25,000. Germany originally described 1 in 55,000. In the UK, we are looking from the rates we've got at 1 in 90,000. I suspect as we see more cases, it will become more frequent, and it's probably about 1 in 50,000 because we haven't recognized it all the way through. This is still very rare, and I have to say we have developed very good care. We have reduced the mortality already to about 19-20%. In the UK, the patients are very aware of this. They come to emergency departments with symptoms after AZ. We pick them up early. Healthcare professionals are aware. And the key is to get them to have intravenous gamma globulin and non-heparin-based anticoagulation. So this is going to be an ongoing problem. In the UK, we are setting a ceiling of vaccination for AstraZeneca at the age of 40. If you're under 40, you get another vaccine, because the benefits of the vaccine only exist for the over 40s and low prevalences of COVID, because the chances of admission to critical care are very low. However, in areas of high COVID prevalence, such as Germany and Canada, where we've got very high rates of admission to critical care, everyone should receive AstraZeneca. And paradoxically, Germany and Canada started off by not giving AstraZeneca to young people, and now they're giving it to everybody. So thank you very much. I've told you COVID-19 gives you the most prothrombotic state with any viral illness. Thromboprophylaxis, we should be using standard doses. I haven't had time to talk to you about the effect of lockdown on the rates of VTE. I've told you about vaccine-associated thrombosis, and I haven't had a chance to talk about post-COVID, but not enough time. Thank you.
Thank you very much, Bidali, for your excellent presentation, very nice presentation. I think that we can open the discussion. I would start with Susanna. Someone asked the question about aspirin in cardiomyopathy, or I would say involvement of the heart in COVID-19 patients. What do you think, Susanna, about aspirin? Do you recommend to use aspirin if you have some sign of ischemic or ischemic-like cardiomyopathy?
No, I think the recommendations for the use of aspirin have to stay with those that have been evidence-based over the decades. I don't think we should be taking knee-jerk reactions without the evidence to back it up. I know that irrespective of the pandemic, there's a lot of questions being raised as to whether aspirin should continue to be the first choice of antiplatelet agent in patients with coronary disease. But I would always urge against knee-jerk reactions and changing practice. You've got huge amounts of evidence for what you should do in patients with STEMI, non-STEMI, ischemic heart disease, stents, and we shouldn't be changing them without the evidence.
Okay, of course. Thank you. I have a personal question about myocardiopathy in COVID-19. You know, in children, we can have some cardiomyopathy post-COVID-19. It is more or less like the Kawasaki syndrome. In these situations, physicians give IVIG, and with good results. So what do you think about this in adults? Are there some papers? Is there some evidence?
So I think the pediatric manifestations of COVID-19 are very, very different from what we see in adults. So if we're talking about adults, there was an enthusiasm early on in the pandemic to recognize every kind of myocardial dysfunction as acute myocarditis. And the data that have come from every study so far have said, no, actually, well, they don't meet the criteria that are laid out. Either they be MRI or they be biopsy criteria. So it's acute myocardial dysfunction in the context of COVID-19 infection, either acute or down the line. And at the moment, the recommendations from our experts in acute myocarditis are not recommending that we do anything unless we have proven that it is an acute myocarditis with viral infection, and then it should be discussed on a patient-by-patient basis. But just because you see a patient with acute LV dysfunction that may be pretty catastrophic, it is not recommended that you treat them with IVIG. You actually need to work out what's going on with that patient. And even then, if you have evidence of an acute myocarditis, the evidence that giving IVIG to reverse the myocardial dysfunction isn't that robust to date.
Okay, thank you very much. And how to establish the diagnosis of COVID-19 cardiomyopathy? Do you recommend to do MRI or echo is enough?
Well, when they're acutely unwell, I think you have to, it's very difficult to, it's very difficult to MRI somebody who's critically unwell, tubed and ventilated on an ICU. The studies that have been done to date have all looked at post-recovery cardiac MRI. And the latest one, the one that came out of the UK, looked at a combination of acute, there have been some, sorry, not that one, looked at acute echo and late CMR. So I don't think, practically speaking, looking at the stretch on, there's what you'd like to do in a perfect world, and there's the reality of critical care in a COVID pandemic. I think people were so stretched to even get echocardiograms done when their ICUs are so full and interpreted and acted upon. The extra resource to take people to do an acute CMR, and how much is that going to change what you do? Probably not very much. So I think echocardiography acutely has to be the thing. And what we will learn from the studies that are emerging is who needs follow-up, what should that follow-up be, how many patients need an MRI, and then what are you going to do with the information that you get from your MRI. So we're just at the beginning to explore the size of the problem stage of where we are with post-COVID-19 and the heart.
Good afternoon, Professor Hunt, and good afternoon, Professor Price, and congratulations for the wonderful talks. I think it's time now to invite Dr. Segun Olunsanya, our media commentator, to join the podium. Good afternoon, and I think that we have burning questions to both our two speakers. So please.
Good afternoon, both, and thanks very much for the excellent presentations. So far, there's not been that many questions from social media, so I will fill it with one of my own. And I hope it's okay for me to ask each of you a question. So I'll start with Susanna. So the question that I have for you is that you discussed the paper that was published last year showing persistent myocardial damage on MRI in athletes. I think that was a recent paper published by some colleagues in BART that suggested that that may not actually be a thing, and I was just wondering if you had any comments on that.
Sagan, the paper I presented was not the athletes one. The paper I presented was the one from the Royal Free that looked at patients who had COVID-19 who were admitted, had troponin rise, and a third of whom were ventilated. So these were not healthy athletes who'd had a bit of COVID-19. They'd had evidence of myocardial damage. So I think that it's very, if you take fit healthy people and you put in the MRI scanner randomly, you're going to find some people have abnormalities. The question is, what does that mean? What is an athlete's heart? And if you take athlete's heart outside of COVID-19, what does that look like? So there was a big discussion about that. What this paper shows is that of the patients, it was nearly 150 patients who had been admitted with COVID-19 and with a troponin rise. So they had both. A third of whom were ventilated. In those patients, 54% of them had abnormalities on MRI that were suggested of either myocarditis or ischemia, infarction, or both. So it was not fit, healthy athletes who just happened to have a bit of COVID-19.
Oh, that's fantastic. Thanks very much for that. And then a question to you, Beverly. You've presented lots of data showing essentially heterogeneity of treatment effect of heparin in the critically unwell COVID-19 patient, or in COVID-19 patients admitted to hospital, with some evidence of harm in critically unwell, some evidence of benefit in people who aren't in ICU. What should we actually do?
We should go back to using standard thromboprophylaxis in the critically ill, and we should use full dose in patients who are admitted and only need supplementary oxygen. And give it to them at the same time as they're getting dexamethasone. I think it's I think it's mainly an anti-inflammatory effect, and if they deteriorate on dexamethasone and heparin, then it's difficult. They're a different group, but that's not for me to answer, I think.
Thank you very much. I think there is so much to say on the disconnect between microvascular thrombosis and whether it's a therapeutic target or not, and about the phenotypes of patients who are able to develop a cardiovascular injury, and all the different things that you really wonderfully presented. Maurizio Cecconi, our president, do you have a burning question maybe? And Jean-Louis, another last question? Maurizio?
Yes, first of all, thank you for the wonderful presentations. Maybe a provocative question to the panel. We've never studied a disease like COVID-19. If we go and look at our patients with sepsis in our intensive care unit, and we start to look more and more, would we find maybe the similar rates of thrombosis, of septic cardiomyopathy? I don't know who wants to start with the answer.
I think that you won't find as much microvascular thrombosis in the lungs in patients who are septic as you will with COVID-19. But I think you make a very good point that now we have different tools. We should be thinking about sepsis in a different way, and maybe measuring D-dimers more closely and looking at them more closely. So that's a good plan. I'm going to take that away and think about that. Thank you.
Eli, if you permit, I have another question, a last question maybe.
Of course.
To Beverly, about the association, the combination of dexamethasone and heparin. What do you think about this referring to the antithrombotic effect?
So, I mean, if you use steroids, they switch off fibrinolysis, but they don't have too many prothrombotic effects otherwise. So I think that heparin, having an anti-complement effect, among other things, is a good partner for steroids. And I think that's what the message of the REMAP-CAP studies and the recovery trial are telling us.
On va essayer de gagner 5 minutes. I think it's time now to close the session and to thank the excellent speaker, moderator, as well as the media intervener. And we have learned a lot, not only that everything is not a therapeutic target, but also that maybe we were thinking that COVID-19 was a so different disease, where it's maybe more like other disease that we are used to see in the ICU, like classic RDS or classic sepsis. So thank you very much, and we are very happy to move to the next session. Good afternoon and good forward to this LIVES COVID-19 ESICM webinar.
Well, everyone has heard about long COVID and the long-term effects about COVID. Actually, we talked about long-term effects of sepsis or critical illness for a long time in the intensive care, so this session is going to be about the long-term effects of COVID. It's a great pleasure to introduce the moderator of this session, Professor Joseph Keseshoglu. He's a friend, he's the immediate past president of the society. Hi, Joseph. How are you, Joseph?
Hello, Maurizio. How are you?
We're very good. I was saying we've all learned to learn your background and the background of your house, from which you've been leading the society at the beginning of the crisis and for many months. And thank you for what you've done for all of us.
Well, slowly the flowers are coming. Nice to meet you all in the European Society of Intensive Care Medicine COVID-19 Marathon. And in this session, we have two speakers. I would like to present first the first speaker. Her presentation is Long-Term Effects of COVID-19 ARDS. Margaret Herridge. Margaret Herridge is Professor of Medicine, Critical Care and Pulmonary Medicine at the University of Toronto Health Network, Senior Scientist at the Toronto General Hospital Research Institute, and Director of Research for the Interdepartmental Division of Critical Care Medicine in the University of Toronto. Margaret, please.
Thank you, Joseph, and nice to see everyone. And thank you for the great honor of speaking as part of the ESICM Marathon today. I'm very honored. I'm going to talk about the long-term effects of COVID-19 ARDS. I have no conflict of interest to declare, and I have no relationship with industry. My brief overview is I'm going to chat first about the ARDS outcomes literature, just to frame the emerging data on COVID-19 outcomes, including functional disability, brain injury, neurocognition, mood disorders, the construct of PICS, and the extended construct of PICS, that is including frailty, multimorbidities, and then reviewing a bit more literature that's emerging now on the post-COVID-19 condition, and really focused on the emerging data. Just to begin, this is a nice schematic from a recent review from Michael Mathey, published in Nature Reviews, showing the complexity of factors, the complex pathophysiology involved in severe lung injury, or ARDS. And a radiograph on the right that's all too familiar now to all of us working in the ICUs around the world. There's no question that there's been a very long and storied literature on ARDS. Emerging after the initial description by Ashbaugh, Petty, and others, focused mainly on pulmonary outcomes. And those pulmonary outcomes varied, but emerging from that pulmonary-based literature, a literature based in function and quality of life. And some of these early papers led by Lynn Gross, work from Len Hudson's group, Craig Weiner, Tim Davidson, Ellen Caldwell, Randy Curtis, Len Hudson, Ken Steinberg, many European colleagues, Richard Griffiths, Christina Jones, many Europeans, all understanding that ARDS is not solely a pulmonary issue, but actually a multidimensional issue resulting in decreased quality of life. Our own group across the University of Toronto looked at survivors of very severe ARDS. These were younger patients in their early 40s. They had 4-quadrant airspace changes. This cohort that was done many years ago would fulfill the moderate to severe Berlin definition criteria of ARDS. They were very sick. 40% of this cohort died in the ICU and had persistent disability. Pulmonary function largely became normal or near normal in those who survived, but the lasting legacy of this was functional disability, and measured as distance walked in 6 minutes, the PCS of the SF-36, and a loss in weight, which correlated to a loss of lean muscle mass. The literature after this, and seminal papers from Sandy Levine, Zudin Puthacheri, Nick Hart, Steve Harridge, Hugh Montgomery, and more recent data from our own group, and not my group, but Ewan Gallagher's group in Toronto, Mike Sklar's paper here, showing diaphragmatic proteolysis, and also proteolysis of the muscles of the axial skeleton. And this being one of the major morbidities after ARDS, and leading to the construct of ICU-acquired weakness. ICU-acquired weakness here as a myosin depletion myopathy and an axonopathy. And important early contributors to the definitional construct here of ICU-acquired weakness, Nicola Latronico, Bernard de Jong, Robert Stevens, and this nice New England Journal review led by Jesse Hall and J.P. Kress. Just to further set the stage, we have important neurocognitive outcomes work from Mona Hopkins early on in 1999, and many people building on that work, showing important brain injury, age-inappropriate neuronal dropout, and cortical loss. And the duration of delirium, here as a potent risk factor from seminal work published by Pradip Pandarapandi, Wasili, and many others from the Vanderbilt group, as a major risk factor for long-term cognition on the order of mild Alzheimer type dementia or moderate TBI. And some further work here reinforcing this message from Mark Michelson and others, and more recent work from Jim Jackson highlighting not only the neurocognition, but also the mood disorder mood disorder legacy of ARDS and severe critical illness. All leading to really a multi-dimensional construct summarized so nicely by Dale Needham in the post-intensive care syndrome schematic here, and highlighting really the functional neurocognitive dysfunction, both for patients and the mood disorders experienced by family. And the most recent extension of this, led by Drs. Rousseau and Jean-Charles Prisset, published in Critical Care, the concept of an extended PICS. There's so many dimensions that can be affected, including frailty, multimorbidities, many of which we've described in our own Recover program. So I want to turn now with that background, very brief background, to COVID-19. COVID-19 is a multi-organ dysfunction syndrome. It is not ours in isolation, and I think this is such an important piece to discuss. The ACE2 receptor expression across multiple organ systems, and we all understand this now as clinicians in our own ICUs, makes this a very complex constellation of organ dysfunction, some of which is recognizable in ARDS, some of which is novel. In terms of some of the cardiac dysfunction we've seen, the arrhythmias, the acute coronary syndromes, the myocarditis, the pericarditis, and also some of the renal dysfunction, which John Prohl is going to discuss in more detail. And also the extraordinary coagulation derangements, both in terms of bleeding and thrombosis that we are seeing, and all of the sequelae of that. I want to turn now to the expanding our understanding of the post-COVID-19 condition, and really moving now toward evaluating the long-term sequelae of COVID. Many of our community have been involved in this WHO exercise with some of our other national or international agencies, trying to understand what the post-COVID-19 conditions look like. What are the sequelae of this, and how should they be categorized? Should they be categorized phenotypically by organ system or clusters of symptoms? Or do we need to really understand phenotypes based on distinct pathophysiologic mechanisms that are still under investigation and emerging? There is a bit of a challenge with the current taxonomy of the post-COVID state, or the WHO term post-COVID-19 condition, and many different terms applied to this across the CDC, across the NIH, across the NHS, and this post-COVID-19 condition that I've indicated is what the WHO is putting forward as a unifying terminology. So I want to review now in the next few minutes but unfortunately I don't have time to review all of the literature. I've tried to select papers so that we're looking across the international spectrum. Excuse me. And here's a very nice paper led by Otávio Ranzani and Fernando Boza from Brazil. I think it's an important paper highlighting a number of things. First of all, this is a very large sample. You can see here their ICU admission proportion is very high at 39%. Their ICU mortality also very high at 55%. They're able to highlight many of the challenges that have gone on and continue to go on across the world in terms of managing critically ill patients outside of a formally designated ICU. As well, they were really able to look at the factors influencing in-hospital mortality, stratified by age in terms of sex, burden of comorbid illness, level of education, racial groups, whether people were in the ICU or not, and how they were mechanically ventilated. And I think this highlights such important issues because, of course, COVID-19 isn't just a disease, it's a disease in a different healthcare context around the world. These have their own social constructs as well. Here's an important paper from the Comeback Group. And these authors were able to look at many outcome measures that I've already outlined in the general ARDS literature. Interestingly, and I focus your attention on the final column of intubated patients. These post-ICU patients tend to have fewer symptoms in terms of persistent cough, still a decrease in, and actually a fairly, the intubated and non-intubated, a fairly similar 6-minute walk distance. Important changes on CT scan findings. And in terms of ground glass opacifications, these are findings from 4 months. One might expect that some of those ground glass opacifications might continue to resolve over time, but we will see. Some evidence of lung fibrotic lesions. The FEV1 not wholly severely compromised, FEV1 FVC ratio similarly, TLC perhaps some mild restrictive physiology and a reduction in the DCO. Like other groups and like the ARDS literature, challenges with cognition, with mood disorders of anxiety, depression, sleep disorders, also very prevalent in the post-ARDS patients, and PTSD. These data are from Dr. Chopra and Hallie Prescott from Michigan. And I show you these data. These are short-term data, 60-day outcomes, to indicate that many of these patients are re-hospitalized. So we have to think now about the continuum of care, healthcare utilization and resources now for this post-COVID-19 condition. We have a new public health issue looming. Again, challenges with return to normal activity, the emotional impacts, and here in this US study, the impacts on finances, that a very large proportion indicated they were moderately financially affected. Now, this very important paper from Wuhan, the senior author here, Bin Cao, the first author, Xiaolin Huang, again casts some very important data, very important insights into this emerging dialogue on outcomes. You see that most of the patients in their study had symptoms of some type. In their more severely ill group patient population, here in the final column on the right, scale 5 to 6, those on high flow nasal cannula, non-invasive ventilation, invasive mechanical ventilation, the most prevalent symptom was weakness, echoing some of the ARDS literature findings. They also had detailed pulmonary function data. Here at 6 months now, they continued to show some changes in spirometry and some restrictive physiology as well, whether related to resolving GGOs, ground glass opacifications, or perhaps even resolving diaphragmatic weakness that I alluded to at the beginning, and imaging changes as well. They also were able to show some challenges with mobility, challenges with activities of daily living, pain or discomfort, again, mood disorders here in this right-hand column, impairments of quality of life as a result, some impairments in distance walked in 6 minutes, where they had an important proportion in the critically ill patients that were less than the lower limit of the normal range. They were also able to show that there was a change in the GFR in these patients. That's also been shown in critically ill patients in general as well. These data from Brenda Poon, from Wes Seeley, Pradip Pandurpandi, Nathan Brummel, Tim Gerard, and the Vanderbilt group, who are world leaders in delirium and cognitive outcomes, is very instructive. We've all struggled with managing delirium in our critically ill COVID-19 patients, struggling with the polypharmacy that we're exposing them to because they've been so difficult to manage. And here's a wonderful, some wonderful insights showing how delirium is related to these continuous sedation infusions, continuous narcotic infusions, and importantly, mitigated by visitation from family or friends. These patients are so isolated in our ICUs, and this is not only just a tragedy, a human tragedy, it's also having an enormous impact on delirium, and one might hypothesize long-term cognitive dysfunction. So they very nicely outlined in this paper, Dr. Poon, that benzodiazepine use and lack of family visitation here, among others, are modifiable risk factors for delirium. My final thoughts, and I show here our own logo for our Canadian COVID-19 follow-up program led by Dr. Angela Chung and myself, so hopefully we'll be able to contribute Canadian data to this emerging international picture soon. That I think it's important to remember that COVID-19 is indeed a multi-system disease and has, in fact, an unknown still long-term outcome trajectory. We have some clearly emerging similarities to ARDS. I've tried to outline those here, but there will be clear differences, and we need to really be open to those. The challenge for us who do critical care and ICU outcomes is to try to delineate what's related to ARDS, what's related to critical illness and all of its complexities, and what's actually related to COVID-19 or the interaction or intersection of all of these factors. The early pulmonary and extrapulmonary sequelae do appear to be similar to the PICS and extended PICS definitions, but definitely require further granular study and data sets. Some important barriers right now are based in nomenclature, finding a common definition of the post-COVID-19 condition, adopting robust core outcome sets, engaging in a lot of translational work so we really understand multi-omics and genetics constructs that relate to these outcomes and long-term sequelae, international comparative studies, and inclusivity. We make sure that we understand what happened to everyone across multiple groups, and in particular vulnerable populations who often are not included in studies, like children, pregnant women, and others. So thank you very much again for the opportunity to contribute this talk and to be part of this wonderful ESICM Marathon today. Thank you.
Thank you very much, Margaret. I would like to announce the next speaker now, John Prawley from London. John Prawley is a senior clinical lecturer in intensive care medicine within the critical care and perioperative medicine research group at Barts and the London School of Medicine and Dentistry, Queen Mary University of London, and is an honorary consultant physician in intensive care medicine and nephrology at the Royal London Hospital, Barts Health NIH Trust. The title of the presentation of John is Long-Term Effects of COVID-19 in Acute Kidney Injury. What's ahead? John, please.
Thank you very much, Joseph. I hope everybody can see my screen share, so I'll move on with my talk directly. And I think this is a great follow-up to Margaret's lovely overview of the settings in COVID-19. I'll just make sure my face comes into the screen for you. Let me just advance my slides. So I have some disclosures, none of which are directly relevant to this presentation. I will move straight on to really talk about acute kidney injury and COVID-19 to provide some context here. And really, there's been a lot of publications about AKI and COVID-19, and a lot of data has been generated. And it's clearly a common and important complication of COVID-19 disease in general, and in particular COVID-19 disease requiring critical care admission. However, the sort of plethora of information we have available has sort of demonstrated that we need to understand its risk factors and particularly its outcomes much, much better. Certainly early in the pandemic, the best data came out of some reports from New York hospitals where a significant minority of patients developed AKI, but a large majority of patients admitted to the intensive care unit and a significant portion required renal replacement therapy. And indeed, in the UK, 27% of patients in the first wave required some form of kidney replacement or renal replacement therapy in the ICU. And this group had a substantial mortality, and the mortality was synergistic with other organ dysfunctions. So this is some of the data from another study in New York, and really it makes a good comparison with non-COVID patients and with patients admitted to the ICU in the preceding pre-COVID period, that there was a significantly greater incidence of acute kidney injury in the COVID patients and a significantly greater need for renal replacement therapy overall. It's interesting here then to reflect on how these patients recovered after severe acute kidney injury, and the kind of lower rate of overall RRT dependence is confounded by the significantly higher rate of death. So overall, in fact, there was as big or if not larger amount of RRT dependence in ICU survivors. And of course, many more people were dying who might have ended up on RRT if they'd otherwise survived. So clearly a very serious condition, but one that needs better characterization. This is the other large New York study. It just really makes the point that while when patients left hospital, a majority appeared to have recovery of renal function, we're going to go into that a little bit later, there was a substantial minority who still had significant de novo renal dysfunction at the point of hospital discharge. And really, we need to know what's happening to this group, what the implications are for their long-term health, and also if these people in the blue here really are in the safe zone or not. This is another large study from the United States, and this is just looking at patients who required renal replacement therapy in the ICU. And it really makes the point that a third of patients with remaining RRT dependent after AKI on hospital discharge, and that's a high proportion, and it's a very significant ongoing burden for healthcare systems and, of course, for patients. So just moving on to outcomes after AKI in general, clearly the outcome after AKI that we're most fixated on is the development of some form of chronic kidney disease. But chronic kidney disease is really an important crossroads, because depending on your kind of overall physiological stability, its severity, and your life left to lead, your outcome may be towards death, particularly cardiovascular mortality, but also increased mortality for a range of other causes of death, including infection and the malignancy, or the risk of end-stage kidney disease with all of the attendant effects on personal health and the health economic consequences of it. This is a well understood interrelationship that was elegantly reviewed some years back. Really, the worry is that we have maladaptive repair and scarring in the kidney. This leads to interstitial fibrosis and all the features of chronic kidney disease. But of course, chronic kidney disease itself is a potent risk factor for further acute kidney injury, and patients develop a vicious cycle of recurrent episodes of acute kidney injury and ill health. And at some point, you fall out of this cycle, either in terms of death or end-stage renal failure. This is population data from the US, very well known to all nephrologists, but it's extremely important. The severity of your chronic kidney disease is directly related in terms of GFR to all kinds of adverse events, including cardiovascular mortality and progressive CKD, but also, and particularly importantly, because I won't have time to mention it further, proteinuria is as important an index of the severity of your chronic kidney disease as GFR is, until you get to very low levels of GFR. And really, more severe proteinuria is an unlooked for outcome or metric in patients who've left ICU, but is really extremely potent. And here's the other thing that I've alluded to earlier. CKD itself is a very potent risk factor for further episodes of acute kidney injury, which then will themselves lead to further CKD. Right. The other thing that we should mention is obviously AKI is defined within a 7-day window. CKD is defined after 90 days. In the in-between, we've invented this concept of acute kidney disease, which we try and use to sort of glue these two parts of the car back together again. This is a rather imperfect concept, but it's an indication of persistent kidney dysfunction. But it's very important that we kind of look at what happens to patients after AKI to determine their trajectory, because CKD may not be overt until they are well out of hospital. And we know in the context of other forms of critical illness, and particularly in sepsis, that the pattern you have after AKI in terms of your degree of recovery or whether you have relapse is a strong determinant of your survival outcome and presumably other outcomes. And it's going to be very important to look at this in the COVID AKI patients. So leaping on to my personal experience a little bit and outcomes. This is the Royal London Hospital where I work. This is one of our purpose-built COVID ICU bays. The peak of the second wave, we had 8 of these fully occupied with mechanically ventilated patients, all identical areas, and there was plenty of renal replacement therapy performed. Just to talk about renal replacement therapy a little bit, because it's very important when you think about outcomes. These patients are not like our standard patients pre-COVID. The duration of renal replacement therapy they're requiring, both in those who died and survived, was dramatically longer, and therefore their renal outcomes a lot more uncertain. Now, many patients still recovered renal function, and of those who were discharged from dialysis, many of them have come off, but that may just be a holiday off dialysis and not lifelong kidney health. This is our local data. Many others have published their local data. This analysis was a little bit focused on ethnicity, but I won't go into that right now, but though we have a very diverse population. We looked at 25% incidence of AKI in hospitalized patients, really proportionally more severe AKI than you'd expect overall. Strong association with risk of death. But we also looked at those who survived set to 7 days. So they come to the end of their AKI episode. And really, outcomes in those who'd recovered renal function weren't weren't terrible, but the group with persistent AKI at 7 days had a very, very severe ongoing risk of death. Incidentally, there was also an important group with late AKI who had not had early AKI in their illness, and they also had very poor outcomes, as you might expect. This is some data about the serum creatinines at hospital discharge in this cohort, and it's coloured by AKI severity, and there's the no AKI group in grey here. And it kind of makes the point that actually the overall trend in serum creatinine in terms of those who don't have AKI is for it to fall. And the stage 3 AKIs were discharged hospital with higher serum creatinines than they had to begin with, and those with less severe AKI were in the middle. But actually the overall direction of the wind is for a falling creatinine. It really makes the point, and I'll go into again, that assessing the renal function in these AKI survivors is really impossible on the basis of serum creatinine because of the confounding effects of their severe critical illness.
Right.
This is an extremely important paper that's been published from Perry Wilson's group in Connecticut and Rhode Island, looking at a number of patients who survived COVID AKI in hospital and a population of patients with AKI who did not have COVID, and they had post-discharge measurements of creatinine. And here's comparison between the two cohorts. Interestingly, those with COVID AKI actually had better EGFR based on creatinine at hospital discharge, quite substantially, but no difference in urea concentration as another measure of kidney function, and also significantly lower body weight at hospital discharge compared to admission. And they seem to have quite good data on this, suggesting a more significant loss of lean body mass during their critical illness, which of course could confound their measurement of renal function based on serum creatinine. And really, this is the interesting data here. The COVID patients actually had better renal function at baseline. They had more severe AKI, but at discharge, they appear to be more recovered than the non-COVID patients. Even at 3 months, they do, but at 3 to 6 months, they are significantly worse renal function at hospital discharge, at 3 to 6 months after ICU discharge, and indicating that really prolonged follow-up is required to see the outcome in these patients, and also leads to think, why is this effect happening? And they did some multivariate analysis to look at this, looking at the slope of decreasing GFR and helping them to account for whether it was purely due to loss of muscle mass, i.e. the effect of weight, or whether actually there was an acceleration of the underlying CKD. And it appears that both are the case. So obviously the effect of loss of muscle mass will then be ameliorated over time, potentially, leading to a apparent worsening in renal function. But in addition to that, there's an actual worsening in renal function. And these patients at hospital discharge are a perfect storm of having worse underlying kidney function, a more rapid deterioration, and they have significant sarcopenia. This is a picture I've taken from a publicly available news site, but I understand this gentleman was a nurse. He's lost significant amount of weight during his very severe COVID-19 illness. I challenge anybody to accurately assess his renal function compared to baseline based on his serum creatinine, which is a product of muscle mass as well as kidney function. We've published data in other contexts showing the dramatic loss of muscle mass that occurs in ICU from patients with pretty good baselines, and the dramatic falls in serum creatinine that relate to their duration of critical illness that occurs in these patients. This is a nice study I found in the literature from the Netherlands, I think, where they had 24-hour urine collections and measured 24-hour urinary creatinine excretion over time. And you can see that 24-hour urinary creatinine excretion, which is a direct measure of muscle mass, almost halves during the duration, during the progress of a very lengthy ICU illness. Your urea excretion actually increases and then falls back to baseline. And this, of course, is because the patients are in negative nitrogen balance due to catabolism of muscle and the metabolism of protein generating urea. So what do we do instead? Well, we could measure cystatin C, and we've looked at this in a non-ICU cohort in data in collaboration with my friend Max Bell in the Karolinska, and this is his data. But really, cystatin C and creatinine agree very well with EGFR in patients who have only just been in ICU 1 to 2 days. Creatinine dramatically overestimates GFR in patients in prolonged ICU length of stay. We infer this is due to muscle wasting, and is likely cystatin C is a better measure in this population. And indeed, cystatin C has better prediction of risk of death at ICU discharge compared to serum creatinine, where the confounding effects of muscle wasting and CKD preclude it being a good indicator of outcome. Thank you. And so to conclude, AKI is a common complication of COVID-19 and is strongly and proportionally linked to risk of death. Duration of kidney replacement therapy is generally longer in severe AKI and COVID-19 compared to historic controls, and degree of renal recovery is less. However, a majority do appear to recover completely, but that's probably a misnomer. Muscle wasting is likely to be a very significant confounder in the assessment of COVID-19 kidney outcomes. Declining kidney function after hospital discharge seems to be greater after COVID-19 compared to non-COVID AKI. And therefore, really, we need continued follow-up, and alternate markers of kidney function likely to be needed to address this very important population in the future, because there's potentially a very significant public health problem of accelerated chronic kidney disease in these survivors. Thank you very much.
Thank you very much, John. Before going to the social media questions, actually, I have one question to both of you, or any one of you. Especially Margaret, you have mentioned very well how we have something like 50 years behind us after the first modern description of ARDS. And these 50 years has shown us many, many things. What we have done in the first instances that we don't do it anymore, or we saw that we were not on the right track, and it took us so many years, while the longest follow-up now of the patients is a couple of months, which you also very nicely stated that we may see completely different things on the long term. Maybe we are really looking at the Pandora's box at this moment, and we don't know what will come in 10 or 15 years of time. But I mean, either Margaret or John, if you look at what we are doing to our patients now, do you have any indication, any potential things that you think we are doing this really very much a little bit with our feelings? Maybe we will do things very, very differently in the coming 10 years. Can you give an indication on that? I mean, one of the things that I can think of is the coagulation treatment, the anticoagulants that we are using. I mean, I wouldn't be surprised if 5 years later we will be using something completely different, another scheme or something like that, another doses. But just from mechanical ventilation part, acute kidney injury part.
Thanks very much, Joseph. I think those are all really important points. I'll just speak briefly, as I'd love to hear what John has to say about this as well. I think my overarching comment would be this, and I say this as a researcher, but also we've all been at the bedside a lot as clinicians these days. I think these patients have been so challenging to manage that it has led to an abandonment of many of the tenets of care that we've spent so much time understanding and adopting. And I think that, the de-adoption of the ABC DEF bundle components, the de-adoption of wakefulness, the de-adoption of early mobility, and the adoption in Brenda Poon's paper that I showed of all these continuous infusions of polypharmacy. I think it speaks to the severity of illness, but my goodness, every time I'm attending, I am overwhelmed by concern about what this is, the effect this is having on my patients. I'd be interested to hear John's thoughts as well on that. Thank you, Joseph.
I would say I completely agree that we were had to tear up the playbook, and we adopted a number of different approaches, some of which were we had no option to avoid, or at least we thought at the time. And this developed a number of other significant issues. And I remember with my renal hat on, some of the patients we sent off having recovered from other aspects of COVID to the ward on dialysis. My colleagues in renal medicine going, this man's completely mad and he's just impossible to control. And I said, almost certainly this is just the after effects of the massive amounts of sedation he has in somebody who has not yet recovered renal function. And actually all we need to do is wait for 2 weeks, and eventually, that peak of toxemia is going to be past, iatrogenic effects is going to be past. It's this manage of the tail end effects of the severity of the interventions we've needed to give is terrifically difficult. In terms of things that have changed, I think that we need better sort of diagnostic methodologies to assess these patients. Now, I'm not talking necessarily about, acute kidney injury biomarkers and things like that. I think the front end is actually a little bit easier to deal with. I think better methods of assessing long-term organ injury after illness, and that's organ injury in the kidney, which may actually be relatively easy to assess in some ways. I mean, there's many things we don't do, like measure proteinuria, that we definitely should do, but it's also the effects of organ injury on the lung that may not be overt. Do we have better imaging methodologies to look at that as people leave the ICU? How do we better assess cognitive effects on these patients in order to better tailor treatments to their needs? And so, I think we owe it as intensivists who've worked so hard to make these people survive to better assess their health as they leave ICU and the hospital, and enable the physicians who are going to continue looking after them throughout the rest of their lives to understand the problems they have, and indeed, and most importantly, the patients to understand the problems that they have and how best to rehabilitate from those.
Thank you, John. Thank you, Margaret. I would like to give the word back to Maurizio.
Thank you for a great question, Joseph, and fantastic insights. Maybe we can bring on stage Silvia Calvino Gunter. She is a nurse instructor at the Grenoble Alpes University Hospital in France, and she is the social media moderator for this question. Hello, Silvia, how are you?
Hi, can you hear me?
We can hear you very well. How are you? Welcome.
Okay, fine. So I have some questions for both of our speakers. First one is, would you be giving prolonged steroid for prevention of lung fibrosis post-COVID?
Mm.
And are there any other interventions that can be done to prevent long-term lung sequelae?
Thanks so much for those questions. I think that my own feelings would always be or my own comments would always be to try to go back to the literature. I think the literature on steroids in prolonged ARDS is still equivocal. Having said that, I personally, in the right situation where people still have a very important burden in the ICU of organizing pneumonia, I have used steroids, and I have used them as per some of the published protocols. So I think there may be a role for that. I'm not sure a routine role, because as I state, the data on that is equivocal. In terms of other interventions to try to mitigate the pulmonary dysfunction, I think that's a little bit trickier. I think that many folks who do basic work in this area feel that there are a lot of innate issues related to healing and fibrosis that may be more host related, and why some patients have a remarkable recovery in their organizing pneumonia after ARDS, and others less so. And I would just finally state that lung protective ventilation and all of the robust literature in that context, paying strict attention to driving pressures, P-plots, tidal volumes, high PEEP strategies, extremely important underpinning to try to mitigate upfront some of this injury to the lung. Thank you.
John?
Okay, and I still have two questions. So the first one is about the kidneys. Are they the target or just collateral damage in COVID?
So I think the implication of the question is to what extent is viral infection of the kidney important? And I think that viral infection of the kidney has been detected both in tubules and potentially in the glomerulus, but it is of uncertain significance. The majority of the biopsy studies have suggested that this is sort of more classical acute tubular injury, but it's actually of the more severe variety. Most patients in the ICU who have acute kidney injury in terms of sepsis would have a pretty clean renal biopsy and perhaps with a degree of functional tubular dysfunction. And the pattern in COVID-19 is more severe. Again, the involvement of thrombotic microangiopathy has been speculated but not really well proven. So overall, it seems to be a more severe a bystander effect of the severity of illness, but it then has a very important feedback modifying effect on other organ dysfunctions, and particularly pulmonary dysfunction.
I think our President-elect, Elie Azoulay, wants to ask a question or make a comment.
Well, good afternoon, Margaret. Good afternoon, John. I really enjoyed a lot your lectures, and I took notes, and I have many ideas for the future. Well, I have, and I appreciated a lot, Marg, about the research portfolio and all the things that are related to the innate risk and the omics data. And it makes sense, as we know that 10% of the non-severe patients are also going to develop a long COVID. So it makes sense to get interested to what is innate and what is related to the patient themselves. My question to the two of you is about the learning curve. So we have had many different waves, and we have the feeling, for example, that acute kidney injury was far more prevalent for the first patients than what we can see today. And my question, Marg, is also, I believe that when we are following the patients, we have the feeling that those who were managed for the first wave are doing worse than those who were managed in 2021. Maybe they were ventilated less. We learned more about what are the long-term outcomes. We have had the family members inside the ICUs helping us to better care for the patients. So my question to the two of you is, what could be expected if we compare the two waves as regard to the long-term outcomes, not only for the long-term outcomes overall for physical and mental health, as for the acute kidney injury and its sequels?
I don't know, John, I started last time, if you want to
No,
start,
I'll
and then
start.
I'm happy to make comments.
I think overall,
Thank you,
looking at the
Emily.
data, it does appear that the outcomes in the second wave were better, even when adjusting for differences in the case mix, which were quite substantial. The second wave patients in the UK were quite relatively younger than the first wave patients. We had much more sort of working age people with less comorbidity in the second wave. But irrespective of those changes, the outcomes were better. But this is going to be a cohort who perhaps have more long-term burden of disease because they are younger, they have more life years to lead, and were previously healthy. In terms of learning, I think that really what we've learned in the second wave was about processes and logistics of ICU care, about actually delivering the right people to the right patient in the right place. And it was all so much more efficient, and we dealt with more patients with much better delivery of care. But what we've then got to do is we've kind of learned that lesson. Now we've got to make the next leap to actually joining up and making the ongoing care of these patients better. I don't think we've yet achieved that.
Yeah, thanks for those great comments, John. I guess I would just add to learnings, Ellie, and thanks for those questions. I think I think I would just make a more global comment about making sure we go to the data to understand what, if what we see is consistent with what the data show. And also to really make sure that we study the individual waves and the processes of care in an international context. I mean, I think this is why the ESICM is so important. I think we really need to understand how healthcare system issues confounded outcome and process of care, access, and really how COVID exposed cracks in each of our systems, that are important learnings, not just for COVID, but for our approach to critically ill patients going forward. I think we're having more families at the bedside now here in Toronto in Wave 3. They're beginning to come back in, and how crucial that is, the impact on communication, the impact on end-of-life care, the impact on delirium, as I was illustrating from Brenda Poon's paper. I think there are just so many learnings, but I think importantly, we need to think internationally, because there are so many ways in which our systems, our varied ethnicities, our very vulnerable populations are key confounders to outcome and how we're going to look after people in the long term.
I like to answer by taking on the challenge. I think that's something that our society has to do, and we have some research ongoing on that. So I would like to thank everyone, the moderators, the speakers, for a fantastic sessions. Also taking the opportunity to remember that when COVID will end, we will still have critical illness, and we cannot forget post-ICU syndromes and long-term outcomes for these patients. So we will have to carry on investing in that. Thank you very much, all.
Thank you.
Thank you. Thank you. Bye-bye.
Bye-bye.
Colleagues, you are joining, you are staying, or you are with us since the beginning. This is the LIVES COVID-19 Worldwide Digital Marathon of the European Society of Intensive Care Medicine, and I'm delighted to introduce Professor Jan de Wel from the Ghent University Hospital. Jan de Wel is Professor of Critical Care, and he is very well known from all of you. He's leading the research at the European Society of Intensive Care Medicine. Very happy to see you, Jan.
Hello, Elie. It's great to be here. How are you today?
Very well, and very happy to be with you, and we are all looking forward to be together face to face, but we can still enjoy today this excellent marathon.
Absolutely. It's really fascinating to see all the knowledge that we are sharing, and it's great to see the role that ESICM plays in this.
So, Jan, are you introducing the first speakers, and we go on with your session?
Absolutely. Our first speaker will be Pedro Povoa. Pedro is a professor of medicine and critical care medicine at the New University of Lisbon and director of the Polyvalent Intensive Care Unit at the São Francisco Xavier Hospital in Lisbon. He's an active member in different societies, and in ESICM, Pedro is the current chair of the infection section. He will be talking on the topic of antibiotics, if and when. Pedro, please.
Thank you very much, Jan, for the introduction, and I want also to send my regards to the audience, to good morning, good afternoon, or good evening, concerning where they are, and also to my friend Gary Falia. It's a pleasure to be with all of you discussing this issue of antimicrobials in COVID-19 patients. And also, I want to congratulate the Society for this initiative and for the invitation. And so in these next 10-15 minutes, I will address the issue of antibiotics if and when. These are my disclosures related to this topic. And why is the reason to make this presentation and to ask me to do this presentation? Because it is very difficult to distinguish a severe COVID pneumonia and infection from other bacterial infections. And so the role of what are the role of antibiotics in COVID-19 patients? And we should not forget that antibiotics are very good drugs, very important medications that change a lot of clinical scenarios, but they have one limitation. They only treat bacterial infections. And for that, we need good antimicrobial stewardship programs. Why? Because we need to try to decrease antimicrobial exposure to reduce the risk of emergence of MDR pathogens that are a huge problem, as you know. We should also promote the optimal use of antimicrobials and only use them in patients with bacterial infections. Those drugs also have toxicity that should be avoided, and we should use them carefully to optimize patient safety and outcomes, and also to protect the patients that are around that patient, because if that patient has an MDR pathogen, it can spread also that MDRs to other patients in the same ward and in the same hospital. In this last 1.5 years, we learned a lot on COVID-19. It is a severe pneumonia with severe inflammatory and other types of lesions on the alveolus and capillary. Other organs are involved, different patterns on the chest X-ray, CT scan, on ultrasound, also changes in different commonly used biomarkers, cytokines, coagulation, lots of different things, but nothing is truly specific of COVID-19 that could for sure to us clinicians at bedside to say if this patient has only a viral infection or also a bacterial infection at the same time. So concerning the ifs and whens, we have two ifs and whens in patients in the ICU. We have one when at ICU admission and if the patient has or not a bacterial co-infection, and the other one is during the ICU stay if the patient has an ICU-acquired infection. Let's start with the first one, and if there is a co-infection. And the early data in February, March, April last year, the data was very limited. And as I just said, the diagnosis between the viral infection and the bacterial co-infection is very challenging because of the clinical, radiological, and lab manifestations. And we knew from previous data from influenza that bacterial co-infection in influenza pneumonia was quite frequent, between 11 and 23%. In MERS-CoV, apart from the bacterial co-infection, there is also a significant rate of viral co-infection. And some early data on SARS-CoV-2 infection, it seems that it was quite frequent. Almost 1/3 of the patients has a bacterial co-infection. And because of that, and to be on the prudent side, the recommendations of the early recommendations of Survival campaign were that in mechanical ventilated patients with COVID-19 and respiratory failure, we suggest using empiric antimicrobials or antibacterial agents over no antimicrobials. And maybe this was one of the reasons, not the only one, that almost all patients in the ICU in the beginning received antimicrobials, antibiotics, and also because we didn't know the disease well and we were quite stressed with the possibility of missing a bacterial infection. And with the data coming on, this is a paper and then also a website where they have accumulated lots of different studies. We now know that the bacterial co-infection is not that frequent, and also but the bacterial infections are much more frequent. And currently, this has 35 studies, more than 7,000 patients, and the rate of bacterial co-infection in hospitalized patients is below 5%, but in patients in the ICU was a little bit higher, around 16%. However, almost more than 70% of the patients received antibiotics. This is a pre-planned study of study that was designed to assess the incidence of ventilator-associated lower respiratory tract infection that we made with Southern Syria, Ignacio Martinez, the COVID study. And in this pre-planned study, we assessed the prevalence of bacterial co-infection in patients with SARS-CoV and influenza. We assessed more than 1,000 patients, 568 with SARS-CoV, 482 with influenza. And in our group, the rate of bacterial co-infection in the SARS-CoV-2 patients was below 10%, 58% with gram-positives, but almost 90% of the patients receive antibiotic at ICU admission. And comparing to influenza, influenza has more than 3 times the rate of bacterial co-infection at admission, 72% gram-positive, and the same rate of antibiotics at admission. We then look at the cumulative mortality of these 4 groups: patients with SARS-CoV with and without co-infection, influenza with and without co-infection. And in the preliminary analysis, it seems that the patients with SARS-CoV and co-infection have a higher mortality, but again, after assessing for the heterogeneity between outcomes of these 4 groups, the difference was not significantly different. We also assessed the impact on the prescription of antibiotics in patients with and without antibiotics at admission, and there was no impact on outcome. And again, that assessing the heterogeneity of the outcomes, no difference in these outcomes prescribing or not antibiotics. And so our conclusion, maybe we should be more rational using early empiric antibiotic treatment in these patients with SARS-CoV infection, maybe limiting to the more severe patient with ARDS and shock, and obviously not guided by proactive diagnostic strategy and prompt escalation. And this is our data from our patients in my ICU, where we treated in the last year 192 patients, and this is just an analysis of the first 110 patients between March and September, where 52 received antibiotics at admission and 58 no antibiotic. The rate of co-infection, bacterial co-infection, was 7%. And this is the cumulative number of patients where we give antibiotics at the admission. And as you can see in the beginning, we give antibiotics to almost 100% of the patients. But after a certain time, we begin to notice that the rate of bacterial co-infection was quite low, and we were not prescribing that frequently. And comparing the mortality in this Kaplan-Meier curve, comparing those that we prescribe antibiotics versus no antibiotic at ICU admission, there was no difference in mortality. And this paper, a position paper on antibiotic stewardship in COVID-19 from Jan, again comes back again to this division between the patients according to the severity. And if the patient is not in septic shock, no focal infiltrates, and maybe no ARDS, maybe we could not prescribing antibiotics with a watchful waiting, and I would add vigilant monitoring, do sampling of the patient, look at the biomarkers, consider rapid diagnostic tests, and then reassess. And those that have those severity markers like septic shock, focal consolidation, and ARDS start, sample the patients also, treat according to CAP or AP guidelines, and then reassess the patient. And I would add here, according to the clinical course, if the cultures are negative, maybe consider stopping antibiotics. The other issue, the other one is during the ICU stay. And again, there is a huge variation in the rate of ICU-acquired bacterial infection between 13% and 80% in the VAP patients under ECMO. As I just said, we made this study, the COVID, to assess the incidence of ventilator-associated lower respiratory infection in patients with SARS-CoV, influenza, and no viral infection. More than 1,500 patients that we include in the study, 568 SARS-CoV-2, 482 influenza, and 5 526 no viral pneumonia. And the rate of ventilator-associated lower respiratory infection was 50.5% in patients with SARS-CoV, VAP 36.1%. And in the other groups, influenza was lower and VAP 22.2%, and no viral infection, VA lower respiratory tract infection 25.3%, and VAP 16.5%. And we then try to assess the impact of this infection on outcome. And it seems that VA lower respiratory infection has an impact, a marginal impact on outcome in patients with SARS-CoV, but again, assessing for the heterogeneity of outcomes between these groups, it lost significance. And the same was true with VAP, with a marginal significant, but again, assessing for heterogeneity outcomes, losing the significant difference between these three groups. This is also a French study, from the Outcome REA network, where they assessed the ICU-acquired bloodstream infections in COVID and non-COVID patients. They assessed 321 patients with COVID and more than 1,000 controls, looking at the bloodstream infections, and these were much more frequent in patients with COVID-19, 14.9 versus 3.4%. And those that receive tocilizumab and anakire have a higher risk of BSI, and with a significant impact on mortality, with a 60-day mortality of 71.4% in COVID patients versus 25% on non-COVID patients. So when to give antimicrobials at the ICU admission, assess the risk of co-infections that we know nowadays that is quite low, but maybe should start in patients with severe disease like ARDS, focal consolidation, and shock. And the other one is during the ICU stay, and from these epidemiologic studies, we know that ventilator-associated lower respiratory tract infection begin to appear after the first week of mechanical ventilation, and bloodstream, the median of the diagnosis, day of diagnosis was the 12th day of ICU stay. So in conclusion, antibiotics if and when. First, remember that antibiotics are excellent drugs, but they only treat bacterial infections. There are two ifs. If a co-infection, and now we know that the risk is quite low. Secondary infections, on the opposite, the risk is high, both bloodstream infection and VA lower respiratory infection. And when at ICU admission, if the patient is severe with septic shock, focal consolidation, or ARDS, and during the ICU stay, maybe after the first week, try to look at ICU-acquired bacterial infection, VA lower respiratory infection, and bloodstream infection, and try to promote a good antibiotics to achieve program. Thank you very much for your attention, and I have questions.
Thank you very much, Pedro, for your presentation. We will have the questions at the end during the debate. So we go to our next speaker today. It is a pleasure and an honor for me to introduce Dr. Garifalya Poulako. She is Assistant Professor of Medicine at the Athens National and Kapodistrian University and served in different functions in the European Society of Clinical Microbiology and Infectious Diseases. Falya is part of the editorial board of Intensive Care Medicine and has published extensively on different topics. Her scientific topics of interest are infections in critically ill patients, viral infections such as the one we are discussing today, antimicrobial resistance, and new antibiotics. Now, today she will cover hospital-acquired infection in COVID-19. Falya, please.
Thank you very much, Jan, for the introduction, and I would like to thank you very much also the organizers. It's a great pleasure and honor of mine to be invited in this event. So I enjoyed the first presentation, and actually we will comment on some common papers, manuscripts. As introduction in my talk, I would say that, of course, antibiotics are ineffective against SARS-CoV-2, but our difficulty in ruling out bacterial co-infection presentation and secondary infection during the course of illness has made us use frequently antibiotics in a percentage up to 98% of the treated patients in the ICU. And in the beginning, extrapolating from influenza pandemics and the remarkable danger of adverse events when a co-infection, a bacterial co-infection is present, several guidelines advocated the use of empirical antibiotics for patients with severe and critical COVID-19. So in the literature, there is a soup of definitions, and actually most of the COVID-19 studies are now using the definition of either a co-infection on presentation or a secondary infection emerging during the course of illness or hospital stay. And in this second definition, hospital-acquired infections, which is my topic today, are included. Early studies have reported variable rates of secondary bacterial infections, albeit always the secondary bacterial infections were associated with increased mortality rates. You will see that the first reports from China reported 5 to 27%, 15% of patients having a secondary bacterial infection, and in most of the cases, the mortality rates were very high, from 80% to almost 100%. Professor Popa has shown already this meta-analysis. This is one of the first meta-analyses in the field, and this is a rapid living review. So the initial studies were 24, and they employed a retrospective cohort design, and most of them took place in Asia. As a general remark, very few information was observed on the pathogens implicated. So in this meta-analysis that is now apparent in the website of the Toronto University, and you will see that there are 35 studies so far. The overall proportion of COVID-19 patients with bacterial infection is now at 8%. The secondary bacterial infection is 16%, and the bacterial infection in critically ill patients is more common and is estimated at 16%. What is important to say is that specific species of bacterial pathogens were reported in less than 14% of patients with reported infection. In other words, our information is of poor quality. And the most common organisms reported in this meta-analysis are Mycoplasma species, Haemophilus influenza, and Pseudomonas aeruginosa. This is not exactly what we expect from nosocomial infections. It is something in between community-acquired infections, respiratory infections, and Pseudomonas as a nosocomial pathogen. So diagnosis of bacterial infections in critically ill COVID-19 patients may be challenging because of the overlapping features of COVID-19 with bacterial pneumonia, such as hypoxia, fever, infiltrates, and the fact that classical markers are not diagnostic in COVID-19. Procalcitonin levels are very rarely above the threshold of 0.5. Leukocytosis is not usually present, and hypotension is not common, at least in the severely ill patient. Our next information from the most recent meta-analysis report superinfection rates that are in higher rates than the previously reported. This is a recent meta-analysis. 24% of the patients that were included had superinfections. They have included 118 articles, and the bacterial superinfections are estimated at 20%, and noticeably, fungal superinfections are reported at 8%. And very consistently across all studies and all meta-analyses, patients with superinfections have a higher prevalence either mechanical ventilation or of mortality. If you have a look at the pathogens that are implicated, as far as we have compiled more studies, we can see that causative pathogens now follow local epidemiological trends. You can see that we have Acinetobacter species, we have Pseudomonas, we have Klebsiella, we have Escherichia coli. And antibiotics in this meta-analysis are administered in 98% of the 83 studies. The prevalence of fungal pathogens are of concern. This is also a very important study, a multi-center retrospective European cohort performed in 36 ICUs. Professor Pova already mentioned it. I will have a different look on this data. The authors compared the incidence of ventilator-associated low respiratory tract infections in SARS-CoV-2 in comparison to influenza and no viral infections. You will see in the upper table that in the adjusted analysis, VA LRTI is significantly higher in patients with SARS-CoV-2 infection after the statistical adjustment. However, as you can see in the graph, it is apparent a residual confounding may still play a role in the effect of estimates. And what about the distribution of pathogens? Now the distribution of pathogens, although it is similar for the three groups, shows that we have a gram-negative preponderance, and actually we have what is expected from hospital-acquired infections. In another recent study, the authors tried to define predictors for hospital-acquired bacterial and fungal superinfections in COVID-19, and you can see that they have identified previous rectal colonization by carbapenem-resistant Enterobacterales, the need for invasive mechanical ventilation, the use of immunomodulators, high CRP values on admission, and treatment with piperacillin tazobactam. If you have a look at the pies in the right panel, you will see that Enterobacterales represent the percentage of the identified pathogens, and the non-fermenting gram-negative bacteria represent another considerable amount of pathogens after the 8th day of admission. The authors also have identified the difficulties for healthcare workers to adhere to standard precautions, long shifts wearing the same equipment, possible shortages of certain equipment, and focus on self-protection rather than on cross-transmission of bacteria across patients, overcrowded wards, shortages of professionals with appropriate training in infection control procedures, and possibly decreased laboratory ability to detect MDR carriers. Of course, this may vary across different countries, and this may vary also according to the pressure on the system that follows the epidemic curves. Another interesting study that was also discussed, we have a second look on this study, a study from the Outcome RIA network from France, which uses matched case cohort methodology and is based on prospectively collected data. You will see that there were 235 COVID patients matched with 235 non-COVID patients, and the authors have identified 43 ICU bloodstream infections. The authors have remarked that COVID-19 increased the daily risk to develop ICU BSI, and a significantly increased risk for ICU BSI was detected in patients who received tocilizumab or anakinra, but not corticosteroids. I would like also to show you the distribution of pathogens, which is slightly different from the previous studies that I mentioned. In this study, we have a high prevalence of coagulase negative staphylococci, and we also have Enterococcus, other gram-positive, Enterobacterales, Pseudomonas, and Candida. What is really the role of immunomodulators? In this retrospective single-center study from Italy, you will see an incidence rate of 47 episodes of ICU acquired per 1,000 patient days at risk, which is certainly higher. It's at least 5 to 10 times higher from the previous baseline of this center. An independent association was found between receipt of anti-inflammatory agents and the development of BSI. And this fact seems to be mainly driven by steroids than tocilizumab. However, the authors comment that the diagnosis of BSI in tocilizumab-treated patients may prove difficult because of the frequently absent fever in 38% and the reduced serum concentration of classical inflammatory markers. A recent meta-analysis focuses on secondary infections with tocilizumab in critically ill patients. I have focused only on the effect of tocilizumab in secondary infections, and you can see that the 23 comparative observational studies, 4 RCTs, 12 cohorts, and 7 case controls showed that there was no significant increase in secondary infection. However, the observational studies, including 400 patients, were in the opposite direction. There is a discordance in the observations between RCTs and single-arm studies, and I think that we need new data to have a definitive conclusion on the role of tocilizumab. Another interesting study that I would like to present you comes again from France. It is a single-center retrospective study of almost 200 patients during the first wave. The authors have observed that almost half of their patients developed a bacterial infection, almost 50%, with higher SAPS2, with longer ICU stay and double mortality. And again, the distribution of pathogens in the BSI was peculiar, with enterococci prevailing, followed by staphylococci and streptococci, those of viridans and Milleri group, which is quite different from the prevalence of pathogens that was observed in the previous years. And also, the authors say that 15% of BSI episodes did not have any apparent origin, and translocation of bacteria from digestive or pharyngeal microbiota was suspected. As far as VIP is concerned, in this cohort, the diagnosis was made in 50% of their intubated patients. At this point, the distribution of bacteria was within the expected range, but the authors have observed a delayed clearance from the lungs, which was unexpectedly slow despite the adequate antimicrobial therapy, and it was associated with clinical failure. The authors have proposed some mechanisms behind this observation. Some of them point at pharmacodynamic alterations or a probable decrease in antimicrobial drug concentration that may be caused by pulmonary emboli, and finally, an impaired immune response that could be mediated by the SARS-CoV-2 per se. And let's go to the fear of resistance. This study from the US has shown that a carbapenem resistant outbreak was apparent in the wake of the global pandemic. CPE prevalence has declined substantially in the recent years, and now the authors have remarked 31 CPE isolates from 13 patients, including Klebsiella pneumonia and Enterobacter cloaca, which encoded KPC2 or KPC3 or NDM1 enzymes. And a study from Spain the authors report an outbreak of 7 patients carrying CTXM 15 or OXA48 producing Klebsiella pneumonia. They belong to a single clone. The patients were admitted to beds that were close to each other. None of them was colonized prior to admission to the ICU, and all except one developed VAP, but all except one were discharged. The authors attribute the outbreak to reusing of personal protective equipment due to its shortage and to the relaxation in infection control measures that has been observed during the surge of COVID-19. So some caveats of the existing literature: it has reports on mixed population, critical and non-critical, very low rates of microbiological sampling. They mostly report on retrospective studies, and there is early antibiotic coverage and no extensive information on severity of cases. I believe that this algorithm was discussed before, but I can comment on this that radiology evidence should be suggestive of bacterial pneumonia. Laboratory or clinical hints that lead to initiation of antibiotics are a PCT value above 0.5, leukocytosis, hypotension, septic shock, multi-organ dysfunction. The physician should follow a meticulous investigation, and I would like to stress the importance of de-escalation or early discontinuation of antibiotics, even in this setting. And finally, treatment duration could be just 5 days or 7 days at most of the cases, as generally commented from all the recent guidelines. And I would like to spend my last slides on the COVID-associated pulmonary aspergillosis. This is a new entity, and this is the timeline of cases, series, and cohort studies reporting COVID-19 associated aspergillosis in mechanically ventilated patients. You will see in red, these are the cohort studies with the biggest number of patients. The biggest of them, the large one, was 135 patients, and the percentage ranges between 3 and 35%. One of the biggest studies in the field shows us that probable CEPA is diagnosed in 27% of patients, and it is an early event. The median days after ICU admission was only 4. It is associated with a significantly higher 30-day mortality, and among patients receiving voriconazole, a trend towards lower mortality was observed. So they stress the importance of early and adequate treatment. The problem with COVID-associated pulmonary aspergillosis is that we don't have yet consensus criteria and a probable definition. This paper, this consensus criteria was published in the Lancet Infectious Diseases in December, and the authors proposed some definitions. And you can see that in order to have a probable diagnosis, we have to follow bronchoalveolar lavage and sampling and have a very extensive workup of the sample in order to have detection of fungal elements. If we don't have bronchoscopic sample, the accuracy of the definition cannot go further than possible. However, the classification of possible kappa will most likely be sufficient to initiate antifungal therapy in the clinical setting. I believe that the field of COVID-associated aspergillosis is very hot, and we need further information in order to have a better diagnosis, solid diagnostic criteria, and to decide which patient has to be treated with antifungals. So in conclusion, recent evidence shows increased rates of hospital-acquired infection. Okay. I can leave it open and not read it. Okay. Antimicrobial resistance is of concern. Outcomes are consistently worse in patients with secondary infections. Use of COVID protective equipment may contribute to the best or to the worst case scenario. Anti-inflammatory drugs may increase the risk, and new pathophysiologic features such as bacterial persistence or PKPD issues should be further evaluated. Thank you very much.
Thank you so much, Thalia. Thank you, Pedro, as well, for this comprehensive overview and all the challenges associated with the with infections. I think on the one hand, it's frequent and it's a difficult thing to do. So I have a practical question for the both of you. You've clearly outlined why it's important, how difficult it is. So how do we practically approach this? How do you look for these infections? How do you recognize it?
Shall I start? Sorry.
Yes, Pedro, please.
Okay. I think we don't have one single answer. I think, again, we should go close to the patient and see how he is going on and how is the clinical course. If the patient is improving, if the patient is stable, and it's stable but it's stable in a good stable condition, let's say, maybe you can wait. The thing that you made in your opposition paper is watchful waiting and a close monitoring of the patient. If the patient is deteriorating or not improving and in a bad situation, maybe you should sample the patient repeatedly and try to find things and try to look for bacterial infections, for also fungal infection. And again, maybe that depends on the place of the world where you are, because now we know that in India, they do not have aspergillus, but they have mulca. So there are different infections, different parts of the world. Okay. And also maybe some viral reactivations like CMV that we don't know exactly what they are doing in those patients.
So, but in summary, you look at the deteriorating patients and then you sample the patient.
Yes, repeatedly, I think. I'm not doing, and I'm not recommended doing surveillance cultures, because now that is usually associated with, in those patients, you find something, maybe you are pressed to prescribe something, but just according to the clinical course, the radiological course, to the even biomarkers, again, looking at the course of the biomarkers and not a single value, because the course of the kinetics of biomarkers are always much more informative than one single value, because you don't know if it is decreasing or increasing.
Okay.
And putting everything together and to discuss and to take a decision.
Okay, Thalia.
Much, Professor Thalia Pulecu. Thank you very much, Professor Pedro Povoa. It's now time maybe to have David Linus, our media editor, intervening into the debate. And Thalia, you might be willing to answer to the previous question, or maybe to the next one coming from David?
Yes, I can answer to the previous question.
Please, Thalia.
First of all, we are clinicians, and I agree that we have to follow the patient's course of illness. We have acquired a lot of knowledge during this year, and I will touch the diagnosis from a different viewpoint. The evidence shows that these patients are not well sampled, and from the microbiological viewpoint, they are not investigated properly in the first period, during the first wave. I believe that these patients deserve the same investigation that we did previously with our population of critically ill patients and follow similar algorithms for treating infections. The duration of antibiotics is very important, and I will stress the importance of complying with the guidelines, which are now of short duration. Either we have a VAP or we have a community-acquired infection, short durations of antibiotics, and take into consideration always the de-escalation. And of course, we have the molecular testing that can help us in identifying other co-pathogens that could deserve targeted treatment.
That absolutely makes sense. Please, David, if you have any comment, questions, or maybe any feedback from the media, we would be delighted to listen.
Thank you, and thank you all for your talks. I suppose my question is consolidated around the pragmatics of delaying antimicrobial therapies. And I suppose an overwhelming question asks if we are now in a worse state for antimicrobial stewardship than ever before. There's a very high cost if the team is wrong, so there's a lot of people jumping the gun, as it were, to prescribe antimicrobials. And in the absence of robust detection mechanisms like scans, delays in blood culturing, and great difficulties associated with CRP and procalcitonin, I suppose the question to everyone is, which follows on from the other questions, is how does the clinician deal with this uncertainty and maintain antimicrobial stewardship? And as a secondary consideration then, how do you maintain this stewardship with concerns over immune modulation with monoclonal antibody therapy that is becoming more and more common, particularly in the UK? It's ubiquitously used. So how do we discern these concomitant infections in the absence of fever, a rise in PCT, a rise in CRP? How do we address that and antimicrobial stewardship?
David, so we have 1 minute for the two answers. So please, and before we give back the voice to Jan and a concluding comment. So please, Falia and Pedro, 30 seconds for the answers.
Okay. I think that part of these questions have already been answered. We have to be more vigilant when we administer immunomodulators, and we should be vigilant also with the high-dose corticosteroids. We know that from previous infections as well. So the antibiotic stewardship teams are not convening very frequently during the era of COVID. This can be bypassed with Zoom meetings, but I know that stewardship is a difficult task. However, I believe that in the second year, we are far better than in the first year.
What I would say, if these patients, according to the data from cells flow cytometry, they are already in the immunosuppressed side. So if we give even more immunosuppression and monoclonal antibodies, the risk is even higher. So if we want to go to that side, maybe we need to be much more watchful, trying to sampling these patients even more frequently if they are not improving or deteriorating. In a patient with, let's say, a common, not that immunosuppressed, I think the risk is on the lowish side. And again, co-infection is quite low in the beginning, but we know that ventilator-associated pneumonia is frequent after the first week. So if the patient is not improving, look for the agents, and we need, as Garifalli said, to collect good samples. That's the only way that we have to. Thank you.
Very much, Pedro. Thank you all. That was a very thoughtful and very well done session, and we learned a lot from your lectures. Jan, maybe once again for concluding comments, and we move to the next session. Please, Jan.
Yes, I will be very brief. It was an exciting session. We've learned that infections are an important challenge, particularly the secondary infections. We don't rely too much on imaging and biomarkers, but it's a clinical approach, and stewardship is the central word.
Thank you very much all, and enjoy the ESICM Marathon.
So we are now in the second half of the marathon, and we will have the final statistics tomorrow, but it seems that we are running this marathon with thousands of people from all around the world on all our media. So it's a great pleasure to introduce the next moderator, who is Armand Geerbs, a professor of intensive care and chair of the Department of Intensive Care in Amsterdam at the University Hospital VU Medical Center. And importantly for us, is also the chair of the Division of Scientific Affairs of ESICM, with the titanic task last year and this year to do a digital conference that is going to be very interactive again. Hello, Armand, how are you?
I'm very fine, thank you. Can you see me?
We can see you and hear you very well.
You're beautiful.
Okay, well, that's good news. Okay, so let me start, if you allow me. And I will first introduce Dr. Chiara Roba. She is a consultant in neuro and general intensive care at the Policlinico San Martino in Genova. And she worked for many years at the Addenbrooke's Hospital in Cambridge. And she is also currently the deputy chair of the neuro intensive care section of ESICM. And research interests are mainly on neuromonitoring, autoregulation, and mechanical ventilation. So she is the best person to speak to us about the neurological involvement in COVID-19. And Chiara, the floor is yours.
Thank you very much, Armand. Good afternoon to all of you. It's going to be very difficult, honestly speaking, to discuss about the neurological involvement of COVID-19 in just 15 minutes. So apologize, because I already tell you that I cannot go too much into the details of each neurological involvement. Now, why do we see so many neurological complications in COVID-19? The pathophysiology is really complicated, and this makes this pathology really different from any other respiratory tract infection. We have learned over the last year that COVID-19 is a multi-organ disease which does not affect just the respiratory tract, but then it causes a systemic multiple organ disease, and of which the brain is one of the most affected organs. And the neurological manifestations have been studied a lot, and several pathophysiological mechanisms have been hypothesized. One of the first one is very easy. It's just the relationship between the brain and the lung. We have a pneumonia, we have a patient with hypoxemia, with chronic hypoxemia, we have impaired gas exchange, and this can obviously affect the oxygen delivery to the brain, and also the respiratory, the mechanical ventilation strategies that we normally use to improve the outcome of ARDS, like protective strategies, are often in conflict with the neurological needs, and this can obviously cause the occurrence of neurological complications. But in COVID-19, there are also some specific features, like, for example, the hypercoagulation and inflammatory cascade, as well as the possibility of a direct viral neurotropism. Regarding the first hypothesis, it seems that SARS-CoV-2 can enter directly into the brain capillary endothelial cells, and this causes a process of neuroinflammation, which causes a cytokine storm with a local microglia activation, which at the same time increases the activation of microthrombus formation. So we have an immunological cascade and a coagulative cascade, which can cause hyperinflammation with brain-blood barrier disruption, and at the same time an increased risk of cerebral thrombosis and complication. Direct neurotropism has been challenged because, from one point of view, it seems that SARS-CoV-2 can replicate within the neurons in vitro, and there are some potential mechanisms which explain the possibility that there is a hematogenous translocation to the CNS or a binding to the ACE2 receptor, as we have seen. So from one point of view, there might be a direct neurotropism of the virus, but if you look at the most neuropathological studies, most of the issues, most of the derangement that we find in the brain are largely related to an hypoxic ischemic injury, to the presence of microthrombi with a limited invasion of a virus in the CSF, which often is negative. Now, when do the neurological complications occur? They can actually occur at any time. In some cases, they are the symptoms of presentation. In some cases, they develop during the occurrence of the respiratory symptoms, and sometimes they develop during the hospital or ICU stay. So there is not actually a rule, and there is a cumulative risk, increased risk of neurological complications over the days of ICU stay. And if we look, for example, this is one of the first studies which have been published like here by Julie Helms, and this is one of the first reports describing the neurological features. This happens so commonly. 84% of the patients in this report was reported to have neurological features, which were still in this first report probably still not too specifically described, with positive findings on CAMA's use, delirium, agitation, and some specific feature, for example, in the MRI findings, where most of the patients, actually in this paper, all the patients had perfusion abnormalities, thus suggesting an alteration of the cerebral blood flow related to alteration of the cerebral circulation. But again, if we look at the CSF analysis, all the patients had negative RT-PCR for SARS-CoV-2. Since then, a large number of papers have been published regarding the incidence of neurological complications, and now we know that we can find such a high number of clinical manifestations, starting from the central nervous systems, for example. Ischemic stroke and hemorrhagic stroke have been probably those which have been more studied, because probably more correlated with the outcome, but also seizures, some cases of meningoencephalitis, and delirium, which is probably the most common neurological complications with neurocognitive dysfunction. But we also have to mention, and we will discuss it in the next few minutes, that also the peripheral nervous system can be impaired with a higher number compared to normal population of Guillain-Barré syndromes or myasthenia gravis. Risk factors for neurological complication, well, it's difficult to say. These have been assessed in several papers. It's mostly seems that severe COVID infection with severe hypoxemia and severe ARDS, so mostly patients who required ICU admission, are those who have the higher risk factors of neurological complication. Pre-existing cardiovascular disease and older age, so pre-morbidity factors, are related. Plus, there is a number of factors which can be specific or clinical patient factors which have to be completely demonstrated. We have recently performed a systematic review with a meta-analysis, which is going to be published soon. And in this meta-analysis, including a total of 76 articles describing the neurological complications, we found that the most common neurological complications are in fact ischemic stroke, delirium, intracranial hemorrhage, and in part peripheral nerve disease, with an incidence of ischemic stroke, which is about 1.3% in the hospitalized patients and 2.8%, so much more when the patient is more severe and needs ICU admission. And this incidence is higher than for normal influenza and obviously for the normal healthy population. And the incidence of intracranial hemorrhage, which seems to be a bit lower, with a pooled percentage of 0.4%. So we try to went a bit more deeply into the details regarding the incidence of stroke, hemorrhagic and ischemic. And in this large paper with more than 2,500 cases from the critical care consortium studied, we found an incidence of acute stroke of 2.2%. Of those, ischemic and hemorrhagic stroke were similar in terms of incidence, but we found also some variables which were specifically related to the risk of developing hemorrhagic or ischemic stroke. And one of the most risk factors was the need of mechanical ventilation, but especially the need for ECMO. And the need for ECMO was importantly associated with the occurrence of hemorrhagic stroke and also of ischemic stroke, but also the presence of cardiac arrest during ICU state was importantly associated and more frequent in patients who had an ischemic stroke. And looking at clinical variables and laboratory variables for the risk of developing stroke, actually there isn't much that can help us to predict which is the risk of ischemic or hemorrhagic stroke. Because, for example, what we just found is that hypoxemia is importantly correlated with the risk of hemorrhagic stroke, not for ischemic stroke, and there is not association with anticoagulants. So it's difficult to predict which are the patients who are going to develop this type of neurological complications. But it will be important to go further in details regarding this topic, because although the incidence is 2.2%, so relatively low, the effect on outcome is important, especially regarding the hemorrhagic stroke. Delirium is another important component of the picture of neurological complication. As I was mentioning, it occurs in nearly the 65% of the patients, so more than half. And this is probably the largest study which has been published on risk factors for delirium in COVID-19 patients. And as you can see from the results, there are some factors which are basically specific for COVID, like the severity of ARDS, the severity of respiratory support need. But in most cases, the factors that are associated with the risk of delirium are mainly associated to the need for deep sedation, the use of benzodiazepine, and Gert will discuss this part further. So regarding the delirium, it seems that although the incidence is higher than in the general ICU populations, not two specific factors for COVID-19 have been found in this paper. Just a mention to the peripheral nervous system disease. Even in this case, what we have tried to understand from the literature is whether there are specific features of COVID-19 related, for example, to the development of Guillain-Barré syndrome. Just few cases have been published, so this makes very difficult to jump to conclusion. And in this case series, for example, it seems that the symptoms, the interval between Guillain-Barré syndrome development and COVID-19 are basically similar to those associated with the normal development of Guillain-Barré after infection. The CSF was in most cases negative, but in COVID-19 associated Guillain-Barré, more severe deficit with more severity of Guillain-Barré development with axonal injury have been found. So maybe the severity is probably associated with the presence of COVID. And the same is for the myasthenia gravis, where basically there was found in this paper a higher number of exacerbation regarding the development of myasthenia crisis, with a high number of case series and case report. And now I think that we need to think about whether this is related to specific features of the COVID or whether it's just related to the effect that COVID had on the respiratory tract factors. In fact, regarding the first hypothesis, SARS-CoV-2 may potentially trigger and amplify the autoimmunity in myasthenia gravis because it presents an amino acid consequence with host components which can activate T cells and B cells and therefore activate plasma cells with the production of antibodies against the acetylcholine receptor. And this can be a specific feature of COVID-19. But if we think about the patient that we have in front of us, the exacerbation might be more likely related to the fact that in patients with COVID-19, the presence of hypoxemia, emotional responses, and the increase of physiological dead space can actually cause the reduction in the pressure produced by the diaphragm because of the reduction of the central drive activation, and the fatigue threshold is more easily achieved, and therefore these are patients who are probably more likely to have hypoventilation acutely and the myasthenic crisis. Other aspects, neuroimaging. A lot of papers have been also published regarding the neuroimaging. Not a specific feature have been described regarding COVID-19 neurological CT findings. And we have in this systematic review, for example, a number of hemorrhage, vascular thrombosis, but most of them were aspecific pictures with a 41% of neurological signs, but no CT abnormalities. So probably CT is not precise enough to describe the pathophysiological features occurring in COVID-19 patients. And this is what the group of Cambridge has tried to teach us, because they used the quantitative DTI and they try to assess the neuroimaging features in patients with COVID. And they actually found that there are, first of all, significant differences in COVID-19 regarding the mean diffusivity in the gray matter regions. In the gray matter region, there is a picture which is basically compatible with pathogenic edema in these patients. And in the region which are at the level of the mesencephalus of the pons, there is a prevalence of a picture compatible with cytotoxic edema. And the new histology show important parenchymal infiltrated T cells, and the most involvement is found in cortical and hippocampal, which can actually explain the high number of mental alterations. So probably a more deep, more advanced neuroimaging characteristics are needed to understand why there are these sequelae. And probably also a multimodal neuromonitoring is also what we need to early prevent and assess the neurological complications in this group of patients. For example, what we found is that measuring the non-invasive ICP during mechanical ventilation in ICU patients, in nearly 40% of them, we found that they had a high intracranial pressure, and the presence of intracranial pressure was associated with a longer ICU stay. So probably there are some complications which occur even during ICU stay when the patient is sedated, and we just find it out when we stop the sedation, when it's probably too late, and therefore the need of a multimodal neuromonitoring is warranted in these patients. The last point that I'm going to touch is the issue of the long-term neurological sequela, which is probably one of the most challenging part of the management of these patients. This is one of the first report published on JAMA. This is a follow-up at 1 month, and if you look at the data here, 85% of the patients had persistent cyst symptoms at 1 month. So basically all the patients presented still respiratory, but also neurological symptoms. This is a bit longer follow-up, nearly 4 months. And again, an important number of patients still presented neurological sequela regarding not just the respiratory tract, but also neurological impairment and neurological dysfunction, with a huge number of patients that after 4 months were not back to their normal life. And finally, this is a 6 months neurological follow-up, a retrospective cohort. A large number of patients where COVID-19 and influenza or other respiratory tract infection were compared. It seems that COVID-19 has a higher incidence of 6 months neurological and psychiatrical sequela. And if you look here, this is regarding any component that we have studied here, including plexus disorders, nerve disorders, neural junction disease, dementia, or mood, anxiety, or psychotic disorders. So the conclusions are that the clinical phenotypes of neurological manifestation are wide. The pathophysiology is likely to be multifactorial. There are factors which are specific for COVID-19 and factors which are general risk factors of neurological complications of any respiratory tract infection or ARDS. We need to standardize the assessment and the treatment of neurological and the cognitive outcome. Among the complications, stroke is not that frequent, but it has an important effect on outcome, and probably a long and important effort needs to be done to follow up these patients, because treating this patient does not end in the ICU. Thank you very much for your attention.
Okay. Thank you very much, Chiara, for sharing this with us. We will now move right away to Geert Mevrouw. He's Associate Professor of Medicine in Leuven and Head of Clinics, Department of Intensive Care Medicine. And we know him all for his research on data mining and mathematical modeling and predicting predicting outcome. And his research projects include computerized decision support systems, tight blood glucose control, and mathematical characteristics of the blood glucose signal. And of course, sedation and delirium. And that is why he is invited to speak to us about sedation challenges. Geert, the floor is yours.
Thank you, Armand, for the kind introduction. Indeed, sedation challenges in COVID, I think we all know what that means right now. These are my conflicts of interest. When it comes to sedation, I think it's one of the fields in our trade that has been revolutionized over the past decades, and where the less is more adagium is probably even more valid than in any of the other fields where we work. And we have been helped by very good guidelines, and they evolve over time. And the most recent version now is no longer PAD or pain, agitation, delirium guidelines, but it involves pain, agitation, delirium management, but also mobility of patients and sleep disruption. And actually, of course, these guidelines are very, very large, but a couple of important points are there. We need protocol-based, stepwise approaches, assessment-driven to manage pain and sedation. Light sedation is obviously recommended over deep sedation. I would argue that even no sedation would be best. We prefer a non-benzodiazepine strategy for sedation in critically ill patients. And in particular, benzodiazepines are one of the most important modifiable risk factors that have been associated with delirium. And this has been translated into bundles, and these bundles also exist for ARDS. And maybe we can argue that not all elements of these bundles are as evidence-based as some other elements, but clearly they're a nice concept. They make it easy to teach these concepts, and also to do research on them. And so the ABCDF bundle, for instance, mainly promoted by the Vanderbilt group, assess pain, brain, awakening and spontaneous breathing trials, choose your drugs wisely, do delirium monitoring and management, early mobility and exercise. The F stands for family empowerment, and then in particular for ARDS, it's important to control the respiratory drive of your patients. And these bundles, even while we can argue with evidence for all elements of them, but they do work. And this is a large cohort of 15,000 adult patients where you see that complete bundle performance is associated with faster ICU and hospital discharge, with lower mortality, with shorter duration of mechanical ventilation, less coma, less delirium, less restrained use, and even to a lesser degree, ICU readmission and discharge destination. And even if you don't do the complete bundle performance, each part of the bundles is associated with even better outcomes. So even if you only do partially these bundles, you can improve the outcomes of your patients. So we can say that for sedation, I think over the past decades that we were definitely on the right track. And if I remember the practice from when I was a young resident, which is more than 2 decades ago already, where the ideal patient, according to many of my nurses, would be the sedated, intubated, deeply sedated, intubated patients. We've moved a lot into waking them up, into mobilizing them, even while severely ill and even while on the ventilator. And so my practice, and I've been going around my unit for years now, annoying nurses and residents that they should keep their sedation simple, avoid polypharmacy, that they should stop the sedatives as soon as they can, that they can't use midazolam continuous IV anymore. If they use propofol, be aware of propofol-related infusion syndrome, monitor dose and duration, monitor triglycerides. I rarely use muscle relaxants. If I use them, it was rather intermittent and continuously. and I had limited experience with inhalation anesthetics in the ICU. We use it in our burn center, but my experience with that, apart from that, was quite limited. And now I will take you through my COVID unit. I'm calling this today, but it was actually yesterday because I rounded an 8-bed COVID unit with 6 patients in them. 1 patient prone, mechanical ventilation on propofol, Dexmed, fentanyl, and a muscle relaxant drip. A wean tracheostomy patient, more than 50 days in the ICU, still on clonidine, quetiapine, but he was on ECMO before. I can assure you that he was paralyzed as well. Mechanically ventilated, prone, renal replacement therapy, 35 days, went from one infection into the other on midazolam, fentanyl, ketamine, and curare. Mechanically ventilated on ECMO, severely obese, 10 days in the ICU, midazolam, Dexmed, fentanyl, sevoflurane, and cisatracurium in bolus. Mechanically ventilated on ECMO, and so on. HFNO, and non-invasively ventilated, and on Dexmed and morphine. So my theory of before the COVID pandemic has changed, because what I do now is definitely complex polypharmacy. I use continuous sedatives for several days. And even while I try hard to stop them, it just doesn't work if you do it too early in these patients. I do use midazolam continuous IV, mainly because propofol, which is my start anesthetic, is probably only feasible for about a week, and then you have hypertriglyceridemia, or you're worried about propofol-related infusion syndrome, and you have to reduce the dose or stop it. Almost all ventilated patients get muscle relaxants now, and most of them get it continuously. We do use more inhalation anesthetics, and I will talk about it a bit more. So honestly, I'm just violating the principles that I adhered to before. But maybe we can forgive, and maybe there's a good reason for that, because definitely we are not the only people in Leuven, the only people with these problems in sedating their patients. And Chiara already referred to this fantastic study that I think you should all read. But there's of course, a lot of these patients need mechanical ventilation. A lot of these patients need proning for several days. So these are severely ill ARDS patients. A lot of them are put on benzodiazepines for several days. A lot of them are put on propofol for several days, and then other anesthetics. Most patients get continuous opioids infusion while on mechanical ventilation. And it's clear that these patients are so ill, and there might be some good reasons why they have such high sedation requirements. A lot of the patients that are admitted in the ICU and ventilator are relatively long. Definitely now that the vaccines are we hardly, or we rarely see elderly people anymore. So we see on average people in their early 60s, late 50s. And apart from the fact that a lot of them are obese, they're in good health, so they have a good cardiovascular system, and they do have a very high respiratory drive and an intense inflammatory response. And an intense inflammatory response has been linked before to tolerance of, to increased tolerance of analgesics. And we do need to administer combinations of multiple agents, so this does increase the potential risk and side effects. And more specifically, currently we do not have any guidelines specifically for this population, and that's clearly because we still don't know what the optimal approach would be. But I do think that is something that we might need to work on as a community. And as a response to the previous letter, an American group sent in the dose of a small series of 24 patients that they have to give to their ventilated patient. The benzodiazepine dose, although it was given prolonged, you can see benzodiazepines for more than 10 days, 15 days in some patients, up to 20 days. But a dose that was more or less what you would expect for a severe ARDS. But opioids were in an extremely high dose in their group. This is a dose that is approximately 3 to 4 times as high than you would expect in another comparable ARDS population. So the story of the high respiratory drive and the difficulty to sedate them does hold true and is reported across several centers. And also in this series, average age 56, most of them on neuromuscular blockers, long mechanical ventilation, high fever, increased ventilatory demands. And maybe also because we don't enter the room so often, because we have to doff and don to enter the room, maybe we don't down titrate as often as we would do normally, because this is something that I usually do. I quickly enter a room, I down titrate my sedatives, and this is of course not so practical in the COVID population. And some people are concerned on self extubation because they're concerned of contaminating themselves or the environment as well. And as a result, we had huge amounts of patients. We gave them huge amounts of sedatives and analgesics, and there have been shortages in several areas. And I remember in the first peak that in Belgium as well, we had to be creative with our sedatives. And when there's shortages, what can you do? You can try to be conservative, to use less continuous IV, more intermittent bolus, or maybe use drugs through an enteral route if it works, or transdermal fentanyl. Some people have had to do that because they had lack of IV opioids. Or maybe you have to use agents that you're not used to, like sufentanil, alfentanil, methadone, even reported by some, or benzos other than midazolam, or add other sedatives that you're not used to, and also the volatile anesthetics. The same for the muscle relaxants. And even at a certain stage, we have been using veterinary propofol, I remember. Now, neuromuscular blockers, why do we have to use them? I think the jury is still out. We all remember the Papazian study, the Accuracis trial, where they have demonstrated a survival benefit for continuous muscle relaxants. Now, that has not been reproduced, and last year a very nice meta-analysis was published in ICMX. So there's no proven benefit on mortality, although there is a trend, but there is an effect on barotrauma. So protective ventilation is easier with neuromuscular blockers, but you do pay a price when it comes to weakness and maybe more adverse events. Weakness is an important problem in our patient. This is a series from our own hospital, 100 mechanically ventilated patients. Upon awakening, 72% of them was weak. Upon ICU discharge, more than half of them was weak. And even upon hospital discharge, more than a quarter of them was still weak. And this weakness is associated with lower Bartel and lower mobility scales upon ICU discharge, lower Bartel upon hospital discharge. What about volatile anesthetics? Volatile anesthetics have no proven outcome benefit, but this meta-analysis pre-COVID did seem to hint towards a faster time to extubation. And I must say, we have used them successfully. In the beginning of the pandemic, we used the classical setup where you put the anaconda or the humidifier where it's supposed to be close to the tube, but we had a problem with humidification, and there was a lot of sputum impaction in our patient. We had to do bronchoscopies. And so we now put the anaconda before the humidifier. So we do humidify, we put it here. The only disadvantage of this approach is that you will use large amounts of gas. So it's because if you give it here, obviously you have to fill the whole circuit with gas. So it can become a very expensive therapy as well. But with good results, at least in our group. Delirium is a form of brain dysfunction that is very dramatic in our patient, and you see very high incidences of that delirium in your COVID patients. Also the same series by Brenda Punn and her group. Brain dysfunction, coma or delirium, 12 days, and even in 21 days, on average, the patient only had 5 days free of delirium and coma, which is quite a lot, of course. And you've already seen this graph. I will highlight different things because I just want to say that the classical, what we normally call avoidable risk factors, such as benzodiazepine infusions, continuous opioid infusion, and also reducing family visits, that is associated with a higher incidence, with a higher prevalence, of delirium. We're not always successful in doing everything in the ABCDF bundles. spontaneous breathing trials, spontaneous awakening trials only in 20% of patients. Benzodiazepines cannot be avoided in a majority of patients. Delirium management is not the way we're used to do it. Early mobility and exercise is a lot lower than you would want to, and family is often left out of the ICU during the pandemic, and it does have a dramatic impact on the patient's mental status. So I've been asked to end with a couple of learning points, and so the learning points are that indeed there's need for prolonged deep sedation, and this means that we did not follow the existing PADIS guidelines as good as we should have, as we did before. Let's put it this way, and this is further complicated by drug shortages in some settings. And acute brain dysfunction is highly prevalent, and some of it is sedation related, and the same risk factors than we see in the other population remains. So I will end with the editorial from Valerie Page on the Brenda Pun paper that very pragmatically states that it might be unrealistic that we will be able to safely maintain light sedation in even only half of our acute COVID-19 patients. And so there's no optimal approach right now, but we should try to move back to the evidence-based approach that we knew before COVID-19. And let's hope that vaccines and maybe better treatment in the future can reduce the severity of COVID-19 and maybe the need to deeply sedate and ventilate them. Thank you.
Okay, thank you very much, Geert, for this overview. You said that less is more. Well, I always try to teach my fellows that you should only give enough of sedation and enough of pain killing, and that means not too much, and that means not insufficiently.
Well, less is more is, of course, compared to what we did decades ago. And maybe it's no longer a valid teaching point. I agree with you, because many of the young people will not remember how it was done before, and I agree that. But it has been like one of the elements on how this was, let's say, promoted in the beginning.
But what you did not mention, and perhaps Chiara can also respond on that, is the effect of the scary clothing that we all wear during the COVID-19 pandemics. This must be a factor in my view. What is your opinion about that?
Several patients also told me that. I think we've improved because we now use popper masks which leave our face free, and that is a big improvement. The noise is of course terrible, but I think for patients it makes quite an improvement, because you can actually communicate with them and they can see your face. I know several of my patients of the first wave have complained about it later, that they said, look, it was really strange to wake up in such an environment where you're actually treated by people without a face that you can't remember afterwards. Yeah, I fully agree.
Chiara, what do you think?
Well, I agree with Gert. What I would like to highlight is that it's true that basically we found the same risk factors for delirium regarding, for example, family involvement, as for general ICU population, but we should not forget that in this specific population, the patients were completely isolated from their families. So this was a very important and very sad often point, because patients were not able to see their families for weeks. We had learned over the last year that open ICUs can improve outcomes, especially in terms of a reduction of delirium, because patients were seeing their families for many, many hours during the day, and this was not possible at all with COVID-19. I know that some units have implemented the admission of families even during the COVID phase. In some centers in Italy, unfortunately not really in my center yet, but I think that this is a fundamental point, and it's probably the main reason why we have such a high prevalence of delirium in these patients.
Okay, well, I think very important part of this this meeting, of course, is that we have an input from the social media. So, Sigun, perhaps you can come in because you collect some of the questions that come from the media. Is that possible?
Yeah, so again, so far, there's not much from social media, so I will use this opportunity to cheekily ask some questions of my own to the panel. So I will ask one quickly to Geert. Have you had any thoughts regarding timing of tracheostomy in these patients? Would that kind of help with sedation requirements and potentially reduce delirium?
Yeah, that's a very good point, and the one that I couldn't make in 15 minutes. But we do try to track them as early as possible. The only thing is that we try to be sure that we don't have to prone them anymore, because proning with a tracheostomy in these very obese patients, often with a very short neck, can be quite a challenge. Maybe other people have been more successful in that, but we found that very difficult. So we kept them with a tube until they no longer needed proning. But indeed, it helps a lot. Once you give them a tracheostomy, you can wean sedation more rapidly, in my experience. Yeah.
Okay.
That's
well,
fantastic.
If we go again to medication, Chiara, can you also mention a little bit about the effect of the medication, especially during the first wave of COVID? There was chloroquine was taken and prescribed, and there are also other medications that are involved in neurological sequelae. Can you comment on that?
Yes, so during the first wave, we were still learning. So we used, for example, hydroxychloroquine. We started to use steroids not immediately, even though we started, for example, to use them quite in a very first phase. There are not data specifically observing or demonstrated that the use of this specific factor was associated with a higher number of neurological complications compared to the no-use of these drugs, but potentially the link is important and it's actually realistic. But I think that in general, the occurrence of neurological complication is such a wide number of pictures and clinical features that cannot be standardized in just one type. So, for example, for the development of stroke, we have seen that, for example, everything that has an effect on the inflammatory component or on the hypoxemia can actually reduce or increase the risk of stroke, of ischemic or hemorrhagic stroke. So potentially these drugs might have had an effect. And in fact, there are some reports which describe a higher incidence of stroke, especially in the first wave of a pandemic. But for example, for delirium, I'm not sure. Well, there are not data, so I cannot tell you whether the incidence has changed since we have the new randomized control trial who have demonstrated the no use of hydroxychloroquine. It's plausible.
I can ask you, you are also a clinical pharmacologist on top of being an intensivist. We have to wrap up the sessions. I can ask you to make a final comment, and maybe, I don't know if you thought that some of the issues could also be related to when we surge ICU beds. Is it that maybe looking after 50 patients instead of 20 makes us use different sedation strategies? We know that our nurses, our teams, they find it very stressful to prone 10 patients rather than one. I conclude with this, and I leave it to you to wrap up the session.
Okay, I didn't understand fully. You want us to stop the session now?
I would say maybe you can make a comment on whether you think about the sedation is also related to organizational issues, also related to when we surge ICU beds.
Well, you know, absolutely good point. I think that plays a major role if you look at the studies where they try to reduce the amount of sedation. Then it's of course very important that you have people very close to the patients who talk to the patients, families sitting around, as Chiara also mentioned. So that it's very clear that it's very multifactorial. Well, I think we have had a very nice overview of some different aspects of the neurological involvement and the sedation. And I hand over to the president and the President-elect. Thank you very much for the speaker.
Thank you all for a fantastic session and also for showing that the problems that we have in our ICUs are problems of everyone. So thank you. Thank you all.
Thank you, Mauricio. Thank you.
Thank you. Thank you all.
Hello, good evening, good afternoon. It depends where you are, but we are in the ESICM Marathon on COVID-19, and I'm delighted to co-chair this session with my president, Mauricio Cecconi. And it's not the session on human factors, because as you know, ESICM is about human factors. We discuss human factors with Professor Mark Herridge from Toronto and the importance of long-term outcomes for COVID-19 patients. We just discussed how much important are family members to reduce patients with delirium. And now with Johannes Mellinghoff, who is the chair of the NHP for ESICM, we are getting more into the details with a very nice session with a doctor and a nurse and many more perspectives on what we can call human factors. Johannes, please, and thank you.
Thank you so much, Eli. And I'm very pleased to be here with all of you and two fantastic colleagues that we have got in this session on human factors. So what we will have first is a session where we kind of look a little bit at the public eye and how we are being perceived by the public throughout the pandemic with Sylvia Calvino-Günther. You may have seen Sylvia a little bit earlier. She was doing some social media support for us. So she is a nurse educator in Grenoble, Alpes University Hospital in France, where she trains and guides new ICU staff in the implementation of new procedures and technologies focusing on extracorporeal therapies predominantly. Sylvia has been an active member for the ESICM NHP committee. She's actually been voted into the committee in the past, and she's engaging in many, many different different things, including, for example, our CRT masterclasses that she is a member of every single time. Sylvia, thank you very much, and over to you.
Thank you for this opportunity. I'm going to talk a little bit about what the pandemic has represented from a nurse's perspective. When I prepared my slides, I was a little bit disappointed because it looked like a rather pessimistic image. So I'm going to give a little social context look before, then a little browse of the bibliography on nurses' perspective, and the more subjective opinion looking from our ICU in Grenoble, from why and perhaps why are we feeling this way, nurses' perspective about the pandemic. So, very early, since the beginning of the pandemic, nurses have become very popular as the frontline fighters against the virus and being described often as heroes in scrubs or heroes without cape. The world-famous artist Bansky reinforced such adulation by creating an artwork that depicts a boy playing with a nurse toy while the figures of Batman and Spider-Man remain discarded in a bin. Such imaging is well-meaning and it's quite flattering for our flattering recognition of our job, but it remains the outside eye and it's quite different from what we as nurses are living and feel at the bedside of our patients. The problem of the superhero narrative during COVID-19 is a real issue, as it was pointed out by Margaret McAllister in one paper some months ago. Nurses have received many marks of social recognition, the drawings, the headlines, the front pages, applauses. Nevertheless, as stated in the article, nurses are not angels and they are not superheroes. Nurses are not superhuman. They are human beings, as good and as flawed, as strong and as vulnerable as any other person and any other group. The risk of describing and believing that nurses are superheroes can lead to three situations. First one, it offers a temporary solve for pursuing our work in poor and dangerous conditions. Secondly, and not the least, not all nurses are honored the same way or noticed for their courage, resilience, and skills. It's mostly addressed to critical care or emergency nurses. I am a critical care nurse, so it's actually very nice for me. But when I think of my colleagues working in mental health facilities or in elderly homes, I think they have been plainly and strictly overlooked. And the third one is that relying on superheroes to help during a crisis absolves everyone else from taking responsibilities for the containment of the virus. And this seems to be sometimes quite evident because the public may trust nurses to provide healthcare when the illness appears, but they do not seem to integrate always that healthcare practices could help to prevent them from getting plainly ill. So actually the question is not whether we are heroes or not. We are not heroes, we are just doing our job. And we are paying a heavy price for our engagement in this against this virus. Nurses need more than praise to cope with the pandemic. We don't, as nurses, we expect wages, we need personal protection, equipment, and rest. And heroes do not need all these elements. And if we look back to Bansky artwork, it's quite easy to imagine that the boy playing with the toy with the nurse doll could easily forget and get tired of it and switch to another action hero. Similarly, and once the crisis will be over, artwork, headlines, and campaigns describing nurses as superheroes can easily be forgotten, and with them, our ongoing need and struggle for wages, better work conditions, and status. This has led to a lot of studies about nurses' perception in the last few years about the pandemic. I browsed very rapidly PubMed about with a simple request about nurses and pandemic, and the number of studies reached as follows. In the last 20 years, there were around 12,000 studies on nurses' perception on pandemics, and actually from this to roughly 1,300 100 studies, 1,121 studies were written in the last year. So actually, all the studies, most of the studies, over 85% of the studies, were actually focused on the nurses' perception of the pandemic in the last year, so on COVID. So it really means that it's the first time healthcare workers' perceptions, and especially nurses, have found themselves in the middle of the spotlight and have become widely the subject of the studies. Even though COVID is not the first pandemic we are facing in this century, it's certainly the one having at the moment the highest impact on our lives. And maybe it will change also the look that people have and the perspective people have of our work and of our conditions. The problem is when I research about the nurses' perceptions on the pandemic, the papers had mainly focused on negative aspects: burnout, fatigue, anxiety, fear, and at least how to build up resilience, or how this other aspect had a weight on resilience. I didn't find really a lot of papers talking about the positive aspects that could be developed during times of crisis, like solidarity, knowledge, experience exchange, and the opportunity to learn and to get a new place as an efficient and recognized healthcare allied. So let's have a little browse of 3 important papers I found while preparing this talk. The first one was about how the threat of COVID-19 influenced the feeling of burnout of nursing staff. This was a cross-sectional study on a convenient sample of 771 nurses working in 10 hospitals in northern Spain. They found that several factors could explain burnout: work overload, lack of material of human resources, and especially the fact that the pandemic was perceived as a real personal threat, not only for nurses, but also for their relatives, as they could be potential disease carriers. Social support, as we have seen before, could moderate the negative perception of the crisis, but actually it never inhibited completely the feeling of burnout. The management should maintain a clear, fluid, and regular communication with the nursing staff in order to increase confidence and sense of control. And then you see that while the pandemic is perceived as a real threat, nursing staff will still remain with the feelings of anxiety and burnout. The second one was also a cross-sectional study, also in Spain, with a sample of 421 nurses, but coming from 39 Spanish provinces. This cross-sectional study evaluated the effect of sources of stress during the peak of COVID-19 on nurses' psychological distress, and they focused on the mediating role of coping strategies, both problem-focused and emotion-focused, and resilience. And again, the nurses with insufficient preparation and those who perceived with fear of the risk of being contaminated were not able to enact proper coping strategies. Now, the third one, it was a little different study. This one was talking about the need of nurses' competences. And it was a study that was conducted in Norway. This study emphasized on the need of competence on healthcare services and the fact that caring for patients with respiratory insufficiency required nurses with experience. This experience was including balancing nursing interventions, conducting medical treatment, and taking the whole person approach to patients' needs. So actually, what could help to build a resilience for nurses was the fact they could be properly prepared and that they had enough experience with COVID patients, or at least with patients with respiratory insufficiency. Now a little bit more personal or more subjective, why perhaps an explanation why nurses could be facing the pandemic and having such a negative perspective of the pandemic. I am working on an 18-bed medical ICU with 10 beds of intermediate care for triage and close monitoring of non-intubated patients. In this second intermediate care unit, we had 2 supplementary beds of intermediate care during what was called the second wave or the second peak. And all of these beds, these 12 beds, could be upgraded as ICU beds if we had the need to intubate the patients. So actually this ICU could be considered as an average ICU in general, as I shared before preparing the slides with most of my colleagues from the rest of France. This ICU unit well, actually the management accepted to increase the staff also in the medical ICU and in the intermediate unit during the pandemic peaks. And we had the arrival of external staff to increase our ratio from at least 2 nurses per day in the ICU unit and 2 nurses per 2 supplementary nurses also in the intermediate unit, and also to increase our patient and aide nurse ratio from at least 1 or even 2 and at times 3 more aide nurses in each one of the units. So it was a big relief for the staff. The only problem is, as you are going to see in this graph, and this one is the graph we had from the admissions and the deaths of COVID patients in our unit. In blue, you have the admissions. In orange, you have the bars, the deaths in the intensive care units. We didn't have so many deaths as we could have expected, but we had a lot of admissions, especially on the second peak or in the second wave in October and December. The management, and by management I mean the head nurses and the doctors of our units, decided that during the peaks we could benefit from staff reinforcement. But the problem we had was that the arrival of external staff could only be implemented at the end, at least on the first wave, at the end of the wave, when the overload actually was decreasing, and during the second wave and even the third wave, quite late on the arrival of the patients. So actually, at the end of any of the waves, the internal staff, our proper staff, was completely exhausted and depressed. Actually, the problem is that even in the general information journals, the ICU staffing problems become a concern, as they have discovered that the turnover rate in ICU is at least of 30% in this year, which is increased from 20% on the last year in just a month. The main reasons for leaving the ICU was, of course, exhaustion, stress, anxiety, poor life quality, and perhaps even disappointment. So another challenge, one of the hardest we're facing during the pandemics, and which could have a lot of weight in the exhaustion feeling, was providing humanistic care with real physical interactions between nurses and patients, even with the personal protection equipment as a physical barrier. The abandoned visits on earlier stages of the pandemic and the treatment of bodies after death have put the essence of our work of nurses care to the test. I suppose Victoria will talk a little bit more about this topic, because it was very important, and we felt extremely disappointed at the decisions of our authorities about especially the treatment of bodies after the death. I found a paper on oncology during COVID-19, and actually I felt that some of the proposals were quite easily applied in our subject. The one is that the negative impact of these experiences needs to be remedied through camaraderie with one another and by accessing self-help and assessment resources. And it's true that we will find strength from each other when we support each other. We can move forward from this tragedy to better care for our patients and for ourselves. And I think it could be applied also to our intensive care unit. Something else that I couldn't find on the papers was about solidarity, which is something that really could help a lot during the hard times of the peaks. Solidarity as a mutual support within a group was one of the positive aspects of the pandemic. First of all was the comeback of Asian nurses as reinforcement staff when we couldn't get this staff from our own hospital. And we were absolutely delighted to see that they were happy to come back to help. And the second one was even more interesting. It was the possibility to collaborate with other hospitals, other regions, and other countries in missions. In our hospital, in our unit, we were able to, one of the nurses was able to go and participate with a French task force in Guadeloupe. And in another mission, myself and another colleague with three doctors could join a mission, a WHO mission, with a Spanish delegation to implement a COVID-dedicated ICU in Mauritania. And this one gives a very different perspective of the pandemic when we try to share and to collaborate with other countries and other people. Just to finish my talk, I have found two papers that were quite interesting. The first one was that the nurses did respond to COVID-19. My colleagues spend a lot of time, many of extra hours during the peaks, working in the unit, getting exhausted, as at every outbreak through history. The inherent risks nurses face are compounded by inefficient, loosely involved public policy and management, resulting often in poorly resource preparedness. Resources arrive too little and certainly too late, and this is a feeling that we share with many nurses in France. The number of nurses who have died after contracting COVID-19 is of 150, and this is the latest data from the International Council of Nursing. These figures included only nurses from 44 of the world's 195 countries. It is largely an underestimate of the true numbers. So to conclude, only 3 take-home messages. The pandemic represents a huge professional and personal challenge for any nurse. It was the opportunity to grow in solidarity, resilience, and knowledge, even if in the papers I couldn't find all of these elements. But it's true that it was at a heavy price, with the very awareness and exhaustion of having been heard too little and especially too late. And now it's the time to come for nurses to let their voices be heard and participate in the reformation of public health policies, information management, and healthcare systems. Thank you very much for your attention.
Thank you, Sylvia. This was very interesting indeed, in particular with regards to the humanistic issues that we faced during the pandemic. Now, let me introduce the second speaker, who will talk a little bit more about the family aspects that we encountered due to the social distancing rules that have been incorporated into practice. So our second speaker is Dr. Victoria Metaxa, who is a consultant and honorary senior clinical lecturer in critical care. She's also the clinical lead for the critical care outreach service at King's College Hospital in London. Many of you might know Victoria from her great work on the CAR T-cell therapy as a promising new treatment in hepato-oncological diseases. And she's been founding member of the European collaboration, which focuses on the pathophysiology, symptoms, and management of these patients in intensive care. She's also an active member of the ethics section and contributes to the drafting of policies and the research portfolio in this area. Thank you, Victoria, for coming along, and the floor is yours.
Thank you, Johannes. I am blushing. So thank you very much, everybody, for the invitation and for still being with us here in the ESICM Marathon. This is a human factors session, and I'm going to talk to you about patient and family and what COVID, the impact of COVID to both of them in our ICUs. And I am going to focus on, the special relationship between patients and families and how that was interrupted. So in the next 15 minutes, I'm going to talk to you about the problem and was there a problem, the extent of the problem and what we can do about it. So some proposals. So come with me a year and a half ago, before all this started, and to this really important publication, 2017. This is a scoping review that gauged evidence-based strategies around how best to support family-centered care in all types of ICUs. He had a very, very important author list. It was multidisciplinary and it was international. And it came out with 23 recommendations in 5 different domains. And you can see here in the family presence domain, they recommended that family members should be offered open or flexible visiting hours so they can better care for the patient. They also, though, understood that open visiting hours would pose a challenge for the nursing staff or the clinical staff. So what they recommended was that the staff of the ICU were supported in such a way that they would work in partnership with their families to improve family satisfaction. They went as far as to say that family members should be present when there were CPR efforts, always with the proper support. In the different domain of communication, they recommended that ICU should have routine interdisciplinary family conferences because they would improve family satisfaction, they would increase trust in ICU clinicians, and they would reduce conflict. But routine meetings are not enough. They should also be structured. They offered the value mnemonic as a structure, but whatever structure you decide to have in your family meetings, what they said, you should promote active listening and you should make sure that the family feels non-abandoned and part of the decision-making. And it's very interesting how long it took for these statements to come out and how quickly they fell through during COVID. In the last part, which was environmental issues, they did recognize, and you heard it from Sylvia as well, the important role, the pivotal role of nurses in looking after the patients, but not only that, their pivotal role in providing support for their families. And they said that we should train our nurses to do so. And of course, each ICU and each hospital should have policies to promote family-centered care. And then this happened. And as I said, everything very quickly fell through. The first thing to go was, of course, the presence of the families in our ICUs. And of course, in the beginning, this was quite understandable. We knew a little about the virus. We didn't know about the transmission, and we were scared. And staff were scared for themselves, of course, but also family members were scared. They were scared for themselves and for their others, the rest of the family that remained at home. Family members were not only frightened, they were also feeling guilt, and you'll see that. I'll talk about that further down the presentation. The next thing that happened that prevented this ban, let's say, that prevented families visiting in the hospital was the fact that we had shortages in PPE. You see the graph in my slide, that is from April 2020 from the UK. And it depicts shortages in personal protective equipment in all categories of them. And you can see in 2020 in April, the UK was coming out of its first wave, but you can see how shortages still exist. They are the bars with the dark blue, and you can see that, you know, shortages in FFP3, in disposable gowns, in visors. So understandably, you would have to ration. And if you're afraid that you don't have your own PPE for yourself to care for the patient, then of course, there's not much left for families to come and visit, right? The third thing that happened, again, especially during the first wave, was this rapid expansion of ICUs. And every week, we were taking over different wards and naming them ICUs. And again, you heard from Sylvia what this did to the patient-nurse ratio, and I'm sure you've seen it in your hospitals. There weren't enough nurses, there weren't enough ICU nurses. So again, that posed a threat to their time, and the time that they could devote to support the family members if they were to visit, and of course give them time to actually support them physically, help them don and doff. So this combination really was detrimental to the presence of families in ICUs. And when the physical presence went, things started to happen with communication. And you can see this infographic that comes from the state of Michigan. And it shows that 98% of the hospitals had a no visitor policy. And I think I can relate to that in the UK as well. The most had end of life exceptions. And again, I think that was quite common around Europe, at least. So what this changed the way we communicated. So people moved to telephone or video conferencing. And you can see there, and that's Michigan, 4 out of 5 hospitals did that. So not only that, but also, and because ICU clinicians were so busy, different teams came in to help. And this could be medical students in some ICUs, but it also could be some redeployed colleagues. So we had colleagues from ophthalmology, radiology, and pediatricians that helped us to communicate daily with our family members and also run the video calls. And although that was definitely a step to the right direction, and it happened quite easily, actually, it wasn't without its own problems, because to be able to have a video call, you need to have a smartphone, a tablet, or a computer. And not everybody has that. Not only that, but you need to be able to know how to work that. So immediately that introduced some form of socioeconomic bias, but also age bias in our communication. It also introduced a difficulty in liaising information because the teams doing that were not ICU clinicians. And I'm going to talk to you a little bit about that further down. So we didn't have families present, and we didn't have communications that were robust. So of course, the impact on decision making was difficult and very important. And this is a study that's quite recent. It was published last month, and it did show. It comes from the Johns Hopkins Hospital in Baltimore, and it shows the impact of a policy that was implemented in their hospital, a policy that restricted visiting. And what they did is they looked at the before and after, the impact that policy had on ICU length of stay and on decision-making, treatment escalation planning, and life-limiting decisions. And what they found is that ICU length of stay was increased by 2.9 days, so almost 3 days after the implementation of that policy. And it actually took longer, almost twice as long, to reach some form of life-limiting decision, including DNA CPR. And the important thing was that this was a COVID-related restriction policy, but the patients they looked at were non-COVID patients. So we see, and I think from now on we're going to see more and more, the impact that COVID policies had not only on COVID patients, but on non-COVID patients. I think this comes as no surprise to anyone. When disaster hits us, and if that disaster is large scale, that's even more intense, then that acts as a stressor. And it activates in all of us basic human needs to feel safe, to feel connected with other humans, to feel calm, that we are of use and there is hope somewhere. However, and in the same time during this pandemic, governments and hospitals opted for a precautionary principle, and I think that was quite understandable. And adopting this principle, even without fully validated evidence, you err the side of caution. So you institute policies that reduce risk to the public. And this full blanket of restrictions, both to hospitals and ICUs, did exactly that and were implemented exactly for that. However, the result, quite understandably, was fear, anxiety, and skepticism to those isolated. Both our families that had to stay at home, but also our patients when they were waking up delirious and completely alone in their intensive care. And this is a study we did in our institution, where we implemented a family liaison team. They were colleagues from different specialties, consultants, the majority of them, and they were tasked with making video calls and phone calls every day and liaise information about how the patient was doing with their to their patients' families. And this is what we found. So we used the family satisfaction questionnaire for ICU, and this is the communication bit of it. And what we found is that a vast majority of the families we asked were very satisfied or satisfied with many aspects of our communication. So the completeness of the information, so how much they understood from the information we gave them, the ease and the honesty of the information, how consistent we were, and how frequently we called them. So, you know, superficially, we did very, very well. But we also conducted some qualitative analysis, and they were quite interesting. So 3 themes emerged from our qualitative interviews. The first one was being there with and for the patient. And the fact that they were not there with and for the patient, how much anxiety and stress it provoked them. They were very clear, at least the vast majority of them, that the video calls were an excellent opportunity to reconnect, and statements that they told us were that it was a life-saving intervention and it helped them really much. However, they did stress the feelings of guilt that they felt. And it's very interesting, they didn't feel anger towards us or the government that implemented the visiting restrictions. They felt guilt because even when they were invited to come in, specifically around the end of life of their loved one, they felt hesitant. They felt hesitant because they were afraid. And that's why they were feeling guilty. The second theme, and I think this was really, really surprising for us, was the breakdown in communication. So initially, and especially during the first wave, as I said, we were opening new ICU areas, and patients were moving from area to area as slowly areas were going from non-COVID to COVID. And it seems that sometimes the communication just fell through when families didn't know where to find their relatives. And of course, that was extremely stressful. I'm sure you can all understand. But they also felt that the communication was completely unsatisfactory because it was inconsistent. So what they said is that the majority got everyday phone calls, but those phone calls focused mainly on numbers and values about how the oxygen levels were doing, about the breathing machine pressures, about renal function, but they failed to give them a more holistic picture of the patient, including their overall trajectory. So the next phone call they got, where we were telling them that there was a deterioration, expected maybe for us, but don't for them, or that their loved one was dying, it came as an extreme shock to them. Extreme shock, because I'm sure you can understand that sometimes the last time they saw their relative was when they were being taken at the back of an ambulance. So, you know, and then the phone call came that they were dying. So this created feelings of extreme disbelief. The disbelief at the speed of deterioration, and many told us, I can't believe how this happened, or when did this happen? No one told me to expect that. And this matched with the disrupted, sometimes, and despite best intentions, with the disrupted information transfer, resulted in not only disbelief, but also suspicion. So they were very suspicious. They wouldn't believe us. They wouldn't believe that we didn't do anything wrong. They didn't believe that we were not hiding anything. And some of them actually accused us of foul play, or actually doing something wrong and hiding it. So what can we do and what can be done about it? So I think that if there's anything that is positive about a pandemic that's going on now for a year and a half, is that it teaches us things and we learn things. And now maybe we can focus and do things differently and better. And you will see, I'm sure, more and more publications emerging on that. So this is from Joanna Hart. It's a recent publication in Chest, where the team suggests strategies where the presence of the family can be enhanced even during the pandemic. So they focus on the non-physical family presence, and they suggest that all ICUs should use robust alternatives to inpatient visitation. And of course, we're talking about video conferencing, but let's not forget that if we opt for that, then we should have robust standards and respect patient confidentiality. What about visiting rules? Well, I don't think we have any excuses anymore. We know how the virus is transmitted. We know about PPE, and hopefully there won't be any more shortages. So I don't think there is any excuse to restrict in ICU family visiting. They talk about 2 family members, and they say that we shouldn't really make any distinction between the patient that's COVID positive or COVID negative and the patient that's approaching end of life and the patient that is not. They do say avoid establishing visiting hours. And I don't think that's, I mean, we knew that years before the pandemic, right? A unit needs to respect the fact that families will have other caring responsibilities, they will have jobs, and they will have health issues themselves, and they should work around that. And they do say that communication needs to be clear and robust with family members, irrespective of the policies you adopt in your unit. So to conclude, the pandemic has had the potential to set back decades of good work on family-centered care in ICU. We have seen, and we will see again more and more in the future, that trying to separate that unison that is the family and a critically ill patient has devastating effects. Alternatives to in-person visitation exist, and they should be adopted. And maybe after the pandemic has finished, a hybrid should just remain for visiting families. There's no excuse to not include and consider that we should have visitors when we make our PPE policies. But last and foremost, I think whatever policy we adopt, it should be based on a very clear rationale, and it should be clearly communicated with all stakeholders, our staff, our patients, and their families. Thank you very much.
Thank you, Victoria. This was very nice, and I thank you so much for the expertise that you brought in, particularly with regards to family communication. Now, we've got times for questions, and I've got a question for us all, essentially, because we're talking a little bit about public policy. And what do you think is going to be the consequence of this with regards to your local areas where you're working? So, Sylvia, you alluded to the fact that a lot of people were coming to help you during the pandemic. They clearly are either still there or they have gone back to where they were before. Have you noticed that staff are disengaging and staff are leaving, which is a huge scare that we have currently?
Well, actually, the staff is disengaging, actually. It's very sad, and it's really heartbreaking, because some people who are really engaged and have worked brilliantly in the last months, they just cannot stand it anymore, and they have to leave because they are exhausted, but physically exhausted. And it's the first time I have so many new nurses that don't stay at the ICU at least for the first 2 or 3 weeks. It's the first time I receive well, it has increased, of course, because the turnover is higher. But for the 23 last nurses, 5 of them have already left, and 1 of them didn't even stay 24 hours in the ICU. Now that's a factor that people are leaving.
Yeah, it's very sad, isn't it? So, Victoria, we kind of went from the superheroes, essentially, all the world to the real experience of family members who obviously were also noticing what was going on in the media, describing, you know, the nursing professional or healthcare professionals altogether as superheroes. Do you think we can combat this, and do you know perhaps or have an idea or suggestion how we can do that?
The suggestion that we are all superheroes when we're not, you mean?
Yeah, I mean, we were all portrayed as being superheroes to start off with, but actually, you know, a lot of patients obviously came in, and the real expectation or the real challenges was for people to then see that, you know, we are not superheroes. We are actually just people who are trying to kind of do our job.
I know, and I think the people, so first of all, I think this is a basic human need, especially at the beginning where everybody's so scared and no one knows what's going on. I think people wanted to feel that the ones taking care of them, which was the healthcare profession, were able to rise above that. They would be there, they would be unscathed, they would be uninfected, they would be there to look after everybody. So I think that initially was a human need in the UK. I think all over the world, maybe people were clapping for us, they were bringing us gifts, so they were leaving. It was just, I think initially that was that. I think it was very flattering. I am not sure how in the long term that actually serves us or serves any purpose. We are not superheroes. People, exactly like Sylvia is saying, people are breaking down. And what I do think is that, what I do know is that the families that came and the patients that actually came into the hospital, they knew that. They knew that, you know, what we had to go through every day. They didn't mind that we were not superheroes. They didn't really mind that, you know, they saw us breaking down and crying. I think it was the people that didn't really experience that firsthand.
Thank you very much, Victoria. Thank you very much, Sylvia. Johannes, we should have with us now Patricia McReady, and we might have some questions from the chat and from the audience. And Sylvia, maybe just before we leave, I really count on you, because the two of you shared a lot of emotions, and we need now to understand better what you call resilience. So please, first, Patricia, the floor is yours. If you have any burning questions from the media.
No, I think there's just agreement that the way that nurses have been portrayed with regards to the superheroes and angels and how it's not helpful rhetoric. There's a comment that's just come in that said, "Thank you for this important subject. We suffer a lot of pressure from families and sometimes the media. We feel under attack," which I think is resonates from what's been said.
So thank you. So many people share their emotions because you actually initiated that we are very open to that. Maybe, Johannes, if you mind, I would be very happy to give 30 seconds to Sylvia for this process. That is a long process that leads people to accept the unacceptable, which is resilience. So do you know any strategy to promote resilience inside our multi-professional teams?
Well, actually, the fact that there are two things that were found to be promoting resilience was preparedness in people who had been working in ICU, and especially people working for several ages in ICU. So it was hard for new nurses to become resilient immediately. But also they found that the solidarity and the factors, the fact that nurses were not alone, but they could talk to each other, and the moments in which the nurses could explain one to another and feel and be together and talk and perhaps cry or even laugh, those moments of not professional work, which allowed people to remain human. And those were moments that gave some rest to the nurses, even to the new nurses, and gave them the envy to remain and to remain in our units.
Thank you. I think that Sylvia and Victoria, you have contributed to let people voice their emotions and to make the ICU more humans. Maybe, Johannes, if you have 10 seconds for a concluding comment, and then we end the session.
Yeah, I would like to thank you very much for participating today. And we really get from the superhero discussion to what happens to families and how they were engaged. And I think overall, this was a very great contribution for everybody. And I thank you all very much, including Patricia, for making time coming today.
Thank you. Bye-bye. Thank you. Bye-bye.
Bye.
Thank you.
If there is been another important thing that in the pandemic we had to do with scientific societies and with scientific journals was filtering information and making sure that every information that goes out to bedside clinicians was reliable. We try to do that as a society with webinars, with events like this, but I really think we cannot underestimate the amount of work done by journals. As a society, we have two journals. One is intensive care medicine and one is intensive care medicine experimental. In this session, we will have the pleasure to discuss two important papers published in intensive care medicine. And I am going to be joined by the editor-in-chief of intensive care medicine, Giuseppe Citerio, that is also the head of the neuroanesthesia and neurointensive care unit at the Monza Hospital. Hello, Giuseppe. How are you?
Hello, Maurizio. Hello, Eli. I'm fine. I'm happy to be here.
Yeah, and let me thank you again because I know that it's been an enormous amount of work what you and the editorial team have done, and you are leading the most important journal dedicated only to intensive care medicine in the world, and I know that the task was not easy, and this has helped a lot bedside clinicians. So thank you, Giuseppe. The next panel member is Marcin Ozuchowski, who is the deputy editor of Intensive Care Medicine Experimental, which is a journal that is growing under the leadership of Nicole Uferman. And Marcin is also the head of Intensive Care Research and Sepsis, Trauma and Shock Group Leader at the Ludwig Boltzmann Institute for Experimental and Clinical Traumatology in Vienna, in Austria. Hello, Marcin, how are you?
Hi, Marcin. Hey, hello. Great to be with you guys.
We're happy to
from Vienna.
So, we will have also, of course, Ellie, that has led intensive care medicine to very high levels a few years ago. And to start, I would like to welcome the first speaker, who is Dr. Pedro Kurz. Dr. Kurz is an associate professor and medical supervisor at the Department of Neurointensive Care and in the Instituto Paulo Niemeyer State Brain Institute at the Hospital Copa Star in Rio de Janeiro, in Brazil, who is going to present the first paper that was published in intensive care medicine. Pedro, welcome.
Hi, Maurizio.
Hi, Pedro. Hello.
Thank you very much.
The stage is yours, Pedro.
Thank you, Mauricio. Thank you, Ellie. And it's a pleasure to be here presenting our work. I would like also to thank the organizers for the invitation. I will discuss here the findings of our study, published recently, called Evolving Changes in Mortality of 13,301 critically ill patients with COVID-19 over 8 months. So, just to put this, our study in context of the evolution of the pandemic in Brazil, this is a recent paper published by our group. In 250,000 hospital admissions for COVID-19 in the country, all over the country. This was a retrospective analysis of nationwide data, so less granular data. But the most important difference that I will discuss more in a bit is that this comes from all the regions in the country and includes all hospitalizations in a determined period of time from the start of the pandemic. And most of these patients were admitted in public hospitals in the national healthcare system, which differs a bit from our cohort that I will show in a few. Here we have 40% of the patients admitted to the ICU and a ICU mortality of 55%. We can see also on the right side of the screen that non-invasive respiratory support was increasingly used over time, and also that mortality was associated with stretches of age. These are still findings from this study. The study evaluated patients admitted from February to July 2020. So in the first 4 or 5 months of the pandemic in Brazil, the mortality of hospitalized patients was 38%. And the study also found a very high mortality in mechanically ventilated patients of 80%. Even in a young group of patients from 20 to 39 years old, mechanically ventilated, the mortality was 57%, and in older patients, it reached 87%. Also, what the study showed, but I would not go into details here, is that there was an important regional variation from north and northeast parts of the country to south and southeast parts of the country. So this context is important because in our study, our cohort includes only patients admitted to the ICU, but all the patients in our cohort were admitted to a private network of hospitals. And most of these hospitals and most of these patients were admitted in the southeast part of the country, which is the richest region and with the biggest cities and largest hospitals and tertiary hospitals. We included 126 ICUs in 42 hospitals, and we included a period from February to October 2020. This was data collected prospectively in an electronic database. The primary outcome of the study was 60-day mortality, and our main objective was to determine characteristics and support that were associated with outcome. In terms of the methodology, we separated the cohort in time periods that were defined based on the data and based on the mortality rates of the group. We used a breakpoint system based on structural changes in the mortality rates to define the periods of time examined. And we compared the clinical characteristics, organ support, and respiratory support over the 4 time periods that were found. In terms of statistical analysis, we used random effects multivariate Cox regression analysis adjusted for propensity score models. This is on the left side of the screen. You can see the curves of admissions and mortality rates, and also the time periods that were defined based on the structural changes. So basically what this does is it separates the data when there's a change in trend or an inflection point in the mortality rate. So we can see that over these 8 months, there were clear differences in time periods where an increase in admissions in a plateau in a high frequency, then a decrease in admissions in a plateau in a lower part of the curve. On the right side of the screen, we can see the survival probabilities of patients in the 4 time periods, and we can see in the 2 first periods the survivals were worse, at least in the first 2 to 3 weeks, and then they kind of get mixed up in the end of the 60-day observation period. In terms of the results, we included overall 13,000 patients, but we focused most of our analysis in patients that received either invasive or non-invasive respiratory support. These were 4,188 patients. The reason for this is that different than in the previous public healthcare system cohort, many of our patients that received only oxygen through a non-breather mask, they were admitted to the ICU in our hospitals. So we focused most of the analysis on the 4,000 that received advanced respiratory support because we thought this was more comparable to other cohorts published with COVID-19. The median age was 54 years old, length of stay medium was 8 days, and we observed an increasing use of non-invasive ventilation over the 4 time periods. It started from 8% of patients, with 1/4 of them in the last period, and a decreasing use of invasive mechanical ventilation as the first measure of advanced support, so without high flow or non-invasive first. Here we can see survival analysis, univariate survival analysis of age and frailty, showing that patients above 50 had worse survival probabilities over time, and also frail patients had worse survival. When we examine the respiratory support that patients received, and actually the respiratory strategy that was used, we can see on the right side that patients that received non-invasive respiratory support first, they had better survival as compared to patients that were intubated directly. And also on the smaller graph, we can see that even patients in green that had failure to non-invasive respiratory support showed similar, if not better, survival in comparison to patients that were directly intubated. When we analyzed the multivariate model, Cox regression model, adjusted for propensity score calculated. We found that after adjustments for all these covariates, the strategy that used non-invasive respiratory support first was associated with improved survival over 60 days with an adjusted hazard ratio of 0.59. So basically, these were the main findings of our study. We observed a mortality reduction over time, especially in the last 2 periods of the 8 months of the pandemic examined. Although we did not adjust for specific treatments, we didn't have individual data on steroids, anticoagulation, and other pharmacologic interventions. We adjusted the multivariate analysis for the periods that probably accounted for management improvements over time. We showed that 18% of NIRS used, 18% of patients used non-invasive respiratory support, which is higher than early cohorts from Europe and other countries that was less than 10%. And we ended up showing that the strategy of non-invasive first was independently associated with improved survival. We have some limitations in our study. This was an observational study. The treatment was not randomized. We don't have data on pneumonia and the extension of lung infiltrates. And we have very small numbers of patients with high flow nasal cannula that we cannot compare strategies of non-invasive support. And also, we did not have ventilatory parameters either in the invasive mechanically ventilated patients or in the non-invasive. These are 2 examples of randomized control trials that were either published or recently finished that probably will increase our understanding of the use of non-invasive. Thank you very much.
Thank you very much, Pedro, for a very nice presentation. And I know that the social media is already buzzing with questions. So I would like to call back the panel with Giuseppe Marcin and also to welcome Adrian Wong. Adrian is a friend, is also the chair of the editorial and publishing committee of ESICM, and he's the man behind a lot of the webinars and social media activities that the society has done this year. I know that Adrian is collecting some questions, but I would like to ask Giuseppe, as editor-in-chief, you've seen thousands of papers this year. Why was it important to publish this paper, Giuseppe?
I think there are some elements that we did consider for evaluating this paper and accepting this paper. First of all, the large number of patients that has been enrolled and studied. The second point is the setting. The study came from Brazil, and we didn't have at that time so many information on the treatment of COVID patients in Brazil. And the other point was that the data allow us to understand the changes of treatment over time and the result of these changes using non-invasive ventilation compared to intubation and mechanical ventilation. And the last point I would like to raise is that we were interested also about the use of the frailty index, because I think is one of the largest series in which frailty in COVID has been evaluated in more than 4,000 patients. So I think we see an effect of the therapies, an effect on the subject, of the frailty of the subject before coming to the hospital. And I think the granularity of data is quite high, and I hope that this data coming from South America will open a lot of new information coming from low and middle income countries that are still missing on COVID treatment in the ICU.
Thank you, Giuseppe. Maybe Adrian can ask a question, but just touching on Brazil, I have to say we were discussing with Eli before, the contribution of Brazil to knowledge in the pandemic has been extraordinary through large observational studies, trials. You really have contributed to save many lives also outside Brazil. Adrian, please, maybe you want to ask the first question?
Yes, thank you very much, Pedro, for a lovely presentation, and congratulations on the hard work of all your colleagues to produce the data. One of the questions that is emerging from social media, indeed, is a personal interest as well, is how much do you think the findings of your study are things unique to Brazil and will only happen in Brazil, as opposed to then being able translatable to all the other European settings, American settings, so on and so forth?
Thank you for the question. I think that there are some particularities to our cohort, but most of the treatments, most of the ICU care, and also the respiratory strategies used in this cohort are very similar to what is offered to patients and what is used in most in most of the countries that have high-level ICU care. So I think this is not a randomized control trial. We will see some randomized data in the near future about non-invasive ventilation. But I think our findings can give people some security that is safe to use this as a first strategy, and maybe using this before intubation in some patients can improve outcomes.
Maybe Marcin, you want to make a comment on this? Do you think this data is bringing some validity also to what we see outside Brazil, in Europe?
Absolutely, totally. I think that what we can use this, so this study serves as a platform for vertical and horizontal comparison. So by vertical, what I mean is that the Brazil itself can check how things progress over time once the sort of first critical care sort of normalizes and does not operate under extreme stress, right? But what's useful for Europe and other continents and other sites is that you can compare how sort of how the stress reactions in different countries or in different places sort of influence the level of care. And I fully agree with the last comment that given that dexamethasone is cheap and it's widely used, the proning is cheap and can be used, right? Or in non-invasive ventilation versus invasive ventilation is also fairly, available. Then at some point we'll be able to see, how the improvement of care that are incorporated into the current practices influence the outcomes at different sites. So I think it's a great comparison platform.
Very interesting point about non-invasive ventilation. We see it used more and more in the second and third wave, and when we see outcomes getting better. Now, I like to think that we are getting better, but can I maybe ask a provocative question to Pedro for his paper? Is it possible that maybe we are just testing more patients and we are finding more patients that are less sick, or that maybe even the behavior of patients has changed? I remember the first days in Lombardy, people were so scared to come to hospitals that they were coming only when they were in extremis, and later on they started to trust the system and to come there. I don't know if you want to comment on that, and then I see Ellie also want to say something.
Mauricio, it's not impossible, but I have the feeling that definitely patients are coming earlier instead of when they are very severe and very unstable. But I think we have improved our management overall. It's very difficult to define that one intervention is the responsible for the improved outcomes. But I think non-invasive ventilation is in a group of interventions that are improving outcomes of these patients, even if we are treating them earlier or in a less unstable moment.
And I agree with you, even if I asked you the question. Ellie.
Pedro, I would like to congratulate you, because I really believe that what Giuseppe said technically about what is the paper, how reliable are the data, how they have been handled, the granularity are, very, very precious. And, I really hope that under the umbrella of the society, you will bring all the data sets together to provide more comparative data for us to understand better what we can learn from you, what we, working together. I have a question that is very important from a society standpoint, which is the surge. I think that you have had a large period, you have dynamics, you have trajectories, and you have very nice data on each single ICU, as well as the occupancy rate and the way we were using an ICU bed at the time of surge. So can you measure the impact of strain and how the demand actually impacted on outcomes? Is it something you can have?
I think yes. We did not focus on that, Ellie, in this analysis, but we saw this network of hospitals being very fast and dynamic in upgrading the level of care that hospitals were able to give. We show in the paper that we increased ICU beds around 30% during the surges that we had. These 8 months included probably one big wave or two waves in the same time. And then we had our third wave in the end of the year, beginning of 21. And we also opened new ICU beds and closed it again. I think this is being looked at in terms of organizational factors and strain to see how this impacts or not impacts outcome.
Ellie, we are going to have some of this data from the Unite COVID study that is going to carry on. Adrian, I see from your eye movements that there are a lot of questions coming there. So
there is. I think I'm going to pick up your controversial question for another one with Pedro, which is, during the course of your data, you've noticed that instead of intubating very early, you started using more NIV and your outcome seems to have gotten better. How much do you think, as a clinician working in Brazil, that increase in NIV was because you ran out of mechanical ventilation and intubation rather than that was the right thing to do?
I can tell you for sure that in this cohort, it was the consequence of clinicians feeling safer to use non-invasive ventilation, which was the main obstacle to its use in the beginning, and also of them feeling safer as using it to improve patients' results. Definitely in this cohort, I can tell you that there was practically no limitation in terms of invasive mechanical ventilation. So it was really a clinician's choice to use it based on safety or of transmission.
Marcin, do you want to comment on this?
No, I'm cool. I think what he says pretty much.
We have the last few seconds. I don't know if Giuseppe wants to make a comment about this question or about some other aspects of the paper.
Not really, but I think an important point I would like to comment, Pedro, is about frailty. Could you give us some hints about what did your management change after the information that frailty was so important in your population?
Yes, this was a finding that from the very early on this was measured in our database, and we noticed that their outcomes were very different based on their frailty indexes. In Brazil, we don't have a strong culture of palliative care. So, and especially in a system where there was no limitation of invasive mechanical ventilation and ICU beds. I can tell you that this was not used in terms of screening or choosing where the patients would go based on their frailty or their age. But definitely in the beginning, we saw many older patients intubated and in our ICUs, and with time, they got younger and less frail. But I can tell you that in this cohort, there was not much change in terms of management or palliative care based on initial frailty data.
Clear. Pedro, congratulations again. It's a very important paper. Thank you all. Thank you, Adrian. We see Giuseppe and Marcin soon for the second paper that we are going to discuss. Thank you again.
Thank you and congratulations.
Thank you very much.
Thank you.
this is another open space for intensive care medicine, the ESICM journal, and we are delighted to welcome the chief editor, Giuseppe Citterio, as well as Marcin Osukowski, who is a deputy editor for ICM Experimental, the journal for which Nicole Juffermans is the chief editor. So today we are having our second published paper in ICM, that is the natural history, trajectory and management of mechanically ventilated COVID-19 patients in the UK. And I'm delighted to invite Dr. Brijesh Patel to present his manuscript, and then we will have time for feedback, discussions, and maybe some controversial issues. Thank you, Dr. Patel.
Thank you, everybody. I hope you can hear me clearly.
We hear you well.
Thank you for the invitation to present our work published in this month's edition of Intensive Care Medicine. This work, I have to say, was a part of a national effort, and I'm privileged to present this on behalf of all my colleagues on the COVID ICU project in the UK, but also those within the UK NHS that contributed data, but also their efforts, the wider NHS with the efforts to the pandemic. I've got no conflicts really to declare within this presentation. So 2020 really placed respiratory failure and what we do in ICU on the map, and also in the public eye. These are photos taken by the UK media at my hospital at the Royal Brompton during the first surge of the UK. However, we know that there have been numerous basic science, translational and clinical studies that have advanced our knowledge in ARDS, which is what we managed over the last year. But also, these studies have also tested life-saving interventions, which have shown improved outcomes in ARDS. In 2020, the COVID-19 research response led to novel pharmacological, but also non-pharmacological interventions to treat this devastating disease that we're seeing at the moment. However, the application of many established evidence-based, but also physiology-based interventions are often sequential part of clinical management that we have been delivering over the last number of decades. And the implementation really of these interventions are based on one, disease severity in terms of hypoxemia, but also the lack of response to less invasive interventions, which then move you along to the next intervention itself. However, we know that there remains an implementation gap in the bedside delivery of these interventions, which may be really enhanced during stress times during the pandemic. And this has been elegantly showed by many studies, and I've shown two here. The first by Dale Needham et al. And colleagues who examined the poor implementation of low tidal volume, but also the APRONET study, really funded through and supported by the ESICM Trials Group, studying the barriers to application of prone position. Indeed, this second translational gap, particularly of these life-saving interventions, will have an attributable mortality in ARDS during the pandemic. And so in March 2020, we realized that the granular management of COVID-19 on a day-to-day basis was not really being collected within any of the UK databases to evaluate the disease and what we did on ICU. And hence we launched the COVID ICU project. This was endorsed by the UK Intensive Care Society and really delivered by a huge effort from very committed and amazing folks during what was the most difficult period of the pandemic. We had two main aims. One, firstly, to better understand progression of COVID-19 disease in patients undergoing invasive mechanical ventilation across the pandemic. And secondly, to map the use and compliance, but also the duration and effect of established evidence-based ARDS interventions and management strategies. We included adults over the age of 18, and those patients undergoing invasive mechanical ventilation as a real entry point into ICU due to the real variation in service delivery during the surge. And those data, but we also included those patients where data were available from at least 48 hours of invasive mechanical ventilation, and across the whole ICU stay up to ICU discharge or death. But we focused really our first analysis on those admitted between the March 1st and the August 31st in terms of the dimensions of the first surge. We excluded patients that required ECMO, given the centralized provision of ECMO within the UK and the challenges of data curation across transfers between referring ICUs and ECMO centres. However, this is ongoing data collection. Overall, we developed a manual and electronic data collection pipeline curated by a specialist data science team. Really routine data were collected retrospectively as well as prospectively, which included admission demographics and very granular data as described here on the left. Overall, we aim to get a snapshot of what our efforts were, and 13 NHS organisations were able to contribute during overwhelming conditions. And these included 18 ICU sites, and approximately we captured 10% of all invasively mechanically ventilated patients during the first surge. This table in the supplement of the paper compares our cohort with published first surge data from the UK Intensive Care National Audit and Research Centre. And the ICNARC, really I have to applaud because they gave us weekly updates as to intensive care capacity nationally. But overall, our snapshot cohort was consistent with this national cohort described in this publication in Intensive Care Medicine in late 2020. The overall mortality for patients undergoing invasive mechanical ventilation within our cohort was 43%, consistent with the national outcome data of around 47% for that period. And mortality was highest if you were admitted in the 2 weeks around the first peak, when 50% of patients were admitted. And as you can see in the table also, the likelihood of having therapy withdrawn was also highest if you were admitted during those 2 weeks of this period. ICU mortality increased with admission severity, as we've all known, but median PF ratio was 12.3 kilopascals on the day of death itself. We performed a standard multivariate model, first of all, on just admission parameters and found that age, gender, but also a higher lactate and lower platelet count as per a higher SOFA coagulation score on admission was associated with worse outcomes. However, we also thought that actually, as these longitudinal analyses show between survivors and non-survivors, that the ICU stay is much more dynamic than just admission parameters. But actually, analyses should take into account the variable states of a patient at admission, particularly during stress times, but also the variable disease trajectory during ICU and the dynamic nature of ICU management, but also the application of our interventions which may modulate disease progression. And you can see here that I've just highlighted some of the parameters that really changed from admission between survivors and those, unfortunately, that passed away. Hence, we approached this by developing a deep learning framework to assess if mortality prediction improves per day of ICU admission. So we used two models, firstly a logistic regression model and a deep neural network model by the AI team that we were working with. And with these both these models, we found that the analysis of every sequential day of the first week showed an improved accuracy in mortality prediction, but also predictive capacity of outcome, including when we included effectively all of the data within the first week, was up to 76% as compared with 60% when we just took into account admission data. And this is just routinely collected clinical data. But really, we developed this machine learning framework not to give you a prediction of mortality, but really to dig deeper and to apply explainability or XAI analyses with shapely predictive modeling to really look under the hood of this data set, to really define which parameters became more important over the first week with respect to mortality prediction and progression of this disease. And in short, this sort of XAI analysis is defined as a SHAP value for each parameter, with essentially a higher SHAP value, meaning that the specific parameter is more important within that prediction model. And these parameters listed became more important over time within that week in mortality prediction. And the PF ratio became more important over time. And if you imagine, given that the whole model was more accurate by day 7, and particularly the accuracy increased per day, the relative contribution of the PF ratio at this time is even higher. And so essentially, some of these analyses suggest that this refractory hypoxemia was associated with worse prognosis, and actually probably supports a lot of the anecdotal feelings that we see by the bedside. So we further examined the impact of hypoxemia as measured by PF ratio. And this alluvial flow diagram really shows the changing state of oxygenation of all these patients over the whole ICU stay. Now, pre-COVID ARDS publications on the lung safe, but also the Berlin definition, have described this progression of hypoxemia, and Dr. Camperotta described this quite early on in the marathon today. But effectively, pre-COVID ARDS showed that 13 to 15% of patients changed to a worse hypoxemia category. What we show here that the COVID patients were twice as likely to progress with respect to hypoxemia, and less than 25% resolved their hypoxemia category over the first week. When we look at impact of this, indeed, looking at those that resolve over the first week with those that do not resolve their hypoxemia category, there's a stark difference in ICU mortality, with 60% mortality in non-resolvers versus just over 17% mortality in resolvers of hypoxemia. So that was our mapping, really, of basic mapping of disease trajectory and which factors really determine that. But after characterizing this progression, we then aim to examine and map on top of that the application and effect of our ICU interventions. So this diagram shows that the interventions that were applied in bold color, and it also shows the significant applications of higher PEEP, and we've defined that as greater than 10, but also neuromuscular blockade, inhaled vasodilators, but also diuretics and renal replacement therapy within the first surge. And actually, there's a lot of random applications of many therapies, some of which would have been on the randomized control trials that we implemented at the time. But focusing on common lung protective interventions, given the time restraints that we have, we found that despite systematic errors in calculation of ideal body weight, leading to what is a higher tidal volume delivery than thought by the caregiver, most patients received less than 8 mils per kilo with a plateau pressure of less than 30, suggesting that the respiratory mechanics of this disease were dissimilar to the pre-COVID ARDS. But also, we examined matched changes in PEEP and PF ratio in the sequential 12-hour measurements and the granular data that we were collecting. And what this figure shows, that changes in PEEP really were quite widespread, especially across the first 2 weeks of mechanical ventilation. But basically, this shows that it led to quite variable responses in terms of PF ratio change, suggesting that actually we need to apply better, a more personalized approach to PEEP settings. Finally, we went on to really focus our attention on the application and responsiveness of prone position. Prone position was applied in just under 50% of all of our patients, and at a median 2 intubation, and for an average of 2 days, which is somewhat less than many other papers that are currently published. But a greater admission severity really led to an earlier application of prone position. So if you had severe hypoxemia on admission, your application was 2 days earlier. Indeed, when we examined PF ratio change around the first prone event, we found that prone position had a better effect the earlier it was applied after the onset of invasive mechanical ventilation. And this supports many previous studies advocating prone positioning within 48 hours. However, this really depends on whether your disease trajectory and severity triggers the application of prone position. And so to define this a bit better, we sought to examine the timing of prone position in relation to disease severity and measured effectively the missed opportunities for prone intervention to try and quantify the barriers to implementation, but also the lack of implementation, and so this translational gap that we're seeing. And we defined a missed opportunity as per ProSEVA inclusion criteria, as listed here in bold. And given that we obtained twice daily data, each opportunity effectively represented a 12-hour period by which prone position could have been intervened. But we found that 76% of patients who had moderate hypoxemia and 46% of patients who had severe hypoxemia at any stage of their ICU admission did not undergo prone position at all. There was 1 prone opportunity missed per patient in all comers during the first 48 hours. There's also a greater number of missed prone opportunities in those patients that died versus those that survived without receiving prone position. And this is quite an important aspect because we really missed maybe 3 to 3.5 days of an opportunity to apply prone position as per ProSIVA criteria. But even in those patients who received prone interventions, there was a median of 3 prone opportunities that were completely missed per patient before the first prone event. So overall, this picture gives us the application of prone position was one, significantly delayed, but also applied mainly in the more severe forms of COVID-19, possibly as a rescue therapy, but also possibly because the system was quite overwhelmed. We went on to further examine, and this is in the supplementary data, the application of prone position in the resolvers and non-resolvers of hypoxemia that I described before in the first week. And we found that only 60% of patients that did not resolve hypoxemia, or either non-resolvers in the first week, interventions applied. And the non-resolvers in the first week had a greater number of missed opportunities, but also had prone positioning applied 2 days later than those that had resolved. But this is the short-term effect, but also we know that a lot of the prone applications that we've had, there's been longer-term hypoxemia effects, and there was a stage of give up of prone position. And so to ascertain the longer-term impact on gas exchange, we examined oxygenation responses of after the first prone event. And we decided as a patient that maintained a PF ratio greater than 150 over the 7 days after the first prone episode. We found that only 44% of patients that received prone position had a sustained PF response over the first week. Prone responders and non-responders had the same number of prone episodes, and the first prone episode was applied at a similar time after intubation. However, prone non-responders had more missed opportunities, and really had a delayed application of the first prone position. And indeed, prone responders showed improved respiratory mechanics with better CO2 clearance despite similar minute ventilation, but also an improved peak pressure, oxygenation index, and ventilatory ratio over this time. So prone position is not simply an oxygenation response, but it's also a mitigation of trying to mitigate ventilator-induced lung injury. Importantly, mortality analysis showed that prone non-responders had nearly a 70% mortality versus 31% in those that responded in terms of oxygenation alone. And that's quite a stark difference in terms of what we find in terms of prone responsiveness. Finally, really to analyze which factors, clinical factors, immediately before the first prone intervention through a multivariate analysis showed prediction of the lack of prone responsiveness. We performed this multivariate model, and we found that a higher age, worse lung failure with higher peak pressures, but also a higher respiratory SOFA score, but greater hemodynamic compromise, as shown by a cardiovascular SOFA and possibly a lactate, were associated with non-responsiveness, were independently associated with non-responsiveness to prone position, suggesting that this coagulation effect and the clotting effect within the pulmonary vasculature may have a significant role. So to summarize, our first output of the COVID ICU evaluation from the first surge used explainable AI analytics to really showcase the increasing importance of gas exchange, but also inflammation, thrombosis, and very subtle hemodynamic disturbances within in relation to outcomes. But this worsening respiratory failure is as a result of disease factors, but also our management factors of poor implementation, potentially, but also a lack of response of standard ARDS interventions, which may be because we delayed our response, our application of prone position. So there is a significant implementation gap in the application of these interventions during a pandemic stress, but also the delayed application which may contribute to this lack of responsiveness. But really, to summarize, a standing evaluation such as this may really help us understand the changing disease, but also that with respect to novel interventions that are going in specifically for COVID-19, but also the changing management and the implementation gaps across the pandemic. So finally, a thank you to the patients, families, teams across the NHS, but also Imperial College COVID and Bronson and Harefield charities that really funded this, And finally, really to the UKRI Imperial AI for Healthcare Network and my clinical and research team here. And really to the ESICM and the ICM Journal itself for organizing this exceptional knowledge sharing day today. Thank you very much.
Thank you very much, Dr. Patel, for not only providing your data, but also explaining very well how you did manage them. As you can see, we are now with Giuseppe and Marcin, who are, Giuseppe is the chief editor of Intensive Care Medicine, Marcin is the deputy editor of Intensive Care Experimental. Villa Antonini is our social media animator, and I'm here and very pleased to be with the president, Professor Maurizio Cecconi. So, Dr. Patel, we can discuss a lot, and there is a lot to say and to comment on your paper. I must say very briefly that I appreciate the way you are dealing with the definitions, but there is a competing issue in many of your variables, so this is something we can discuss. So my first question would go to the chief editor. So why did you accept this paper? And Giuseppe, maybe this is the opportunity for all of us to tell us what is the next paper that you expect from us on COVID-19.
The paper we are expecting is something you alluded to a paper with try to unify many data sets in order to have a better understanding of the disease and comparing different regions and treatment. And going to this paper, we decided to accept this paper for many reasons. The first one is the granularity of the data. We receive almost every day some manuscript that look at the predictive values at the entrance of a patient and looking at the entry value, looking at the mortality or the severity of the disease. This paper studied for a week the trajectory of the parameters, and I think is clinically sound because represents something that we look at the bedside. The patient is going to improve, and so we have a better outcome. And following the data over the week, we can consolidate our prognostic evaluation. The second point is that the analysis of the data underline that there were some missing opportunity, and I think we wanted to stress this point because we discussed a lot today about strategies, and we think that all the patients are exposed to the best practice, and sometimes we are not doing our best, for example, in applying proning position. And I think this is an important message because we accumulate knowledge and we need to put knowledge in practice. And I think it's very honest, the paper by Patel and others saying that we know, for example, that prone position is important, but we didn't apply so often. And we can understand the response of the applying a strategy on the trend of the patient over time. But I think I would like to also to thank the authors for the robust analysis they provide. And you can find a lot of information in the supplement that I think are interesting to read.
Thank you very much, Giuseppe. And it's now for Villa Antonini, and I think everyone knows you and everyone is fond of you for the energy and all the wonderful messages that you pass on the social media. So please, Villa, any comment, any feedback from anyone surrounding your social media?
Yes, we have a question from Twitter about prone positioning. Could considering PF ratio as suggestive of responsiveness to proning be enough? What about the duration of the proning sessions?
Yeah, thanks, William. That's a very good question, and actually, reviewers' comments on that. I think we weren't able to collect those data, is the honest truth, and I think the duration of the proning sessions was potentially quite variable within the data collection itself. But I think as the question says quite rightly, you know, the Proceva trial is 16 hours prone position from a logistic perspective. We weren't able to collect that data, but I would hope that if someone is prone then they would be deproned. But I know anecdotally that there were many patients who weren't deproned as well, and so we weren't able to collect that data. It wasn't documented as routinely as many of the other clinical parameters.
Well, I have a comment, Dr. Patel, on this specific point. Your model is actually computing time to event. And we know that we can sometimes save some patients using ECMO and sometimes prolong their course over weeks. So did you made a lot of efforts to standardize what you were referring to, and prone positioning, response to prone positioning has been modelized and very nicely. So did you actually assess maybe externally what were the indications for ECMO and whether they were missed themselves? And then after your answer, I will pass the voice to Maurizio Cecconi.
Yeah, it's very interesting. So I think the nature of the way in which the ECMO service is delivered within the UK with 5+2 surge centres really became quite difficult. I mean, we work in an ECMO centre, and one of the reasons to launch this was when we get phoned for advice. It was really important for us to understand what trajectory was happening prior to the phone call that we got. But looking, just to put this into context, up to 20% of all patients that underwent invasive mechanical ventilation were referred to the severe acute respiratory failure / ECMO network that we have within the UK. And I think the two databases are somewhat separate, and we're currently now doing a similar analysis on the ECMO referral database that we have. But really looking at this, I think the challenge has always been the ECMO criteria that are placed. And actually, one of the questions that I had was, many a time is that we have proned this patient 5-6 times now, and there is no real improvement. And then the referral for ECMO came on. I think one of the important aspects is the delay in prone position, because once you delay by 2 or 3 days, actually you're then trying another intervention for maybe 3, 4, 5 days. And I know some of the criteria that we use within the UK in terms of ECMO eligibility is based on the RESP score, which effectively is duration of mechanical ventilation. So any delay in all of these interventions has a sequential knock-on effect on whether you'll be able to be suitably placed onto ECMO.
Thank you, Dr. Patel. And one last comment from...
I just wanted to make a comment, congratulating you for the paper, but also intensive care medicine for putting this paper forward, because while we know that randomized controlled trials are the way to test for an intervention, we have a lot of interventions that have demonstrated benefit, but then we don't implement them at the bedside. And to have large data sets where we use machine learning techniques to see if something that we know should work didn't work because it was not applied early maybe, it's very important. It's a very important message and very important evidence that informs our practice. So thank you very much and congratulations on the paper.
Thank you, Maurizio.
Well, thank you again, Dr. Patel. And we are looking forward to your next production. And we are looking forward to see all of you in real. But for now, we still have some part of this marathon, ESICM marathon. And I would like to thank you and to end this session to move to the last session of the marathon. Thank you again, and thank you ICM for all the hard work and the excellent selections of the 2 wonderful papers we have just had the pleasure to hear and to comment on.
Thank you.
Thank you.
Well, it's been quite a few hours on this marathon, but we are still have to have some road to do together, and we're going to do this road with some great speakers from different parts of the world. We've learned a lot this year. We've really learned a lot, but the big question is now, how are we going to build the future? And the future is going to be what lies ahead in the next months, but I think more importantly maybe is how are we going to build the future of healthcare, of our intensive care units, and how are we going to be prepared maybe for the next pandemic. I'm going to be joined in this debate again by Elia Zuley and also by some fantastic speakers. So the first one I would like to introduce is Professor Anna Wunsch from the Division of Critical Care Medicine at the University of Toronto. Hello, Anna, and welcome.
Hello, thank you very much.
How are you?
Good to see you.
Great to see you. Professor Mervyn Mayer from South Africa. We all know Mervyn. Mervyn has been involved with a lot of activities related to the ALIVE Fund and some activities in low and middle income countries. Hello, Mervyn.
Hi, everyone. Thank you so very much for the opportunity to join you amongst this very esteemed group.
Great to see you here, Mervyn. Professor Susana Lobo. Professor Susana Lobo, she is the current president. I see Sheila here. It's great to see Sheila. Maybe I'll introduce Sheila then, or, okay, hold the camera there. It's great to see Susana Lobo. Susana is the president of the Brazilian Society of Intensive Care Medicine. She's been a great contributor also to the relationship with the European Society of Intensive Care Medicine. It's great to see you, Susana.
Hello, Susana.
Hello, great to see you all. Thank you for the invitation.
Now we can have Sheila Miatra, Professor Sheila Miatra. She's a consultant in intensive care medicine. Hi, Sheila. Hi, Sheila. I know it's very early in the morning or very late at night for you, so thank you so much for being with us.
Hello, everybody. Happy to be here. Thank you for the invitation.
And Sheila, she is a consultant in anesthesia and intensive care and a professor at the Tata Memorial Hospital in Mumbai. And she's been really a member of our society, contributing to many activities of our society for a long time. And last but not least, Dr. Lenny Derde from the Utrecht University Medical Center. Hi, Lenny.
Hi, Lenny.
Lenny has played a very, very important role in this pandemic. She is the co-lead at European level REMAP CAP, one of the research platform studies that were contributed to bring so much research that we could bring at the bedside. So great to see you, Lenny.
Lovely to be here. Thank you.
So now that our panel is complete, I think it's time to warm a little bit the debate. I would like to start maybe with Anna Wunsch. And Anna, last year at the beginning of the pandemic, if I can have Anna maybe on stage, at the beginning of the pandemic, you wrote a piece, which I think was published on the Nature website, bringing some comparisons between the polio pandemic of 1952 in Copenhagen, where we would have loved to be next year, if next autumn, if the pandemic was not there. We know that the pandemic of polio in Copenhagen was the beginning, basically, of modern intensive care. Anna, what have we learned from that we brought to this pandemic, and what are we learning from this pandemic that we can leave to the next generations?
Thanks so much. It's a great question. Just within sort of two sentences, first, for those of you not familiar with the Copenhagen polio epidemic, because I've actually discovered many kind of younger generations of intensivists aren't. It was in 1952, a very large outbreak in Copenhagen where they only had one iron lung. And it caused them really to innovate, to recognize for the first time and kind of prove to the world that positive pressure ventilation through tracheostomies was a successful way to ventilate people longer term, not just in the operating room. And because they didn't have ventilators at the time, they actually used medical students, up to about 1,600 of them over the course of months, and saved many hundreds of lives this way. And just as a very tiny plug, I'm in the midst of writing a book on the topic, so I have a lot more to say, hopefully at a future date. But I think there's a lot of parallels. collapse, right? A system over
so scared
by critical illness, having to find ways to innovate. And that's clearly what's been done on so many levels throughout COVID. I think there's a lot, that's sort of the obvious parallel, and that this created a real sort of shift in thinking about how to take care of patients. And I think we're seeing similar shifts with COVID, and that the main thing that I think is maybe not talked about so much is the fact that what we learned with polio was then extrapolated with mechanical ventilation across really a whole range of different diseases. And I would guess, kind of thinking about the future, is that we're going to see a lot of the lessons from things we've had to do to innovate in COVID, really looking at different means of non-invasive ventilation, thinking about timing of invasive ventilation, that those things will be extrapolated then not just to COVID, but really pushing us to think more broadly about how we take care of all of our patients with a lot of different diseases in critical care. And then lastly, I would argue that John West wrote a nice piece saying that there was a lot of physiology that was learned during that epidemic, and really respiratory physiology came into its own when people were able to use that sort of laboratory of the polio epidemic to make some insightful comments about physiology. Again, I think we're seeing the same thing now, that we're seeing a lot of people turning their brains to thinking about respiratory physiology and mechanics and mechanical ventilation. That was always there in the background with a lot of great researchers, but now we're seeing just the entire world thinking about it.
And I also think that there are pictures of some of those medical students that became leaders in the field of intensive care a few years later. And I know that we are all tired and there is fatigue and burnout, and we are worried about losing some of the people in our intensive care units. But actually, I hope that maybe what we are seeing today is going to inspire the next generation actually to come to intensive care and to grow the intensive care of the future. Ellie, I know you want to ask a question too.
Absolutely, I agree.
So, thank you very much, Hannah. I'm now going to ask a question to Sheila. Good evening, Sheila. I'm very happy to see all of you and to see you. Sheila, as you know, we were in close contact, and we know that in India, not only the first wave has been very high and very long, but also the second wave has hit India very, very badly. And we also had very terrible nightmares about the issue of oxygen. And you know, there is so much infodemia that we hear a lot of things on the media, and we are never really sure of what happens. So can we have more information about this infodemia and what was the real situation about supply of oxygen and access to oxygen of our Indian friends and colleagues?
Right. Thank you, Professor Azoulay, for this question. So there was a stark contrast between what happened in the first wave and the second wave. So when the pandemic began globally around March, we had one of the very early and very strict lockdown, one of the largest lockdowns in the history of the planet. And the pandemic really began in India only mid-May. So we had around 2 months to prepare. And to be honest, we were very worried because with such a large population, so much overcrowding, developing nation with limited infrastructure, but we had 2 months to prepare. And I think we did pretty well at that time, and we really geared up and prepared for the pandemic. And, in the first wave, we had a large number of cases in proportion to our population, but we did fairly well. And this first wave went on for a very, very long time. And finally, by around November, the cases started coming down. And by January and February, the pandemic was almost over in India. We had very few cases. And in addition to this, the vaccination also came. So we started completely opening up. The confidence level started becoming very high. All the infrastructure we had built up, the extra facilities, everything started shutting down. In fact, people almost believed that we would not have a second wave. And I think we paid a very big price for this complacency because we were patting ourselves on the back, such a big country with such a large population, and we didn't have such a high mortality. And then we had almost 5 times the number of cases. And not only were the number of cases high, but it was in a very short period of time. The escalation was very rapid, and we were so ill prepared. And the number of cases coming in, I don't think any healthcare system in the world can handle this kind of a surge. And this was completely unanticipated, something we were so ill prepared for. And for the first time, I experienced something that I'd never seen, oxygen shortage. All along, we were preparing for increasing the number of ventilators, and we never thought that we would run out of oxygen. And when you have a situation where you are dealing with almost 17 times the requirement of oxygen in a day, even the capital city like New Delhi ran out of oxygen. So this was a very, very scary situation. And I don't think once these patients start coming into the hospitals and in the intensive care unit, much can be done. It really has to be controlled in the community. So I think this was a very big lesson that we learned. And we've also started for the first time thinking about how we can conserve oxygen. And this is not something we really thought about, different measures that we could do in a pandemic, in a situation like this. So there are a lot of lessons that we've learned between the two waves.
Yeah, and I think that you are raising very important points. The first lecture today from Dr. Lindström from the WHO was about a comparison across different social systems. And we, as ICU specialists, we are used to evaluate the physiological reserve of our patients, which could be called frailty or another marker of comorbid conditions. So now we need to understand better from the reserve of our healthcare systems. And you report something that is very interesting about preparedness. And this is not specific to India. It has occurred in many European countries and in many countries all over the world. And so I think that we share this experience, and I hope that we will have the opportunity to meet and to discuss more and to know what we can learn from this. Thank you very much, Professor Miatra.
Yeah, and what is interesting, Eli and Sheila, is also the fact that the pandemic is shown also for high-income countries and places where we never had a problem, that everyone can go into a limited resource settings at some point. This is what happened to me in Italy, and I think you said it very nicely, Sheila, is that no healthcare system can manage an uncontrolled outbreak. When the infections are exponential there, it just is impossible to control. I always learn a lot from my friend Mervyn in this sense, because he's been teaching us about how to deal when there are limited resources, and we were in touch also the very early stages of the pandemic. First of all, I would like to know how's it going there now. Mervyn, we heard from Dr. Lindström about vaccines and the fact that we need to find ways for an equitable access to vaccines, and I could not agree more. I think first is ethically right to do so, and second, if we don't control the pandemic everywhere in the world, that could be new variants that could bring the virus back where we thought that it was gone. How's it going, Mervyn? What can we do to help in these settings?
Well, thank you very much, Maurizio. Certainly the vaccine issue is a major problem, and inequity in low-middle income countries is a very real issue. In fact, in my own country, in South Africa, currently, less than half of the healthcare workers have been vaccinated. And in fact, in that context, it has only been within the context of a trial. So there hasn't been readily available vaccine available for healthcare workers. It's been part of a trial. For the community out there, in fact, this week was the first week that some vaccines have been made available in the community. And that obviously carries huge risks in resource-limited settings. We went through a massive first wave, a massive second wave, and we're now entering potentially another massive third wave with the same vulnerable people that are out there. That having been said and recognizing that, I think, as I've shared previously, there's no country in the world that could have been adequately prepared, and I share the same sentiments as Sheila. I think preparation is pivotal. We also had the opportunity of a couple of months of benefit relative to the rest of the world, and we put in a lot of preparation. And just to give a little bit of a background so that we can really look at the perspective of things, in a country like South Africa, where there is a population of 60 million people, functional intensive care specialists, only about 35 to 45 in the whole country. And that is the reality of what we had to face. And to give you an idea, and we've had more than 55,000 recorded deaths, and that's nowhere near the reality of the situation. The number of excess deaths is 3 or 4-fold that, based on current data. And so I've always been an advocate that challenges bring opportunity. And one of the entities that we did with the availability of potential preparation and perhaps some insights and lessons from the rest of the world, seeing what was going on, we in fact tried to engage social responsibility, and in fact very early on advocated that rather than building field hospitals, we faced the same situations as in India. In fact, on many days there's sometimes no water supply. I think we've had rolling blackouts, electricity failures over the last short while for more than 100 days. So real challenges that we are facing, together with the logistics, the human resource entities. But we were able to actually, with social responsibility, more than treble our facility so that we could accommodate patients. And we were a major referral hospital, and we were able to manage, in fact, the vast bulk of patients. And that was based on an entity that I feel very strongly about, and that's simplicity. If you do the simple things well, you're likely to have suitable outcomes. And being poor doesn't necessarily mean poor care. In fact, sound practice is both feasible and excellent quality care is definitively possible. And just yesterday, we were involved in the biggest study that's come out of Africa, which was published in the Lancet, called the ACOS study, which is an acronym that stands for African COVID-19 Critical Care Outcomes Study. And to put everything into perspective, on this second biggest continent and the second most populous continent, in fact, mortalities are much higher than anywhere else. And that includes North America, Europe, South America, and Asia. Significantly greater mortalities. And to put that into perspective, between 11 and 23 excess deaths per 100 patients. Insufficient critical care resources, definitively documented. In fact, in terms of referrals of patients, less than 50% of patients referred for critical care were able to be accommodated. If we looked at what happens elsewhere in the world, essential entities that are often taken for granted, like dialysis where necessary, in fact, only 1 in 7 patients had access to that.
Mervyn, I think this is very important data, and there are sobering statistics, and I would like to thank you again for all your work that you're doing also with the Global Intensive Care group, also to bring the information out to the outside world, because when we want to help, it's very important to realize that we can help only in the way that is needed. And you've been telling us that we need to find ways to tailor education to these settings for providing care that is simple and effective. And I think that's what we will try to do with you and with your guidance for some of these courses. So count on us. We wish we could have done more and better before, but we are here to support you in this. Eli.
So thank you, Mervyn. And I would like now to ask Professor Susana Lobo about many different aspects of COVID-19 infection in Brazil. But I need to start by bringing our congratulations on what the Critical Care Brazil has done, because you have been amazing by producing a high-level research in wonderful journals, very nice studies, bringing knowledge and transferring knowledge to the bedside, and I think it has been very useful. Just a few minutes ago, we have had the pleasure to have Dr. Jorge Pedro Kurtz from Rio de Janeiro with this wonderful study that was published in Intensive Care Medicine, and really nice data, nicely analyzed, and we really congratulate our colleagues from Brazil. Well, at the same time, we have a lot of information about COVID-19 infection in Critical Care Brazil, but how was the infection in the community? How was the access to hospitals and critical care? In France, for example, where I live, some hospitals were so full that some patients were brought back home with a bottle of oxygen. So, and we know, I don't think that this is so specific to countries, but you provided a lot of data on COVID-19 in the ICUs, but we have had less data from Brazil on how was the reality of the pandemic in the community.
Thank you, Ellie, and thank you, Mauricio, for the nice comments and for really the Brazilian researchers have been done wonderful work. And thank you for your question. ICU work in Brazil has been relentless. Pandemic is hit badly Brazil, all regions equally. Important to say to you to know that the healthcare system in Brazil is universal. It means free for all. However, with many regional and social disparities. In the last 20 months, the number of ICU beds dedicated for COVID-19 patients has grown 150%. We started with 48,000 beds and we reached 60,000, even though Brazilian hospitals remain crowded. And sometimes we run out of drugs, equipment, health professions, and even oxygen in some places. Scarcity of intensivists was a big issue. And sometimes we had some place we had to use triage protocols. About the control in the community, we have some lessons to learn here, maybe what not to do. In fact, the pandemic was poorly managed outside the hospital. In a year, we have had 4 ministers of health and a constant political battle among the 3 government levels. The crisis here was characterized by miscommunication with the public, playing down the severity of the disease, insufficient lockdowns for fear of economic loss, insufficient cash assistance for the more vulnerable population, lack of testing, vaccination is low. Now only 10% of the population had 2 doses. The second wave came in January from Amazonas with a new variant of concern, the variant of concern, the P1, that spread very quickly to other states and became the protagonist variant throughout the country, with higher transmissibility, reduced the neutralization, and the big problem here. We are now, to end, we are now in a very high plateau of cases and deaths. Anyway, Brazilian has now more deaths and unemployment than most countries. We have more deaths than 90% of the countries, according to WHO data. And we are now possibly heading to a third wave. But just to finalize, we have some case of success, of good management. One example, it was a research in Favela da Maré in Rio. We see this favela has a population of 100,000, more than this, a little bit more than this population. This research was run by Fiocruz and some scientists, and they showed that with good communication, social assistance, tests, contact tracing, and that isolation, it was a research, they got an 8% reduction in cases.
Thank you very much, Susanna. And I think that these are helpful comments to understand better the biggest picture about how was the system in Brazil. And actually, I'm sure that we have the feeling that we share many common points. And I think that would be a very important thing to better understand differences across our settings, to know how we are going to handle, I hope not the next waves, but maybe the next health issues in our countries.
And it's a session about rebuilding the future. We are hearing so many stories that we can all relate to, difficult, but the positive is that if we focus on controlling the infection in the community, and that's a message that we need to have the strength and be brave enough as an intensive care community to tell to public health, to governments, is that we are the last line of defense. We will be ready, but this battle is won out in the community with the control of the infection. And this is a very important message to pass for the future. When the crisis started, I told myself, I'm not ready, and I don't think many people were ready. But if there was one thing that I think was really a very positive story in all this pandemic, was how fast research was progressing, probably thanks to some of the progress and some of the research of the previous 20 years, and in particular something completely new, which was research platforms, preparedness research platforms, which is something that some people started to work with some vision some years ago. And that's why I would like to ask the question now to Lenny, because Lenny is leading the European, co-leading the European branch of REMAP-CAP, which really has been one of the few research platforms, together with Recovery and Solidarity, that they brought so much evidence out there that changed practice and saved lives. So Lenny, tell us a little bit about your experience with this, and more importantly, how can we capitalize and how can we grow this for the intensive care community for the future?
Thanks, Maurizio. Sorry. Yeah, that's a really important question. And as you say, one of the things that we hoped could contribute in this pandemic was setting up an adaptive platform trial way before the pandemic and building it in such a way, that it could pivot during the pandemic. So that's what we did, and we started doing that in 2014, because we knew that if the ICU was ever going to be involved majorly in a pandemic, it would be a respiratory infection, and then most likely a viral infection. So what we thought is, if we start doing a trial that answers, the many questions we still have for CAP, we can then pivot to investigating any, new variant of CAP that will occur in a pandemic, and that's what happened at the start of 2020. However, I don't think that adaptive platform trials are the answer to everything. What really resonated with me was some of the things that my colleagues here said. So Hannah said that the polio epidemic brought innovation. And I think, that also relates to, I think, my work in REMAP-CAP, is that was really an innovative way of doing randomized controlled trials. And we're now seeing the benefit of that. But there are many other ways to innovate. And another thing is something that Mervyn said, is that challenges bring opportunity. And I do hope that this, pandemic, that we can definitely call a challenge, has brought us the opportunity. And there are a couple of things I think are key for research going forward. The first thing is, we do need it. I mean, I know, in a pandemic and a surge and you're overwhelmed and the last thing you want to think about is research. But the only way out of the pandemic, and that is, I think, what we've seen is, research at many levels. And I think there are a couple of key things. The first thing is, it's really a team sport. And luckily, we as intensivists and ICU nurses, we are team players, because that's what we do every day. And I think that could benefit us in the future if we try to build research structures. So I think that can be very helpful. The second thing is, I really think research should be more really in our DNA. And that has two kind of angles. The first angle is, I really think that research should be in our education as intensivists more than it is now. And what I don't mean is that everybody has to be a trialist or a basic researcher, but, intensivists have to kind of know at least how to read a manuscript. And some may want to, have a career in research or a partial career in research. Then we have to find ways to support them. And we should also, embrace the opportunity to give people from countries like South Africa, India, Brazil, low and middle income countries, also an opportunity to participate in that. And I think ESICM can play a role there. The other side of that same medal, sorry for my voice, it's not coronavirus, I promise, is that our patients also deserve that we do research. So I really think the question should not be... I
think that's such an important point, Lenny. When I was in the UK, I was seeing the development of the NHR, which is this network to deliver research. And I remember the mindset changed completely when we said that we wanted to give patients the opportunity to be in a research trial, which is completely different from what we were thinking in the past. I hope I will be able to get a patient. Now it's different. We know that being in research is good for you, and I think that's where we have to invest. We've been talking about teams. How are our teams, Ellie?
Well, this is something that I think is interesting to share together. Well, in my country, for example, many teams complain because every week one ICU nurse declares that she or he would leave the ICU in the next weeks or in the next month. I must say that there are many different symptoms. One is physical exhaustion, and two is a kind of insatisfaction with the system. You know that ICU nurses are not working the same way in all our countries. For example, in some of our countries, the ratio is 1-to-1, or sometimes for ECMO patient, 2 nurses for 1 patient. But in other countries, and I was very interested about what you said, Merv, we are not having the same way to organize our ICUs and the same number of people caring for our patients. So I think that making a very quick roundtable about what is your feeling and how this pandemic and the successive waves are going to influence the I wouldn't say burnout. I think that we are having a lot of symptoms. One of the symptoms that is prevalent is physical exhaustion. And then comes after this kind of moral distress at some places where nurses have had to witness some hasty decisions. Any decision, sometimes decision for getting to the ICU, and sometimes it's an early discharge decision, and sometimes, unfortunately, is an end-of-life decision. And another group of symptoms that we see more in doctors is the feeling that they could do better, but the surge and the strain deprive them to provide the best care they could do. So what's your feeling? Maurizio, maybe you could start and tell us how is the situation in Italy?
I think I can relate to what everyone was saying, and the fact that first of all we need to acknowledge that we had a very tough year.
Yes.
This was not normal. We had to fight against tiredness, many shifts, sometimes also against the information. We had many reports of ICU capacity being reported as 30 or 40%. Well, actually, we know that those were just the COVID patients, but actually most of our units, they were full of COVID and non-COVID patients, and we were running 150, 160% capacity with the same staff. Acknowledging that, and I think acknowledging that also as leaders, that the quality that you provide during a surge is different.
Of course.
Is saving an extra life, but sometimes is maybe not being able to do the things they were doing. I remember speaking with some nurses, and they were feeling very stressed because they didn't have the time to shave the beard or to cut the nails. It's not going to save the life, but it's the quality that they were used before. So first of all, we need to acknowledge this. We need to speak with the institutions about the fact that our teams in hospitals had a long time working with this. We need to acknowledge this. We need to demand also that we are going to need some time to heal and to get back this energy and not to put it under the carpet. I think, first of all, this is the thing. Already talking about this, bringing it out there, I think it's something very important. And then, of course, passing the message that we cannot just increase ICU beds, but again, we need to find ways to control this in the community with vaccines, with public health measures, and so on.
And with the results that will be coming, that when critical care is performed outside the ICU walls, outcome cannot be the same. So that's obvious. We already have 6 or 7 papers showing that when we are changing a nurse-to-patient ratio, not only we decrease quality of care, we increase nurse burnout, and of course we also increase length of stay, duration of mechanical ventilation, and unfortunately mortality. Hannah, maybe any feedback from North America? The US, Canada, do you share this experience?
Yeah, absolutely. I think this is a universal, but I think it's also important for us to acknowledge that this was going on long before COVID hit. We're seeing the extreme version of it with COVID. But I was asked at a party about 5 years ago what I did, and the follow-up question to me was, what sort of support do they give you psychologically to do that job? And I was sort of stunned by the question at the time because it's not a conversation that our community had been having regularly in sessions like this about the need for support of the caregivers themselves. So, stepping back, I realized at that time that it was incredibly important and that we were very sort of behind in terms of talking and thinking about these issues. COVID, I would view as a horrific experience, but then also an opportunity for the future because it's brought it out of the sort of the shadows and the shame of people admitting that they need help and support in various ways. I have seen models where psychologists and psychiatrists are kind of embedded as part of the ICU team there to debrief with nurses, physicians, other caregivers after particularly challenging situations and cases. I think that that's a fantastic model that we should all, when we can all take a deep breath, think about implementing, and that we need to just make it more of the everyday conversation to be asking people how they're doing.
I think it's very interesting what Anna just said, is that we used to do this before COVID.
Of course.
And COVID at some point will end, but COVID is probably part of the family of sepsis, and sepsis is here to stay for all sorts of reasons. Are we doing enough? Maybe Sheila, if you want to comment on this, are we doing enough to inform the lay public that sepsis exists, that long COVID is something that we're seeing, for instance, with sepsis, so that people don't think that when the COVID is finished, we don't have anything to worry anymore about other infections and about what's happening in intensive care and with ICU survivors?
Right. Thank you. That's a very good question. Actually, I'm very worried because whenever we do teaching, we do meetings, the only thing people want to know about, learn about is COVID. It's almost like once this is over, what about the rest of intensive care? What about other infections? People have started to forget that there are other infections in the intensive care unit. So this is a big concern. And I think the point you made is very, very important, not only in the community, but among the intensivists. There's just so much focus on COVID and so much learning around COVID that we really need to, focus on non-intensive care aspects of COVID and also other infections and sepsis. For instance, the incidence of the bacterial infections are really high in our intensive care units now. And people are only concerned about protecting themselves and, basic, measures to prevent nosocomial infections have just gone for a toss, at least in our part of the world. And this is really a big concern because we have to think about our life beyond COVID as well.
Very good. Thank you, Sheila.
Maybe some feedback from Brazil?
Yes, I agree with Sheila because in Brazil we can have, we can see already an impact in other non-COVID patients. When we look at the mortality in our platform, ICU register from AMIB, we can see that last year the standard mortality rate increased to 0.2. in non-COVID patients. And we are very worried about this. We are trying to send this message. We have to care to other patients, but it is very difficult when you have every attention focused on COVID patients.
Of course, every life are equal, and COVID and non-COVID patients should be taken together. But all the efforts have been made for COVID patients, and this is true even outside the ICU. We have many patients for cancer surgery who have been delayed for the first wave. Of course, not for the second and the third. But the notes, for example, were as twice positive as the year before, showing that delay in optimal surgical management can also sometimes be paid into life expectancy. Mervyn, maybe some comments from yourself on the team health.
Thank you, Eli. In fact, I want to actually put a positive spin on things. There's been a lot of negativity. And one of the entities I mentioned earlier, which Lenny very eloquently reiterated, was that challenges like we're facing bring opportunity. And I mentioned that what we had advocated early on was to expand facilities within facilities in resource-limited settings. The rationale for that was that beyond COVID, you actually would have an expanded infrastructure that would advance intensive care. And in my setting, what it's actually done is advance it 10 to 20 years. And many thousands of patients would benefit. what we try to do was not forget the non-COVID patients. So the very patients that you're alluding to, in between surgeries, we had this expanded capacity, and we were able to offer care that had never been offered before, which was just absolutely remarkable. And we hope that moving into the future, that will be retained. And in fact, that model will be shared not only around our country, but elsewhere in resource-limited settings. I want to come back to another entity that was mentioned, because I think, once again, a lot of positivity can be shared. And, you know, the entity relating to nurse burnout, healthcare worker burnout, was a real entity. Right at the outset, we had limited numbers and groups of individuals that had major fear, panic, and anxiety. And what we did right at the outset was spend some time that we all need to be doing, and that was to communicate with people. Communication is paramount. It's absolutely essential in all components of everyday life. And so we didn't have a debrief session. We had communication sessions every morning, every evening, so that day staff, nocturnal staff would be covered, and everyone had a voice, so it was inclusive. What that meant was that decisions that had to subsequently be made were easy to implement, and eventually we were having volunteer staff. We were also told, and I think a very important lesson by authorities, just do more with less. But the corollary of that is never to do less for more.
And Mervyn, if I can say on that, is that yes, we're all tired, but you're right. There are some positive here, because we are all gone the extra mile to increase the capacity, because we always wanted to give an ICU bed to who would benefit from an ICU bed, and that's the purpose or why we do this job. So, you know, even if it's being tiring here, I will still go back and still become an intensivist, and this is what I would like to say.
Of course, we all.
Actually, to young doctors. Maybe, Lenny, what are you going to tell to a medical student, like those medical students of the Copenhagen pandemic, but this time in 2021, about intensive care and about becoming an intensivist?
Yes, thanks, Maurizio, for that question. So I'm an optimist like Mervyn. And I do think that, so the first thing is, they may know a little bit better what an intensivist is and what an ICU nurse does than they did 2 years ago, because, you know, we're in the media more. We get to tell people about what we do and what we love. So that's great. And yeah, I just want to reiterate the point of, you know, I know this is it's been a very challenging year and a half, and we shouldn't just, you know, pretend it's all about roses. It's been really hard, and we really have to kind of walk the walk, not just talk the talk, and help the people, make sure that there's adequate support for the teams. But to new doctors, I'd say, you know, there are a lot of opportunities. ICU is really, you know, it's a fantastic job, and there are many things you can do in it. So yeah, I think I'd have a bit of a positive story there.
I agree with you. Maybe, Ali, I'm going to ask you the same question. What are you going to tell to a young doctor, to a nurse, to somebody that is thinking about going to ICU?
Well, I must say that for sure, some of people who were maybe expected to do intensive care medicine are not going to do it, but some other people will do it. Because now, as you just mentioned, I think that people know what is intensive care, even the lay public. I remember we did a study in the 2000s where we were asking the lay public in France, do you know what is intensive care? And only 1/3 of the people were aware of what is an ICU environment. And so I think that the pandemic has brought intensive care to the front line. So that's something good. So people will come knowing what there is inside. If I had something to say, is that we do medicine using supportive care for the time the disease can resolve. So this is not only a medical specialty, but we are also with a technical environment, making that everyone can find her or his interest. And I think that this is very exciting for a young physician, and this is why people come to us, and I think they will come more in the next years. I'm convinced of that.
And another good thing, I think, about this year is that we open the doors and people have seen what we do with our patients together, and how much important is the humanity and the human side of things. I think it's time to wrap up. We are crossing the finishing line of our marathon. I would like to thank all the speakers of this panel. All the speakers and everyone that made this marathon possible today, the technical teams, the ESIC office, the sponsors. I would say I learned a lot. I want to go away from this marathon thinking that we have learned a lot as a community. We are a fantastic community. And I think the vision that we had together to be a global community that wants to do exceptional clinical care for our patients and their families with research and education as leading lights, I think a day like this is a proof that we can do that together. So thank you very much.
Thank you.
Thank you, everyone. Bye-bye.
Have a good evening.
But I know that